Hello, please let us know whether the meeting has started.
Yes, Dr. Sonal, I think we have solved this and we are allowing everybody to enter the Zoom room only. And there is no webcasting on website. So all our participants will be joining directly on the Zoom room.
Okay.
Thank you. And we can start in 2 to 3 minutes.
Okay, just I'll share this.
Is
Yeah,
this only for the presenters?
yeah. Others can mute themselves, please. Dr. Abhay Kulkarni,
Okay.
mute yourself, please.
Our IT team is sending everybody the WhatsApp as well as email to the new link. We have sent the speakers group. So I think everybody is getting the link. They can join with this new link.
Okay, do one thing. Can you share it to Dr. Thomas? He has the
Yes,
laptop.
yes, I would be sharing.
Yeah, please do that.
Okay.
Hello, everybody. Sorry for the delay. And I think we'll go live in few minutes. And I'll not waste much of time doing the introduction and all. So, Dr. Thomas, Dr. Thomas will be the first speaker, then Dr. Ramesh Selvam, and then Dr. Ratin Das. We go by the same sequence.
Sonal, I think so. Once Dr. Thomas joins into a formal inauguration, at least just inaugurate.
That I will do. That I will do, doctor. Just that
Yeah.
I need him to. He doesn't have a WhatsApp. This thing there logged in his laptop. So I'll just send him
Dr.
the.
Sonal, can you WhatsApp the email ID of Dr. Davis Thomas? I would be sending the
I'll share.
alternate.
I'll share him. Share it with him immediately. Don't worry.
Yeah, please.
I'll do that.
I see Dr. Suresh Sajjan is logged in. Sir, are you there, sir?
So we have muted everybody else who are not
Okay.
the
Okay.
speakers, because what will happen otherwise, everybody will start talking or
Yeah,
asking questions.
I know.
Davis is joined.
Okay, great. Apologies for the delay. Are we live? And let me know when we are live.
Sure.
I know we are live otherwise also, but then just for the sake of YouTube, let me know in advance.
We can't see Dr. Davis.
Yeah, amongst the 33 participants, he will be the one. When he starts his camera, I'll get him in.
Can you see? I don't. Yeah, he's come. There he's come. So
Hello,
start.
everybody. Apologies for the delay, and I'm sure we are on for a big start. Delay is always a good thing. I always believe in delays. So, Dr. Nurul, let me know. Dr. Thomas,
Yes,
can you
Doctor.
just
Dr. Sonal, you can formally start the program.
yeah, can you just unmute yourself, Dr. Thomas? Dr. Ratin Das and Dr. Seema Rathi will join us in some time. Okay. Good evening, everybody. I'm Dr. Sonal Yerpude, the chairperson for this International Orofacial Pain Congress 2024. This is in collaboration with MedSkills and National Health Academy. We have always experienced that pain or orofacial pain, when we come across, it is multifaceted and multifactorial. And that gave us all this platform wherein we are collaborating with each and every aspect of dentistry, which will help us reaching a diagnosis and providing patients with a better healthcare. Here we have Dr. Thomas as our patron. Dr. Thomas needs no introduction. He is the one who introduced orofacial pain concept in India. I would say we all were dealing with orofacial pain, temporomandibular joint disorders, nerve disorders.
भैया मेरे को
Every other. Please, others, mute yourself. Okay, we were dealing with all these kind of multifactorial features in our dentist practice.
वेबसाइट पे नंबर बोलो ना, बोलो मिल जाएगा, बोलो मेरा नंबर पे
National Health
व्हाट्सएप
Academy
कीजिए
organizing team. Please
9312
mute yourself.
आप एक काम करिए, आप एक नंबर पे
The
कॉल
team, the
करें।
team
Sonal,
is
can you ask them to mute
व्हाट्सएप पे दिया नंबर
everybody?
है, बोलो
the team,
वेबसाइट
the
पे दिया
team.
नंबर है।
Mute everyone.
Yusuf, mute yourself, please. Please, everybody mute. Okay, thank you so much. Thank you so much. So I was talking about Dr. Davis Thomas. He needs no introduction. Everybody knows that he's been the pioneer in helping us know what are orofacial pain conditions. We as dentists, we have always witnessed these conditions in form of pain, odontogenic pains, or conditions which were undiagnosed. Now, this Congress, when I thought about the plan for this, or when I was charting out the speakers and every aspect regarding the same, others please mute themselves. This is the last warning. Otherwise, I'll have to mute everybody. It's very rude then. Thank you so much.
Sonal, the organizing team has to be muted, the
Yeah.
NH organizing team.
NHA organizing team, can you please mute yourself? This Congress seeks to address these challenges that we because of this multidisciplinary and multifaceted painful conditions we come across. Our 3 days of sessions will delve in latest research, explore evidence-based practices, and discuss case studies that are highlighting both successes and ongoing challenges in the field of orofacial pain. Our patron, Dr. Davis Thomas, will give us a guiding light for, or I would say a trailblazing experience, which will help you in your practice. And with that, and without wasting much of your time, I would like Dr. Davis Thomas to come ahead and share his presentation and his pearls of wisdom with us. Dr. Thomas needs no introduction. Dr. Thomas, can you switch on your camera?
Yeah, I'm switched on, Menti.
Yeah, okay. Dr. Thomas, he's very much an Indian from India, has an Indian origin. He has done his BDS from Manipal and DDS from New York University. He if I start talking about his curricular, the kind of experience he has, I think this whole conference will be taken care of with that only. So let's just start with let Dr. Thomas take the stage, and let's start with his topic that is going to be. He's going to throw a light on what are the differential diagnosis in orofacial pain conditions. So, Dr. Thomas, the stage is all yours.
Can you hear me? Thumbs up.
You're
Ramesh,
audible,
can you
Dr.
hear me?
Davis. You're audible.
Okay. All right. So good afternoon, everyone. And I apologize if the voice goes down. Just let me know. I am on a cruise ship right now, somewhere near the Grand Cayman Islands. It's not docked yet. I'm in the one of the breakfast areas we have here on the ship. It's a pretty large ship and with like 6,000 people on it. It's a massive thing, but I, I found a nice little quiet place so I can say hello to you all and to my mentee students who now I see are faculty on this beautiful course. So first of all, thank you to the organizers. Thank you to Sonal, my mentee, and thank you all the other mentees and faculty who joined. I will make my presentation a little bit small and cute, so all my students and mentees can now take over this type of massive conference thing and be just come out with flying colors. And I love seeing you all on the screen right now. Hope my screen is visible. Like I said, I'm on a ship. We are in deep ocean right now. So might be if it goes down, just show me that it's going down. Sonal, I'm still okay?
Yeah, good to go, doctor. No problem.
Okay. So we'll talk a little bit. By the way, I have to tell you, if you learn science and you make your definitive effort in it, like 100% to it, um, n- not voodoo, but actual science, literature, evidence, and science, that will help you teach everyone else whatever you know. Knowledge is one wealth. I strongly believe that does not reduce while sharing. And every slide of every presentation of mine has this Tamasoma Jyotirgamaya attached to it. And I strongly believe in it. My email is on it. If you have a specific question, you can email me. But it will take a little time for me to respond, but bear with me on that delay. Let us as dentists understand. Now here on the ship, I'm teaching not dentists, I'm teaching physicians. There is a bunch of physicians from the United States that have come to this cruise ship, spending 7 days on the ship with their families. And a couple of hours a day, I teach them about pain management and sleep medicine. If you can imagine that, a dentist teaching physicians, it's not because of I'm a higher IQ or anything like that. I'm a hardworking man. But beyond that, I set myself a path in science, evidence-based dentistry, and evidence-based medicine. That is why a bunch of specialists, registered nurses in the USA, are really highly informed. A couple of pharmacologists, ER physicians, they're sitting here listening to my presentations. And I'm the only dentist in this, either as participant or as a presenter. As a matter of fact, my co-presenter is a full professor of psychiatry in the USA. If I can do this, you can do this too. It's just nothing more than hard work and persistence and perseverance in pain, or science and sleep medicine and anything else you can get your hand onto. Let me give you a pearl to take home. And I thank the organizers for this huge program. Everyone listening to me, right? The message to me is, from me to you is clear. If I can do it, you can do it. I'm no genius. I work hard at the things I need to work. I only follow science that is available and the latest literature that is available. There's nothing else. So whether it's dentistry, general specialty, or pain, or sleep medicine, or anything else, just go to the latest in the literature and make sure you're learning from the right people. There's two concepts that please look it up. I don't know what makes these people go through this type of pain. I mean, if you look at them, and in one side we are talking about pain management, what the heck is this guy doing, right? How much pain do they have to go through? This is a religious thing going on. Do they feel this level of pain? This is India, by the way. I mean, is there pain tolerance and pain experience, pain threshold? These are the three things you need to think about when a patient. There is no cookbook. There is no cookbook for pain. There is no one textbook. Whoever the pioneers are, I'm in the process of probably making another textbook. But in the process, I can tell you there is no all-encompassing textbook ever. There's no all-encompassing mentor ever. It is not possible. It's an ocean of knowledge. Please look up pain thresholds, tolerance, and pain experience. What makes them do these things? Is it possible for this lady, without really crying out in pain, to walk on that fire? Is it possible for him to cut his own scalp? Here we are controlling the pain of injecting a patient. So if these patients are with you and complaining about, let's say, a 7 or 8 out of 10 pain, is that the same pain as I would complain? Probably not. I mean, if she has to complain about 8 out of 10 pain, that is pretty harsh pain. So I want us to understand pain is not a cookbook. There are people who are absolutely insensitive to pain, and then there are people who are relatively insensitive to pain. We are not given any education in this field in dentistry. Absolutely zero. We have looked at literature of how much dental schools teach us in India, in the US, in Europe. We're a big zero. Specific to pain, not just extraction pain with ibuprofen. So I must encourage you to read the latest and take some succinct, really good courses. By the way, can you ask them to mute, please? There are 116 people, or you can mute everyone and then I'll move on. I'll mute because it's recording and it's really non-fair to the people who want to listen to this. So please mute your microphones, everyone, or the organizers can mute everyone, then unmute
I'm
me.
on. Yeah, please mute.
Okay. And call out their names if you have to, because how many times are we going to repeat the same thing, right? All right. So red flags for dentists, right? I will not go into the details of this because as the faculty is composed of a lot of my mentee students and they are really great at doing this, I will let them divulge the entire thing and unfold the mystery in OFP on the next several sessions. So I'm not going to go to further details, but these are the red flags I would say. The patient has been grinding for 10 years, but this patient has past 3 months of pain. The untrained dentist immediately goes to saying, oh, this is your grinding, Miss Jones. It doesn't make sense, right? It doesn't make a patient 10 years to grind the heck out of his teeth and muscles to cause pain. So the inference here is it is not the grinding. Something else has changed in that patient. And it's not the bruxism that causes pain. As a matter of fact, we know that literature. We know that literature, that bruxism is not the one that's causing pain. So what else causes pain? You need to learn that. Patient feels jaw tired on chewing. What do you think is the diagnosis? Is that bruxism too? That's the first thing that comes into an untrained dentist at the lowest level of nirvana in pain management. This is what they think. You've been grinding. And then can you imagine the nonsense of us asking the patient, okay, I'm going to trim some more cusps. If the patient has any IQ, wouldn't they ask you, dentist, Dr. Thomas, this is what they're going to ask me. You told me that I've ground my teeth down to half my teeth size. So they were like 8 millimeters long before, now they're 4 millimeters. I've done it myself. over the last 10 years. You're saying you want to grind it down more? Does that make any sense to us, right? This is all old stuff, literature. Newer ones I implore you to learn. And several dentists adjusting the bite for grinding habit. Grinding is not even a habit. So that level we need to take from, and then we can go up the ladders of pain management and actual education. The patient says, I'm feeling tired, just opening the mouth for some time. What does that even mean to us? Does that mean that's a grinder too? Patient scheduled for extraction, sleeps in a chair. This is my first indication that that patient might have obstructive sleep apnea. So this type of inferences come with education. And I know that maybe Dr. Shelvam and others will diverge into this part, but it's a scope. So I'm going to go through it pretty fast. TMJ, TMD is just a small component. What does that even mean? TMJ is not even a diagnosis. Please not let us tell patients this. TMD for me is relatively a waste basket. What does that mean? Like an orthopedist cannot tell you, Dr. Thomas, you have a knee disorder. What does that even mean? This is the level of education we such have right now. But let's take it to the next level. I call it musculoskeletal pain, neuropathic pain, trigeminal neuralgia, these things. I'm sure the other faculty will cover. Neurovascular pain, migraine can come on a tooth or teeth. So migraine is neurovascular. Trigeminal autonomic cephalalgias, the big name for nothing. What is it? Trigeminal is in the trigeminal distribution. Autonomic, you can have tearing and salivation, all that good stuff. And cephalalgia, headache. Cepha means head. Not a big term, but almost 100% of this, 100% will be misdiagnosed by untrained dentists, at least in this field, as just, TMJ, TMD. Someone else has come on again. So
Dr. Rathi,
ask
please
them to
unmute
mute.
yourself.
The next one that I have for you is non-odontogenic, and someone will cover this for you. Don't worry about this. I'm just giving you a spectrum. Non-odontogenic toothaches. Couple of the most biggest blunders in dentistry is because of the lack of training in pain. Toothaches are not of tooth origin many times. Are we equipped? Do we have the wisdom, the education, and the training to understand and to rule out the tooth as the cause and not to do procedures that are irreversible unnecessarily? So many, hundreds and hundreds of cases I've seen, and it's heartbreaking. Snoring and sleep apnea, we can do so much for this patient. And that is what I'm teaching these physicians on the ship. There are pulmonologists sitting in there. And I'm teaching them what we can do as dentists to treat these sleep apnea cases. They just know it as oral appliances. And no dentist is in my audience in this entire 7 days I'm on this ship. Why do they trust you? Because I've done my diligence in learning, in teaching, and in research. You can do it too. Sleep and pain, sleep and orofacial pain. This is one of my biggest ones, is systemic factors in orofacial pain. And other factors and research. I love research. This patient, all my students have seen this, right? There's no history of trauma here. Different types of implants, different procedures. This poor thing had gotten extracted all the teeth on one side. When you see something like this, please think, is there any dental disease that can only affect one side? And it's a robust no. I don't need even literature for that. It's a robust no. It cannot happen. The same microbes are here too. What makes us dentists do this type of blunders and put these patients to? This patient has spent $52,000 already. And this is not India. This is not some third world South African countries or African countries. This is the United States. So if it happens here, it happens in India. It happens in Pakistan. It happens in other countries. It happens in the UAE. It happens in South America. This is what we put our patients through. And this is unfair, unjust, and it must stop. And it stops by us starting to learn real literature in pain management. This is myofascially induced toothache. All these teeth, deep cleaned, extracted, grafted for no reason at all. And now the patient wants me to extract this tooth, which is not happening under my watch because there are two muscles involved in this patient's case, two sets of muscles. And that is what we need to know. Okay? So just the basics. Again, somebody else has come on, ask them to mute.
Dr. Manish, please.
Masseter, and then our faculty will later on have you understand the philosophy behind this, but understand this. This muscle, masseter, can robustly refer to the molars and the premolars. And there starts the nonsense of dentistry if you're not taught. This is not the case. The same muscle, medial pterygoid and lateral pterygoid, can refer to the ear and in front of the ear. Untrained dentist, it's a TMD case. Trained dentist, you will try to delineate by trying to reproduce the pain. That is the key. In the emergency room, when you go with a big stomach ache, they're not going to just sit there and ask you 100,000 questions. They're going to poke right there on your stomach. What are they trying to find out? Is the pain local or referred from somewhere else? If pain management, and those are the people I'm teaching here, pain management, medical specialists, MDs, if I can teach them, we as a group can teach ourselves. Dentists first, this type of nonsense, right? That happens in dentistry. Look at what that patient went through. This was the muscle that transferred to a front tooth that now she wants me to extract. And the surgeon tells me, just have a look. I don't think this is the tooth. And he was right, not the tooth. So what is the referral patterns? This is myofascially induced toothaches, right, from the masseter and the anterior temporalis muscle. That is the level to which you should take this science to. And I know that it's slow process. There's a lot of unlearning to do. All my mentees know it already. Learning is easier. Unlearning, very, very difficult. Right? That is the most difficult part of our lives. And I went through it back in 2004, 2005, 2006. Now I'm talking about 20 years ago. I had to unlearn a lot of those principles and in a good scientific way. And I implore that all our education institutions do the same. Help you unlearn. I'm not going to describe all of these. I'm just going to tell you that these are the bigger ones that you will see, and the dentist probably will most likely mess up because they have no clue. They are not taught this way. The last one is psychogenic pain, which I think the more you realize and educate and train yourself, psychogenic pain will stop to exist. The only psycho in that room, when you tell the patient you're a psycho case, is you. Do you get it? The only psycho in the room, not your assistant, not your front desk manager, not your associate, not the patient, it's you. Because in the epitome of absolute ignorance, we are telling the patient, I think this is psychogenic pain. It is not. In the last 20 years, I hardly have seen one or two, now I'm remembering back, psychogenic. And that too, if you get fellowship and mastership and everything under us, and then you think it's psychogenic, don't touch that patient yet. Sit back, do a little prayer. Lord, give me the wisdom to see through this case because I think it's psychogenic, but maybe Dr. Thomas said already, I might be the only psycho in the room, not the patient. Please remember this, okay? Look at this type of nonsense treatment, right? How many cases do I get? How many have to see? How many butchering of our patients do we need to see? And I'm calling it harsh butchering because that is the truth. If this was my mother, how would I respond to you as a dentist? Think about it. If it is your mother, your daughter, your son, your father, your uncle who you like, okay? Not the uncle who you don't like. So if this is done to your uncle that you like, would you like that? How would you respond? This is absolutely not a tooth cause. This is called butchery, right? Because in this case, it was a referral pattern from another muscle which we forgot after our first year of anatomy. Chaurasia was all done. We threw the chaurasia away or sold it and burnt it. And then we said, oops, it's going to come back to us because this muscle will refer to teeth, the pain. And so to go through this type of butchery for patients is sad. It is unjust. It's unfair. So learn medicine. Look at this one. If the patient is pain here, and what is wrong with that gums? The gingiva are beautiful. There is absolutely no bite on this bus, so nobody should trim anything here, right? And the specialist tells the student it must be some subgingival calculus that causes pain, because what the mind does not know, the eyes cannot see. If you and this is from the Bhagavatam, which I follow very much. If you don't know it here, the eyes will not see. By the way, I'm a Christian, but I follow Bhagavatam. That's me. Okay, so eyes will not see what your mind does not know. Your mind only knows calculus and subgingival calculus causing pain. That's all your eyes are going to see. But there is no subgingival calculus there. I wish I had this type of gums in my mouth, right? And there's no bite on it at all. So the question is, and look at this one. This patient went through root canal, crown, root canal, crown, root canal, crown, everywhere. All we had to do is identify, reproduce the pain from a small little dot right here on the gum, which is causing entire pain on that segment. What will this patient tell the dentist or do to, or against the dentist who they know? Now, ignorance is not an excuse, but arrogance is absolutely a crime. So if you're ignorant, you cannot excuse yourself from it, because this is our, see, head and neck in the mouth. Nobody else will take it. ENTs will say, you go to the dentist. So please learn science and literature. Okay. None of this is tooth induced, by the way. So they can do procedures such as this and block that digastric, and then the pain will disappear. Both these cases are, this is also digastric case. Okay, referring to that area. Are we equipped? Are we trained? Do we even have the basic knowledge in dental schools? Even in the US, we don't. India, I'm definitely positive we do not. We do not teach this. Pressing, but we, and I have a bunch of absolutely phenomenal mentees in this course. I know they can do it. They can inspire you. They can do it. Because I'm, slowly winding down, getting tired. Been doing this for 20 years, and I have so many people coming up to take that position, the stage, and share this stage with me, like we're doing today. And I'm very proud of them. Please look up these terms. I'm not going to give you the details on this, but one thing I'll tell you, you have a golden opportunity when that patient comes to you with a toothache that looks like a toothache to you. But if you try to delineate and reproduce that pain, it is not being reproduced. Do not touch that tooth. Just because the patient pointed out to that tooth is not your diagnosis. Why so? Well, patient points to the chest, and the cardiologist says, oh, she pointed to the chest, so let me open up the heart. I mean, it makes no sense. Patient pointed out to the cusp. Okay, let me trim the cusp. No, you need a diagnosis. I'm challenging ourselves, our community, to have a diagnosis. None of this is taught in dental school. Maybe trigeminal neuralgia, maybe. Not my concern at all. My concern is this one, pre-trigeminal neuralgia. Please look up this case. This is a simple case from my archives long ago. Patient shows up with pain here. Untrained dentist starts all types of procedures. Kills this tooth, puts a composite. Can you imagine this big amalgam filling replaced by a composite? Chances of sensitivity, pulpal necrosis, more, not less. That's the first foolishness. But let's assume that was done for the right intention. What makes a dentist think this metal post can cause pain in a dead tooth? Have you ever hurt a cadaver? Then why is this any different? If this was the truth, your anatomy cadaver should feel pain. It's a dead tooth. And another smarty pants thinks, because lack of training. lack of training. We dentists are so good people. We want to do the right thing, but we don't have the guidance. And that is our problem in pain management. Okay. I'm not going to give you the diagnosis on this because that's beyond the purview. This is pre-trigeminal neuralgia. I'm going to give you the diagnosis. This is pre-trigeminal. Patient says some zing, some little sensitivity on this. Dentist starts killing all the teeth in that area. To what level have we grown? Well, 4 or 5 of them trim the teeth down first. Can you imagine if these physicians that I'm teaching here on the ship now see this case, what will they think of us? That is why physicians look at us and laugh. Let's stop that. Let's take our careers, our courses, our branch of medicine, that's dentistry, to a new level. Why don't you do that, right? Can be done. So pre-trigeminal neuralgia will show all the signs and symptoms of a toothache. Okay? And also, it will be sensitive to cold and aggravated by cold, food or beverages, confuses the hell out of the dentist. But let me tell you, that is pre-trigeminal neuralgia. If you don't have a reason to enter that tooth, do not touch the tooth. If you cannot reproduce that toothache, don't touch the tooth. And that's it. Look at this. Some of these cases are aching pre-trigeminal neuralgia. So please, let us teach our own dentists, our own societies to not do that type of damage that I showed you so far. If you look at New England Journal of Medicine, which is the highest standard in medicine in the world, All India Institute of Medical Sciences and other esteemed institutes in India see this as a textbook. And so does the entire US people, right? Look at these things, right? Eating, drinking, we know can be triggered. Shaving, we know. Applying makeup, combing hair. Who knew can cause trigeminal neuralgia? Okay, blowing the nose, swallowing, yawning, head movement, jaw movement. These are the percentages of inciting events in trigeminal neuralgia. Are we equipped to know this? And this shows up at toothaches, by the way. If you trim down teeth in this case, my friends, what level have we grown? What type of IQ are we now showing to our patients when we trim teeth down for this? Laughing, eye movement, raising the voice, tongue movement, all causing toothaches secondary to trigeminal neuralgia. These are the cases that I would heartfelt, I would say, please do not do this. Please teach ourselves, teach our colleagues, teach our students, teach our first-year students so they don't do this type of nonsense to patients. This must stop. I'm very passionate about this must stop because until something happens to you and your family and your best friends, everything is chummy, right? When it begins to happen to a family, our friends, our mother, our father, and they're treated like this, will you react in the same way? I don't think so. I sure don't. I will react in the most angry way that I can think of. So let's protect us and the dentists and the dental students and the residents and the postgraduates and the faculty. We need to change and learn medicine of dentistry. Here's a case. I will not show you the entire case, but not bore you with this. Occasional numbness, she said. You know how many dentists saw this case that it didn't even talk about this numbness? And guess what? The result was disastrous. They treated this with the plates that they're, I hear all these little different terms for the plates that we can make. Acrylic plates, upper, lower, soft, hard, soft, with clamp, without clamp, and clasp. All the nonsense that I've seen in dentistry. 20 years of it. Well, I've been in the US practicing 30 years. But what type of education should we have to understand this case? Everything else is okay in this case except numbness. That was my key. Look at the red flag. This is secondary trigeminal neuralgia. Shows up as TMD, shows up as toothaches, right? What happened to this patient? All this stuff happened to her, and everything is a red flag for me. Nobody picked it up, and the patient did not survive. Why? Because the patient had a breast cancer. We published the case, okay? Breast cancer that was ruled out as no problem, PET scan done 3-4 years ago, and she never returned. And guess what we had? A large cancer right in the petrous temporal bone, destroying the entire. You know what? How many dentists they have seen? This is not one case. This is hundreds we're seeing. No reason to touch the teeth because we are. This is the United States. Pretty positive in my last visit to India that I've seen same or even worse. And my students have seen the same. So let us educate ourselves, please. And let's make sure that we can educate and then start delineating these cases. So this type of absolute tragedy, what will this patient's family and friends and kids do to you if you did not have a clue and you were treating these cases with some plates and some trimming of cusps and stuff like that? Because that is what we have been told. And that is not science when you look at pain. And that is my message to you today. This is from a textbook. I will not even tell you what textbook it is. A textbook, and it says TMJ palpation. Do you know that this clinician has not only palpating the TMJ, is like 1 inch away. The TMJ is right at the tragus. This is not the TMJ. This is not the TMJ. So even within us, there are fools that do things like this. Is this TMJ palpation? TMJ is right at the tragus, not half an inch away, not quarter of an inch away, at the tragus. Remember, anatomic landmarks. This is from a textbook. What am I going to tell this guy or girl that you are wrong? Sorry, change your picture. This is from our own paper. Here is a 15-year-old boy, 5 dentists, okay? Specialists, 6 of them. TMJ, that's a diagnosis. What type of foolishness is this? Is TMJ a diagnosis, temporomandibular joint? Is TMD a diagnosis? This poor thing had gotten so much done until my student, Dr. Ruchika Sood, is a really fantastic clinician, right in, I think she's on the faculty panel too. She brought me the case and we dissected the case together. By the way, these are all practicing clinicians. This is Chile, my student. Ame is now faculty with me, my student. So if we can do it, you can do it too. This is absolutely nothing to do with TMDs. This is nothing to do with the face at all. It's an occipital neuralgia case. And we found that. By the way, the surgeons who did the case, they missed this completely until I saw the CT and I said, hey, what does that look like to you, dentist? It looks like a pseudocyst. It's a mucus retention cyst. What education do we have? That is my point, right? This is nothing to do with TMJ, TMD, nothing to do with the face. It is everything to do with these nerves that come out on the back of the neck. Are we trained? Are we equipped? This poor thing stopped going to school. His brother stopped going to school. And then Ruchika had the wisdom of looking at the case and saying, hey, Dr. T, can we just talk about this case a little bit? And right in her practice, we as a team, we reproduced the pain and the patient was fantastic after that. And this patient's mother is a dentist and father is a surgeon. Can you imagine if that happened to that kid? What will happen to the rest of our population? Untrained dentist is the worst thing that these patients can go to, and physicians. Okay. What do we do to these patients, man? This is my mentor slide. I mean, what are we thinking? When do we stop this nonsense? This started with 1 or 2 root canals, right? Where has it ended? And this has nothing to do with the teeth. It is shocking. I'm going slow because I'm on a ship with around 4,000 to 5,000 passengers. And this is the breakfast area. There are physicians walking in who are my course students. So if I'm looking at one side and saying hello, just bear with me. But I don't want them to hear what I'm saying right now. Listen, we need to teach ourselves first, okay? And for my mentees that are on this forum, please give them these cases, okay? Whoever can listen and take a succinct course to do the same. All this stuff, and biggest one in here, look at this, wisdom teeth causing pain. I asked a bunch of clinicians, where the hell is this written? completely impacted wisdom teeth causing pain. Where is it written? What is the mechanism? My challenge to the newbies on the screen right now is show me the literature that says completely impacted wisdom teeth, not into the mouth. There's no pericoronitis or periodontitis. Completely impacted wisdom teeth. Let them sit there on the back of the jaw. Can cause pain. Where is it written? Give me one mechanism of pain. There is nothing, zero. We're doing a full review for Journal of American Association. Full review. Where is it written? Wisdom teeth causing anterior tooth crowding. What type of physics nonsense is that? This is why orofacial pain is a specialty. This is why it's a specialty. I will not give you the details on this because my amazing co-faculty will give you all of this stuff. Occlusion causing TMDs. Now, I know Dr. Ramesh is somewhere there on the audience. I see oh, there you are. He is a guru of I love occlusion. Dental occlusion, the principles are written in the last 100 years, because there was people who looked at it 100 years ago, is gold. It's platinum. But when that is misused to say, if you don't correct that, that will cause TMD, that is the problem. And if you have a TMD, I can correct it by doing occlusal correction. That becomes a problem. Then I ask for evidence. And I'm doing a filling, I'm doing a restoration, a single crown, a post and core, a full mouth rehab. I've been doing that for a long time, 25 years in the US. I want to follow every principles in occlusion. I'm good at it too. When you talk about the curve of Spee, or curve of Munson, or curve of Wilson, I love it. When you talk about a reverse curve, when you talk about eccentricities, prematurities of contacts, I love it. Because you are creating something artificial for the patient. You have to follow principles of occlusion because they're based on what? Physics. And I love physics. But the moment you say, oh, it's a class 2 occlusion, therefore there'll be TMDs, you are wrong. That is not supported by literature. That is not science. That is not even voodoo. It's crazy. Okay. So that level of teaching and understanding that these faculty will do for you. Another problem with dentistry, scanners. I call them scammers. Okay. What is the best scanner you need to have? It's between the 2 ears, a couple of inches inside and a couple of inches above. Where did you land? In the brain. If my brain cannot scan the patient, no scanner can. Believe me when I say it, especially in pain management. Okay. The laboratory, the dental labs you send a case to, if you send a messed up impression, the lab is going to send you a messed up crown that will not fit even your toenail. So the problem is, don't blame the lab. So don't blame anything else. The scanner inside here has to start working. Then let's look at the evidence and the science and the literature behind other scanners or scammers. Fair? That's all I'm going to say about that. Role of occlusion, it's debunked. As much as I've seen in 30 years of literature. Debunked, okay? Debunked. As a matter of fact, America was so proud. 32 teeth should be intact, we said. 60 years ago. 32 teeth. All tap, everything should be perfect. 20 years ago, Europe said, we don't need the second molars. We need first molar to first molar. And then everybody was like, what? No wisdom teeth? No. No second molars? No. First molars. Guess what they did now? Molar to premolar is okay too. So this is their full mouth rehab concept. What are we going to do? Call the entire Europe fools? No. No. They have done their research. As a matter of fact, a lot of dental research did not come from the US. It comes from the Scandinavian countries. That's fantastic. And they said premolar to premolar are absolutely fine. Think about it, right? How much is the primary etiological factor based on occlusion? This big, 0. Learn new things. You will start by unlearning some things. I'm sorry, but learn medicine first, then dentistry, right? You have to be a good medical mind to become a good dentist. You have to become a good dentist to become a good orofacial pain specialist. You cannot be failing all the courses in all through the 4 years, and you walked around drunk in your internship, and now you say, I want to become an orofacial pain specialist. Not happening. Go back to your first year, start learning it again, come slowly forward, learn dentistry, learn the entire occlusion first, completely, nice and clean. Learn to become a good dentist, then let's become a good orofacial pain specialist. Because MBBS people know that they cannot become a cardiologist in 1 year, right? Orthodontist knows that they cannot be doing orthodontics after the first year when they bend some wrought wire rusted iron clamps into a U. That's not orthodontics. So then why is this any different? Takes time, perseverance, persistence, and solid hard work. Okay. I'm not going to do much of this, but I will tell you, these are the sources that we know of that can cause non-odontogenic problems. And we must know others. Psychogenic is going to go out of my thing. Post-implant nerve pain, all this amazing stuff you must study. You must know. What are you going to do if you did an implant and that nerve or the patient says is numb or post-implant pain? Are you equipped? And that is not putting the patient on ibuprofen, by the way. That's the lowest level of nirvana. Lowest level in orofacial pain, way down. But way up is, can we reverse it? How fast should I act? What is my diagnosis? That's my challenge for you. I will not read this to you. I promise I will not bore you with that. I'm just going to click through these slides. These are published by, really nice, good researchers. Please look at post-implant pain. How can you recognize it? How can you treat it? And how can you stay away from trouble? This is post-implant pain. This is mapping of the nerve. Please learn medicine in dentistry. That's my message to you today. We looked at a long process of all these. Look at this one from Dr. Rangarajan Vedantam. He's an amazing clinician in India. He's been probably the best prosthetist I've known, other than Shankar Iyer. They are like colleagues and my colleagues. He's my student in orofacial pain. He published his textbook. He brought me this case, right? He said, Dr. T, have a look at this. This poor thing has been suffering from 1990. Look at the dental work done on this. What is the cause of this? Patient said pain, right? The poor thing starts from 1992 to 1993. This is Ranga's case, Dr. Rangarajan Vedantam's case. And he brought this case and said, Doctor, what the heck is this? I think I know it. And he's so smart. He was right on the track, right? Look at the amount of work done on this poor little thing. I cannot imagine what this patient went through. And all we had to do, Dr. Rangarajan, myself, and the patient, was we as a team, we tried and we reproduced the pain from two areas. Look at the amount of work done on this poor thing. Look at this. What if this happens to your mother? And it's not one case. He's probably seen 100 by now, or maybe more. And so has all my mentees. And this was based on trimming teeth down and taking teeth out. Stop doing this, right? Let's educate ourselves, please. And all we had to do, and Ranga is amazing because I asked him, can we do a little bit of stent like that? Okay, he did that. Put some medicine right in there, put some medicine right in here, and the patient is 100% pain-free. So then the patient might ask you, look at the reverse curve. I love this thing, reverse curve, huh? Ramesh, are you listening? I love this. Reverse curve. Okay. So the thing is that to be corrected? Yeah, that is the physics thing. But I'm not talking about physics here. I'm talking about why should this patient go through this hell if the first dentist in 1992 to 93 to 94 and 4 specialists at that time in Chennai saw this case, right? Why should this patient be butchered like this? Because of the lack of knowledge, and the lack of education, lack of training. I'm not going to bore you much. I know there are so many people that this fantastic team have set up together. I have a lot of cases to show you. but I am also on a ship, and the breakfast here is going to start in 15 minutes. Then you will see people walking around with all types of food. I don't want to drool everybody sitting and watching this. There are so many cases I can show you. But let me tell you one more thing, okay? Bruxism. It's the biggest circus in dentistry. All right, let me just go through that. We just published the paper in JADA, Journal of American Association. This is what we know about bruxism. You see them? That's it. Okay. The blind leading the blind. All right. Why? Because Ramford in 1961 wrote this in what? Journal of American Dental Association. The same Journal of American Association that 2 months ago, with my absolute amazing people, we published sleep medicine and bruxism, 2 different papers, complete review. From when Ramford started that, any type of occlusal interference can cause bruxism. Wrong. This has been disproved like 100 times. Bruxism may be eliminated by occlusal adjustments. Wrong. Occlusion has to be adjusted to centric relation in order to achieve muscle balance. Wrong. Why? Because the definition of centric relation changed by the glossary of prosthodontic terms. I'm not saying this. The GPT 1986 changed the very definition of centric relation, which Ramford thought that was the right one, from the most posterior superior position of the condyle, 1986-87, GPT, changed it to the most anterior superior position of the condyle. So what happened to those patients? We did all these adjustments in the back on the most retrognathic. We made them, didn't we? Centric relation we recorded. Ask Shankar Iyer how reliable centric relation is. So, or ask Dr. Angrajan Vedanta, what are the changes that has happened in the last 64 years? We're going to be in 2025 soon, right? That is 64 years. If you still believe and do the same thing Ramford said at that time, such as in this article, whether it is from some people from India, I think, where have we grown in dentistry and in medicine? I implore you to study dentistry and medicine. I'm going to stop there. I love what you guys are doing right now. I'll show you a couple of last slides and then I'll stop. We published this. If you want to look at literature, okay, this is my edition 1. This is Dental Clinics of North America, not any book. Yes. And this one was the first one, as you can see here on this side. This is the TMDs, nothing else in here. Everything to do only with TMDs, right? And the second one connected to that is the systemic factors affecting your dentistry. Please get at least a PDF copy or whatever you can get to, read it, learn it. This is not just me, I'm the editor for this. And the third edition, we have started on it already. There are 46 co-authors. Amongst my mentee students are also there. We're going to publish certain things that will really be eye-openers. And JADA also now approved my special edition already. We're going to see some more special editions coming out. I'm the sole editor for this, not because of my merit, but my students and my mentors have made it happen through me. That's all. I'm just a medium. I don't take credit for any of these. And the last but not the least, 2/3 of your faculty here have gone through this. This is our course. This is the most succinct course, I should say, in the world that you can get. Okay. I have not seen a course similar to it. Not because I'm one of the faculty, I'm the course and the program director, but this is from Smile USA, and almost 2/3 of our faculty in this entire 3 days you'll see have gone through some form or shape of this. There's a fellowship level, and then there is a mastership level. And I hope to see Dr. Sonal, Dr. Ramesh, and all of them who finished 150 hours. In the next 150 hours, we're going to start in June 2025. And we'll make them prepared for this. That's going to be 300 hours, not 3 hours, not 30 minutes like I just did, not 3 in the 330 hours, it's going to be 300 hours, not on all dentistry, specific and solely to pain management in dentistry. And with that, I thank all of you for listening. You've been an absolute amazing audience. Let me tell you this, real knowledge will only make me humble. It will not make me go with my thumb like that and say, I've been practicing for 25 years. Listen, for all of you listening there, for all of the mentors and mentees, you practiced something wrong for 20 years. Can you call that experience? Thought process for today. Okay, you practice wrong. I practiced wrong from 1993 when I was licensed in New York to 2004. I thought trimming teeth will clear TMDs. Can I call it experience of those 10 years? I don't think so, because my eyes opened, the third eye, knowledge eye, and the Sudarshanam, good vision. Bible says the same thing too, right? Jesus also said the same thing Krishna said. You take the block of wood from your eye first, so you can see the small splinter of wood in your friend's eye. Do you get it? This is blocked already. Why would we judge somebody else? Right? Why would we teach someone else? Take that splinter of the other person's eye, you have to take the block. I removed my block back in 2001. That is almost 25 years ago, quarter of a century. I hope you see it in your heart, and God bless you to do the right thing and learn it the most succinct way. But the mind does not know, folks. Your eyes cannot see. And from me, ignorance is not an excuse. When you butchered that tooth, you butchered it. Did you know it? No, but that's not an excuse. You learn from your mistakes. Yesterday, I showed 2 cases that made me sweat to the physicians. They did not even diagnose half of that. So I told them, I can teach you as a dentist. You can learn as physicians, and vice versa. I can learn from a lab guy. Again, Bhagavatam, I quote, because it talks about gurus, 18 gurus. An ant can be a guru. A spider can be a guru. Spider teaches you how not to get caught up in the web that the spider creates. Spider doesn't caught up in it. The rest of the insects get caught in it. What a beauty. I can translate that into medicine and science, then my life this time is successful. I thank you all. If there's any immediate questions, I'll take it. Ramesh, thank you for waiting patiently for me to finish this. You guys have been fantastic, and the organizers, Ratin, all the other folks I just talked about. Sonal, you are a class of your own. All right, you're a class, because you really makes it possible for people to come together at this level. And again, I must apologize. You can hear the noise in the background.
Yes.
Breakfast has started. This is a humongous ship. I'm just going to share screen for a quick moment, if I may. 1 second, and then I promise to stop. Okay. I just want to share it for a quick moment. I don't know if you're seeing the screen, where that's Krishna and
Yes, we can see it.
baby Krishna. This is the ship I'm on right now. Okay. If I can do it, you can do it. I'm not teaching dentists here. Okay. If you look at physicians and you scroll down, this is the biggest C providers in the USA. And if you look at that, continuing medical education courses, this is made possible because I only based it on medicine, literature, science, and evidence. And it's taking some time because it's busy. I'm sorry to hold you, but what I'm telling you is this: if I can teach all these folks, you see this. Oh,
Sir, any
the
question?
course itself is now out because I was finishing by December 9th. Okay, if I can do it, you can do it. That's my main message to you. Thank you. And I see folks walking around me. I'm going to stop sharing.
Questions, sir?
Yeah, Dr. Abhay Kulkarni,
Some
can you
questions?
yeah, Dr. Abhay Kulkarni, do you have a question?
Yes, sir.
Yeah, please go ahead.
Yeah. Sir, good evening, sir. I just wanted to ask, you shared about pre-trigeminal
Yes.
neuralgia. Is it advisable to start
Yes, sir.
carbamazepine if we at all diagnose it?
Is it
Hello,
advisable? I'm
over from
sorry,
my
I'm on the
side.
ship, so go ahead.
Sir, is it
Is it
advisable
advisable
to
to do what?
start carbamazepine treatment in such cases if at all we diagnose it correctly, pre-trigeminal neuralgia?
Oh, excellent question. So if you have ruled out all dental and you're
Uh,
convinced that this is pre-trigem, the
uh,
first thing, and that is what we teach in the course, okay? Not start a medication, but we're going to do our diligence to make sure there's nothing wrong inside the brain, by the way, right? Because
yeah.
trigeminal neuralgia and pre-trigeminal neuralgia can be secondary to tumors, cysts, demyelinating conditions. A lot of stuff can happen inside the brain. So you need to know how to prescribe an MRI. If you know
Okay.
that, then while you're waiting for the MRI stuff to go through, you can start, but not in spite of it, not without it, right? Because if there's a 25-year-old with this condition, you know that you're looking at a probably case of multiple sclerosis. So there's a
Okay.
lot of branches of this surrounding it. But if you ask me the question in a different way, Dr. T, I did the MRI, it's negative, it's not MS, there's no Lyme disease or anything like
Uh,
that. It's pure pre-trigeminal neuralgia. Then, and you're an MRI with and without contrast that I can look at and I can say, yes, you're right. Now we can do, and exactly the question is that the same treatment? Absolutely, yes. You put the patient
oh,
on an anti-seizure medication, which is either carbamazepine, oxcarbazepine, lamotrigine. We have a lot of things in that. L- Learn it from that 150 hours. I'll teach you everything.
okay.
Thank you for the question. Fantastic question too.
Yeah, Dr.
Amazing.
Thank you.
Thanks for the
Yeah,
question.
you're welcome.
Yeah, so everybody who attended this lecture and everybody who knows Dr. T, one thing you will know after attending his session is what not to do. You'll be scared to touch a case which has some amount of doubt in your mind. You will be scared to touch this case again. So Dr. T, it's always a pleasure to listen to you. And if
Thank you.
time permitted, I would have literally wanted you to keep on continuing with the lecture because I wanted to know more. So, and every time you keep on adding slides, and it's
Thank
always
you.
like the knowledge keeps increasing tenfolds. Dr. T, I would request you to continue or
Thank you.
stay online with us for the paper presentations also.
Sure.
We have fantastic students who have literally made efforts, and I can see the way they were trying to connect to the dots also. And now we have, yeah, Dr. Abhay, thank you. Thank you so much. You can unmute yourself, Dr. Abhay. Yeah, and now we have another fantastic speaker with us, Dr. Ramesh Selvam. He is known as the man who is rediscovering occlusion. Dr. Ramesh, can you come on screen now? Dr. Kulkarni, can you just switch off your mic?
Yes, Dr. Sonal, I'm here. Can I share my
Yes.
screen?
No, just a second. Let me introduce you. Let me do the honors, Doctor.
It's
Okay.
okay.
Dr. Ramesh Selvam, the man behind the occlusion-driven dentistry, graduated with gold medal in conservative dentistry and endodontics from Meenakshi Amal Dental College in 2001. He is a dedicated clinician and founder of Dr. Nisam Family Dental Care, treated over lakhs of patients, and I would say mentored more than lakhs of students also by now. And he is a specialist in TMD management, and he's also completed his fellowship recently. Congratulations on that, doctor. And he is a faculty with Dr. Vasant in Dr. Vasant Dental Academy. He is actually a co-founder there, and it would be a pleasure to know his insights on scope of orofacial pain in a regular dental practice. So, Dr. Selvam, can you share your screen, please?
Yeah, I'm doing it, Sonal. You're able to see my screen, Dr. Sonal?
Yes, it is, but I think the mode is little enlarged view
Okay.
because the Bible B is cut. So maybe you can just reduce the size of, yeah. So I don't
Okay.
want anything to be missed.
Can you see here? Can you see this slide? This slide is okay?
This slide also, I can see only 3 present, the organizing committee. I think what has happened is your aspect ratio is wrong here. So
Yeah,
maybe,
let me check it. Let me
yeah.
check. Yeah. Is it okay now?
Yeah,
Yes, so
go ahead, doctor. Go ahead, because others are saying it is perfect on their screen. Let's see for 2, 3.
Sir, it's absolutely okay, sir.
Okay,
Okay.
great. Go
Good.
ahead, sir.
Good.
Okay.
Okay, thank you, Dr. Sonal, for this wonderful introduction. I'm so happy and honored to be a part of this great symposium. What you're conducting, your hard work is seen seen in front of my eyes. Okay, so I don't want to take a lot of time because 30 minutes, like that too, presenting in front of my mentor, Dr. T, is something very special to me. Okay, let me start my presentation. As the presentation comes, I'll tell about my journey, because I'm straight opposite of what I was learning. Okay, that is the beauty of this beautiful journey. I'll tell you, right? I always believe fear of Lord is the beginning of wisdom, and that is where it started. My entire learning journey, I owe to my Lord for what He has done to me till today, right? Let me move on. Thanking the IOPCON committee for the honor. Thank you, especially Dr. Sonal, for the invite. You made it happen, and thank you for that, right? Let me move on to I need to thank my occlusion mentor. So by this time, everybody would know that how the role of occlusion in TMD, everybody knows the answer, right? But I need to thank this man because when he taught me TMD, he is the only mentor in his slide. When he was talking about management of TMD, his first slide is not about occlusion. His first slide is not about anything. He first wanted me to just see the systemic factors that is going to affect the particular patient, which can be a precipitating factor in TMD. That is his first line. That stuck me very hard in my entire occlusion journey. I'm a big fan of occlusion. I love, I eat, I breathe occlusion, right? So from there, he taught me the depth of occlusion-driven dentistry. I'm thanking my mentor. Because of this occlusion journey, I am into this OFP journey, right? Thanking my guru, Dr. Vasan Sivaraman sir, because he started the passion, he ignited the passion. Occlusion started me to land up in OFP. Okay, I'll tell you how it happened, right? And of course, I need to thank my great mentor, OFP mentor, Dr. Davis Thomas. In my entire fellowship, I think I have never spoken a single word in my entire classes, not even doubts. Okay, I think he's going to hear me for the first time what I'm going to speak. Okay, thank you, sir. Thank you. You have taught me what case I should not touch. That is the biggest learning from you, sir. The biggest learning what I got from my mentor is we need more knowledge for not touching a case rather than touching and treating a case. Okay, thanking them. Okay, so let's move on to our main topic, orofacial pain specialist. I feel we are the real stomatognatic physician. Okay, there are a lot of specialties around there in medical professional where different people have different specialty. But I feel this particular specialty, dentists are the best people to take up that specialty. That is what I feel after entering into this OFP journey. What is the real scope? Okay, Dr. T has clearly explained the overall scope of OFP, what OFP can do, what when you get trained as an orofacial pain specialist, is what you can do to the people, what you can do to your patient has been clearly explained by Dr. T. I'm not going into that. So what I'm trying to say is, what is the scope for a dentist? Why should a dentist take up this journey? That is how I've designed this presentation for you people, right? Okay. There's a famous quote which says, pain is pain. It needs no description. Pain is pain. You don't need a description. It's pain, right? That is what, it's a very famous quote which says these words. Let's see, is it correct or wrong, right? Okay, what do you mean by pain? Since it's an orofacial pain online symposium, I'll add a little bit of what is pain, what do you mean by orofacial pain, and then I'll take you into the journey of scope of orofacial pain by a dentist, for a dentist. Okay, so what do you mean by pain? By IASP definition, this is what is called pain. Okay, everybody knows pain, right? It's an unpleasant sensory and an emotional experience associated with actual or potential tissue damage or resembling that. This is the definition of pain. When I say pain, pain is not easy to perceive from patient angle. Pain can arise from anything and everything, and we need to be descriptive when we talk about pain. So this is the definition of pain. Okay, Okay, classification of pain. How the pain can be classified? It can be classified basic depending upon it can be physiologic, it can be anatomic, it can be functional. Okay, let me take you into it. What do you mean by the physiologic? Why am I saying all this? When I say all this, I'm going to take you into how a dentist can be the best orofacial pain specialist, because you're going to land up there. You will be the first person to see such patients. You will land up in a situation where you will be the first one to diagnose some great problem like what Dr. T has showed in the previous lecture. So what is this physiologic classification of pain? Nociceptive pain, it can be inflammatory pain or nociplastic pain. When it matches the stimulus, we call it as a nociceptive pain. Nociceptive pain. Inflammatory pain, when there is a tissue damage, for example, heat or cold or infection causing or an infection causing, that is an inflammatory pain. Then comes the nociplastic, altered nociception. For example, fibromyalgia, irritable bowel syndrome. All these are classification of pain. I told you what is pain, what is the physiologic classification of pain, nociceptive, inflammatory. All these basics I have learned over a period of time now. Nothing was taught to me in the college about pain. About pain management, all I know is take an LA shot. That's it. Okay. If a patient reports with severe pain, open the root canal. Forget about whether the teeth has DZ or not, nothing. If the pain is continuously coming for the patient, all we know is just give an LA and access opening and do the root canal and finish it. And what after root canal if the patient comes back again with the pain after doing the root canal? The next root canal or the upper anterior tooth. So we need to understand the basic classification of pain, right? Okay, and depending upon the anatomic location of where the pain is starting, it can be called as a somatic pain or a visceral. What do you mean by a somatic pain? Somatic pain is nothing classified into superficial and deep. Deep is musculoskeletal and superficial is cutaneous and mucosal. It is easy for the individual to precisely locate. These somatic pains are easy for the patient to locate. But when it comes to visceral pain, it arises from the internal organs. For example, a cardiac pain. They can show somewhere near the chest. It may be cardiac pain. It can be from any other visceral organ also, any other internal organs also. This pain is diffuse and difficult to localize. As a dentist, this basics of pain has to be learned. What is this nociceptive pain? What is this? What do you mean by an inflammatory pain? What do you mean by a nociplastic pain? How a somatic pain will be? How a visceral pain will be? Because we are going to land up with a situation where the patients are walking in front of you. They'll sit in front of you and they'll be saying pain in the teeth. End of the day, or a dentist, they'll say pain in the teeth. And we should be able to delineate and differentiate whether the pain is really from the tooth or not. For that, we need to understand some basics of pain, right? When it comes to functional, when do you call it an acute pain? Pain of less than 3 to 6 months is what textbook and the literature says. When it comes to the chronic pain, which is persisting beyond 3 to 6 months, is called as a chronic pain. And here comes a situation where this neuropathic pain cannot be classified it cannot be categorized into any one classification here, because it comes under the both physiologic as well as the anatomic classification, because it's because of a nerve. It's pain caused by a lesion or a disease of the somatosensory nervous system. Why am I putting all this in front of a dentist? There are some egg budding dentists who are sitting here who have started that dental career, okay, dentistry career, waiting for something new, right? So you wanted to, there is enough to learn already in dentistry. Why OFP? Why OFP? What is the scope of OFP in dentistry? That is where I'm going to take you now. So what do you mean by orofacial pain? We are talking about OFP. What do you mean by orofacial pain? Orofacial pain is nothing but it is a pain disorder of a jaw, mouth, face, head, and neck. It refers to pain disorders of the jaw. When I say jaw, what jaw are we interested of maxilla and the mandible, right? Then comes the mouth. Mouth seems to be a simple word, but the mouth has a lot of things inside, which we need to look into. Face and the head and the neck. This anatomical region, it's a wide, diverse structures and tissues that are attached in this entire area. That is what we call it as orofacial pain. Why dentists are there inside this orofacial pain arena? Why are we here? Because it ranges from dental pulp to the meninges of brain is orofacial pain. Anywhere the pain can arise. And the beauty here is, as a dentist, you are the first person to see the pain in these areas. Naturally, when something related to mouth comes, naturally people come for a dentist. It's not for teeth alone. They think it is because of teeth. They think it is because of gums. They think it is because of something around the mouth. It is our responsibility, moral responsibility, to get into this diagnosis. Diagnosis is something very, very crucial in orofacial pain. This entire area, it covers from the dental pulp to the meninges of brain, which is huge. One life is not enough to master this OFP is what I feel after this 1 year of fellowship. Okay, this is what is called orofacial pain. Let's give an example of orofacial pain. For example, this classification, you cannot put it like this is physiologic, this is anatomic, this is like functional classification. Because take an example, our department, right? A carious tooth, patient has a momentary pain, and it is elicited by taking some cold drinks or juice. It is elicited by the cold beverage, and it is, we all know, it is reversible pulpitis. Up to this is dentist. After this, as a OFP specialist, it's a beautiful combination, being a dentist and an OFP specialist. You will understand this because I'm living a life, I'm doing a practice combining both. So what pain is this that is happening in a carious tooth? A nociceptive pain, it can be called as a nociceptive pain, right? And from a physiologic perspective, it can be a visceral pain from anatomic perspective. Deep inside the pulp is creating that pain. An acute pain, of course, any dental pain, most of the times it's very acute from functional perspective. What classification can we give for this? This is example number 1. The most common thing, TMJ pain, several month duration, and it is stimulated by chewing. If they have a problem in chewing, where will they come? If they have a problem in swallowing, where will they come? If they have a problem during opening and closing mouth, where will they land up? It is you, it is we, the dentist. We are here to answer them. It lasts for several hours after cessation of stimulus. This is the situation. What pain can we categorize this? It can be inflammatory pain, anything related to, for example, a capsulitis, the articular capsule getting inflamed, and inflammatory pain from physiologic perspective. It can be a deep and a somatic pain from the anatomic perspective. It can be from the retrodiscal tissue. It's called the bilaminar zone now. It can be a chronic pain, functional several hours after cessation of stimulus, and it is for several months. I said 3 to 6 months. More than that, it is chronic. It can be a chronic pain. Why am I putting all this here is when you say pain, when the patient walks into your clinic, when the patient is sitting in front of you saying orofacial, saying pain in the orofacial region, stop, think, and decide what is causing this pain. What is aggravating this pain? Are we able to reproduce this pain? Are we able to exactly locate where the pain arises? That is how an orofacial pain specialist will think. So in orofacial pain specialty, we cannot say pain is pain. It needs no description. No, that quote I'll not accept for in orofacial pain. So pain needs an explanation here. Pain needs a description here. Where is it arising? How is it arising? How is it elicited by the patient? Because we need the description of pain. Because unless we know the description of pain, we cannot delineate what is causing the pain. Proper diagnosis, we need to know the description of pain. Is it aggravating by doing something? Is it waking you up from sleep? Is it aggravated by function? So many things are involved. So in orofacial pain specialty, we cannot just take it for granted. Pain is pain. We'll give one paracetamol, one ibuprofen, one injection, one pulling out the tooth. No, we have to stop. That needs a prescription. My mentor, Dr. T, always says, rewind the clock. Rewind the clock to the point where it started. Okay, sometimes my consultation goes beyond 2 hours or 3 hours after this OFE journey because I have to rewind the clock. When I rewind the clock, I'm stunned and so bad to see so many things with so many CTs, MRIs, so many medical reports. Still, the patient comes with the same pain. We just solve that with some little bit of knowledge what God has given and the mentors like Dr. T has given. We just solve it by diagnosing the problem. As a dentist, you may not be able to do the entire perspective of a pain management, but you can collaborate with the physician. You can collaborate with the team to solve this problem. So 3 major questions. Dentist here, there are young people here, there are some senior people here. Please, these are the 3 major questions that should hit your brain as a orofacial pain specialist. When you face a patient with a pain complaint, you need to ask 3 questions. Where is the pain? That will give you an idea of the location or the structure or the system that is involved behind this pain. Then what is the process? What is the pathologic process behind this pain? What is creating this pain? Where is the pain? Important. What is creating this pain is important. And why? Why did it start in that particular system? Why did that pain start in that particular structure? What is the reason behind it? So these 3 questions will answer everything for you. Even don't ever think I wanted to become an MBBS doctor. Okay. So many people who are sitting here, maybe some people would have directly preferred dentistry. I wanted to become a doctor for my mother. That was a dream. Okay, end of the day, I didn't get. Many of you would have missed the MBBS seat by 0.5 marks. That is what I missed, my MBBS seat, and I was into dentistry. I'm thanking God for that. Okay, now I feel like a doctor, the real doctor. Dentistry, of course, it gives a lot of satisfaction, but the real doctor in you comes out when you become a orofacial pain specialist, because we need to get back to the general medicine book. We need to get back to the pathology book. We need to get back to the pharmacology book. Most importantly, what we read to just pass, right? That is where the real medicine starts. Clear? Okay. Everybody is will be thinking, oh my God, I'm a dentist. Why should I learn about OFP? What is it going to do to me? I can hear your mind voice now. Already too many things to learn and master in dentistry. Root canal, post and core, implant dentistry, smile designing, veneer, this, that, full mouth rehabilitation. So many diverse things are there for us to learn as a dentist. And why should I take up this OFP journey so seriously? Because I'll not categorize this as a money-making big treatment that can be done, but this will be the best thing you can do to a patient. This will be the best thing that you can give to a patient. The real doctor, right? Sometimes a life-saving things can be done by a dentist. Take it from me. So if you ask why me for OFP, the answer here is very clear. I give the same statement even to my mentees who is practicing occlusion-driven dentistry. Okay, I'm coming to that. You are the chosen one. Otherwise, why are you sitting here when people are going and practicing doing something? You are sitting here for a reason. I believe you are sitting here for a reason, and God has put you in this particular symposium for a reason. You are a chosen one by God, maybe because dentists are an integral part of OFP management, since we face the pain in and around mouth, face, and neck. Correct? Naturally, they come to you. Naturally, they come with the pain. They say something about pain. What do? When we know something, we diagnose. When it comes to teeth, we do something. Always think about it. Always think about it. Because dentists are an integral part of OFP management, since we face the pain in and around mouth, face, and neck. Okay. Always, there are two important responsibilities when, okay. Now the dentist wanted to enter the OFP practice. My thought process would be the responsibility of a dentist in a OFP practice are twofold. One is you will be the diagnostician. The biggest asset, the biggest gift after starting this OFP journey is my diagnostic level has scaled up like anything. Why am I saying this? I do good dentistry. I love doing dentistry, and I'm a big fan of cusp, fossa, everything, I love every part of tooth, and I design the entire occlusion. I love, but end of the day, if it is not teeth, what is it? I should be answerable. Patient saying pain in the tooth, and I'm answerable. Teeth is not the reason I know. Then I have to give another choice for the patient. The biggest responsibility is, first you have to be a diagnostician. Sometimes you may be the first and the best one to diagnose a problem. Many cases, even rheumatoid arthritis, some patient, they come, right? They'll be in the remission period. Sometimes they come at that age. Now we have a knowledge at this age it will come, next this age, in between there is the remission. Depending upon that, it makes me think, okay, let me put this case into an orthopedician or a rheumatologist for diagnose for any rheumatoid arthritis. There is possibility in this case. You may be the starting point, take it from me. You may be the starting point to find a malignant tumor happening in the brain, what Dr. T showed in the last webinar. Think about it. Sometimes you may be the therapist. You may be the starting point to start. Okay, this is what is happening. So the responsibility of a dentist in OFP practice is huge. You will become a great diagnostician. Sometimes you become the primary therapist, or you may be a secondary therapist, but the exact referral has to happen. That is the responsibility of a dentist. Please understand. Okay, let's come to the topic. In 10 minutes, I think I have to finish the scope of OFP in dentistry. Dentists are the true physician of stomatognathing system. Where will these people go if they have pain during opening, closing? If they have a good teeth, that still they have pain, still they have sensitivity, they don't know the reason. Where will they go? It is you, because you people are the chosen ones sitting here. Okay, let me move on. What is the scope? I'm just going to give this 7 points. Why dentistry can take up this OFP seriously. Okay, the biggest asset of this OFP practice is it's a beautiful combination. It's a beautiful combination, because this is something not many people are venturing into it. Many people are venturing into different parts of dentistry. this, that, it's okay. But not many will like or enter into this OFP journey because it involves medicine. We have become so mechanical about the process of dentistry, we forgot the medicine. Okay, we forgot the medicine. So what is the scope of OFP in dentistry? We deal with a unique joint in human body. Forget about all those big stuff of orofacial pain. I'm not going to go into it. We are dealing with a unique joint, right? When the patient walks in, they have a range of motion. What you are checking, we're asking the patient. Let's take an example of a patient who is ever difficulty in mouth opening. Maybe difficulty in mouth opening, and they are saying that my jaw is getting locked, my jaw, I'm not able to open beyond this, I'm not able to achieve, I'm getting tired. So we are dealing with a very unique joint in the human body called temporomandibular joint. Okay, if there is any pain that is mimicking the pain near the TMJ region, immediately your mind has to think about a lot of things. It can be a real pain caused from the TMJ area. It can be other pains that are referred to the TMJ area. You need to be clear about all those stuff. We are dealing with primary and secondary muscles of mastication, right? Medial pterygoid, lateral pterygoid, masseter, temporalis, anterior belly of digastric, sternocleidomastoid, splenius capitis, trapezius. All these muscles are integral part of dentistry. You need to understand. We will be the best person to find out the myofascial part of OFP. And of course, teeth and supporting structures. I don't have to tell you anything. We are all good at it. Then comes, sometimes you just inquire. So what is your problem? What is the systemic factors about heredity, about their parents? You get to know a lot of things. We deal with some systemic factors, some drugs that is related to OFP also. When we don't have the knowledge of a drug which is causing a myalgia like pain or myofascial pain, you need to understand even the adjustment of dosage also can have an impact on the muscles. Sometimes you will be the first person to find out this patient has a obstructive sleep apnea, sleep disorders. But just seeing the tongue and see the position of the uvula in relation to the posterior part of tongue, your Malambati score, you will be the first person to diagnose that. Think about it. So what we get out of it, OFP will bring you the true doctor in you. It will make you stand out of the crowd. Let me explain that. Okay. When it comes to temporomandibular joint, it's a huge spectrum. How to treat TMD? If somebody asks me, even in my curriculum when they come, I say it's not impossible to treat, impossible to teach everything. It's a huge spectrum. It is because of search of knowledge I entered from occlusion driven dentistry. From there I went to another concept, then another concept, then another concept. But I can proudly say this orofacial pain has given me a lot of answers. This orofacial OFP system has given a lot of answers in those one unanswered case. Okay, many a case we solve with dentistry because we want to give a good occlusion when there is no such issues related to the orofacial pain. But there is one case which will make you run on your toes, which will not make you sleep. That huge spectrum of TMD, you need to understand we are the one handling that joint. Even the orthopedician doesn't see, when there is an orthopedician near my clinic, he always, any joint he'll handle. When it comes to TMJ, please go to Dr. Ramesh. He is the best person to take it. Think about it. What can cause pain? Is it a muscle that is attached? Is it the dentin? Is it the bilaminar zone, ligament, articular disc? Anything can cause pain, right? Anything. On many people, you have to understand the anatomy, the basic anatomy of TMJ. If the ROM is affected, we are answerable. How will the patient is not able to speak, patient is not able to take his food, right? That means if something is happening in the range of TMJ, you need to understand we are the one handling that. So any pain, it can be a true pain of internal dearrangement of TMJ with symptoms, and it can be a referred pain from some other source. We need to have the knowledge. You hear a sound. People saying, "Are you meeting, sir? I have a sound here, crepitus." If it is happening, then you will be the first person to diagnose a degenerative disease. Degenerative joint disease. An idiopathic condylar resorption will lead to an anterior open. The moment you see the anterior open bite, oh my God, sudden anterior open bite. What is happening to the patient? Let me look into it. That is the beauty of dentistry combining with OFP. And then comes the TMD and the neuropathic. They are comorbidities. We saw a case, right? Multiple dentistry was done on that neuralgia case. Okay, trigeminal neuralgia, very common glossopharyngeal. There are multiple neuropathies which are comorbidities. So to stop here, in this particular point, we the dentists are the one handling this joint, and we are responsible as an orofacial pain specialist to answer the questions of the patient. Then comes the muscle spasm, the biggest problematic muscles that is going to have an impact on the tooth is going to be this primary and the secondary muscles of mastication. We also have a slight temporalis. Your anterior temporalis will refer the pain to central to canine upper, and the middle temporalis will refer the pain to two premolars. Okay, your posterior temporalis will refer the pain to the molars, upper molars. Masseter, it can refer the pain into the maxillary and the mandibular molars. Your anterior belly of digastric can refer the pain into the lower anteriors from canine to canine. So think about it. This referred pain you need to keep in mind. When you look into the mouth, when the teeth is in a good condition, when the patient constantly says pain, everything is fine, everything is good, gum is good, bone is good, teeth condition is good, immediately it has to strike. For that, you need to have that OFP angle, OFP eyes. Many people come with headaches, right, related to the myofascial spasm. Who are the best person to handle these cases? It's face, right? It's headache, it's teeth. Sometimes a sinus pain referred into the maxillary teeth. A cardiac pain, you all know, it can refer to the jaw, right? Think about it. We are dealing with these muscles, and this is related to OFP. That is the scope. This I don't have to explain much. Primary source of pain, it can be here. Then occlusion. If you see sudden bite change that is happening in a case, if there is an idiopathic condylar resorption, it is going to create an anterior open bite. If you catch them early, even then, we may not be completely able to treat the entire case or close the open bite. That's a different ball game all again. But think about it. Think about it. The most important point here I wanted to stress is the non-odontogenic toothaches. If the tooth is fine, if the tooth structures are fine, if your gum is fine, bone is fine, if you have a non-odontogenic toothache, I have seen plenty. They said 1 lakh of case is not an easy case for a dentist. In this 23 years, I have seen patients where the entire arch from canine to last molar, no teeth is there. I have seen a lot of complete denture cases where multiple teeth are extracted. End of the day, finally, the patient is on Masseter. The patient is on carbamazepine. So what is the diagnosis here? It is something as a neuralgia pain which was diagnosed after pulling out all the 32 teeth. Think about it. Non-odontogenic toothaches, you should always have it in mind. Who can find out? People come with toothache. That is the beauty. Why I'm saying scope of OFP in dentistry, people come with toothache. They don't know the tooth is not the reason for that. But as a specialist, as a medicine specialist, as a doctor, we can tell them it is not because of teeth. Don't go and do some stupid work there. Don't go and do root canal therapy. Don't go and do extractions. Don't do replacement. Don't do FMR reconstructions. Think about it. We can do it as dentists. Of course, systemic pain in some examples I'm just giving. This is 30 minutes to speak about a scope of OFP is too much to talk, but I'm trying a level best from dentistry angle. Patient come with pain in the TMJ region. You have the liberty, you have the knowledge now. It can be any arthritis. If all the joints are going to have pain, will the TMJ escape? It is going to have the blunt of it, right? Rheumatoid arthritis, osteoarthritis, psoriatic arthritis. Sometimes take it from me. In my practice, I have been the first person to diagnose this. I may not be able to 100%. I am not 100%. Why should I? There is a limit up to which I have put a mark. I don't go beyond that. I'm not a rheumatologist. Okay, but I have the liberty. I have a limit up to which I'll enter. Then I'll involve the entire team. Pain happening in the muscles. If the entire body is going to have pain, in a fibromyalgia, will the primary or the secondary muscles of mastication are going to escape? Think about it. Vitamin D deficiency can cause muscle pain. Drug interaction and the dosage change can have an impact on the muscles of the face. I'm talking about dentistry-oriented OFP practice. Pain in the teeth. I saw I told you the example of temporalis masseter and the anterior belly of digastric. Right? Think about this. A mid-face migraine comes along with menstrual cycle regularly. It is classic with upper and the lower premolars. I was just blown away when this was conveyed to me in my OFP journey by Dr. T. Right? Pain in the teeth. Good-looking teeth. Correlating with a menstrual cycle. Mid-face migraine comes along with menstrual cycle and it refers the pain. So non-odontogenic pain, people come to you because they come to you, you are the dentist. You are supposed to say that this is happening not because of it is something else. At least up to that level of diagnosis, you're not going to do any irreparable or irreversible damage to the patient. Think about it. Of course, sleep disorders. This is something like I'm blown away when it comes to OFP practice. On simple clinical examination, simple clinical, history and questionnaires, what I give. Okay, I'm stunned. I see multiple patients with snoring and OSA. They are not even aware of the importance of taking care of their sleep pattern. That snoring. Snoring is dangerous. It can lead to one point of time, it can lead to OSA, right? A simple Malambutti screw. What do you mean by Malambutti screw? Just the position of the posterior part of the tongue and the uvula position. It's not a Greek and Latin. It's a very, very simple thing which only a dentist can see. Will the other specialty open the mouth and see? Rarely I see that. Right? When the patient comes, what do we say as a dentist in the dental chair? The moment we sit there, many people don't even talk to the patient. We just ask the patient to open the mouth. When they open the mouth, the first look is, my first look always goes to occlusion, and the next look nowadays comes to my OFP angle. Then appliance therapy, what a dentist can deliver for this sleep disorders, if the sleep specialist tells you, yes, this mandibular advancement disease, they are life-saving. You're going to save the life. It is an emergency situation for the patient. Who can do it? A dentist can do it. That is the scope of OFP for you in dentistry. Okay, and OFP will bring you the true doctor in it. This is something I love saying it, because the satisfaction what you get after finalizing and getting after all the history, you come on end of the day, you get a diagnosis, right diagnosis. Maybe one or two will have a doubt, is it this or that? The satisfaction, the happiness, what you get out of it, when so many multiple doctors are not able to find out, we are able to clearly say this may be one or two, maybe the reason for your pain. Amazing. Recently, I had a patient, sir, from US. I had a 3 to 4 hour of discussion with her. The entire journey, I rewinded the clock. I was very clear of what people have done. This clarity you will gain in this particular OFP practice if you incorporate in dentistry. There are young people sitting here. Don't think about dentistry alone. This is one of the major things that is going to change the entire way how the dentistry also is going to happen in future. Think about it, right? It will make you stand out of the. There is a huge competition, right? In the entire world. I always say occlusion driven dentistry, it will take you. In my place, take it from me. I don't feel any competition at all. I don't fight for root canals. I don't fight for this. I don't fight for this. The moment they see the person 3 to 4 shops next to me also decides this fellow is better, will send the case to him. You will stand out of the crowd. A zone where you will be unique in your approach towards pain. You will be unique. Who is palpating trapezius? Who is palpating sternocleidomastoid? Who is palpating at least temporalis to see a toothache that is happening in a premolar? Think about it. The OFP practice will make you stand out of the crowd. You will be in a zone where you will be unique in your approach. For that, as Dr. T rightly said, your dentistry has to be good. Your dentistry, basics of occlusion-driven dentistry has to be perfect. And then comes this OFP angle. You need to balance both and learn. When people ask me, what should I do? What is your opinion about this? I always say this, master one and then become the master of other. Don't jump into both and become nothing, right? You will reach a zone where you will be unique in your approach towards pain management. Even the worst of pain that cannot be managed. I'm not just boasting or saying something which the general, I have a huge respect for the MBBS people, right? A huge respect. Amazing. That's my dream. Now I landed up in dentistry. Now the dentistry is taking me back to my dream again, to become a medicinal doctor. Think about it. So what is the scope of OFP in dentistry? Do you agree now? Everybody sitting here, do you agree now? We, the dentists, are the true physicians of the stomatognathing system. We are in a better position to treat such patients because people come with pain in all these areas only to a dentist. They don't go to a gynecologist and say all this, right? Think about it. So dentistry, there's a huge scope. OFP has become a specialty. That was the first slide of Dr. T. In March 2020, the National Commission of Recognition of Dental Specialties, they have declared orofacial pain as dental profession's 12th specialty. Just have this in mind. There are so many young blood sitting here. Have this in your mind. But do your dentistry perfect. Learn that perfect. Because as I started into this journey, I'm feeling like, oh my God, am I moving totally away from dentistry? That is it will attract you so much that we wanted to quit dentistry and you will become an orofacial pain specialist. I'm just drawing a line. Okay, this is enough. This is my limit. Let me diagnose. Let me refer. To diagnose and refer, you need some knowledge. You need huge knowledge. It's a 12th specialty. Try to procure once you are good at dentistry. Always remember, come and join this journey of OFP and be one among the few in the world. I can declare and say it is one among the few in the world. Not many people have the guts or heart to accept that is unlearning, right? I am a person whom I was taught, I was driven by occlusion-driven dentistry, but my mentor was very clear in TMD. declare is, he taught me the first slide that struck me very hard. That slide took me into the journey of OFP. Okay, so occlusion driven dentistry, a proper bite as a dentist we need to give. And then this OFP manager, it will be a deadly combination for a successful clinical practice. You will stand out of the crowd. Nobody will be there in that area to reach that level of thought process. The entire faculty around your area, even your general physicians, will have a huge respect on you, like what I have gained in my place. Think about it. Okay, so knowledge has to be improved. It has to be challenged and increased constantly. That is what I have learned after doing 50, 60 courses here. Otherwise, it vanishes. This is a beautiful quote which I love. And I thank you once again for this wonderful opportunity. Hope I finished in 30 minutes. I don't know whether I finished in 30 minutes. Thank you, Sonal. I'm stopping the share.
Yeah, thank you, Dr. Ramesh. And I would easily can tell you, give you a title of brand ambassador for Orofacial Pain.
Oh my God.
They will also agree to it. Nicely put and nicely summarized. And I'm sure Dr. T was listening all the while, and he will have some praises for you. I'm sure of that. Dr. Thomas?
Yeah, I just went to grab some breakfast. The ship is now getting filled, so I muted myself. But Ramesh, your passion in describe, can you hear me?
Yes, sir. Yes, sir.
I don't know if you guys can. Okay, Ramesh, if you can hear me.
Yes, sir.
Sorry, this is there's another ship coming through, so there's a little interference. You can see that ship somewhere there. There was a ship right behind us, one of the Disney ships. So it's going to cut down a little bit. But Ramesh, you did a fantastic job. It's really the passion with which you presented this is just unbelievable. So again, very proud of you and thank you.
Thank you, sir.
Yes. Dr. Ramesh, thank you so much for throwing light on subject.
Ma'am,
Everybody, yeah?
can I disturb one more
Yeah, with
question
Dr.
for please?
SLV, yeah.
Yeah.
Dr.
Good evening,
Ramesh,
sir.
there's a question for you.
Can I
Yes.
request Dr. Abhay to please start his video so that we can see him
Yeah, I
answer?
would like to see him. Dr. Abhay, you can start.
Whoever asks a
Yeah.
question, please start your video so that we can
Yeah.
see the speaker
Yes.
participants.
I'm not able to. I'm not able. Yeah. I hope you
Yes,
can see me. Yeah, I'm
Yeah.
sitting in a car right now. The thing is that, Ramesh sir, you are an endodontist too, I feel, right?
no, sir.
So,
I'm a proud general dentist, sir.
oh, I see. Because I misunderstood that this thing. I was in a general dentistry for many years, and then I opted my oral medicine and radiology.
Great.
And what I wanted to ask you is regarding the phantom pain, if you can tell me something. Like previously, I used to do root canals. Nowadays I have stopped it. And that time, even though the root canals has been done properly, the patient used to get frequent time that the patient always used to complain that there is some pain. And after so many discussions, I came to know that this can be a part of a phantom pain. So, can you please throw some light on it? If it happens in our clinic, how it can be treated, and I mean, a clue to little diagnose it also.
So for me, to my level of practice, what I'm doing here, I strongly believe myofascial pain, myofascial spasm is the number one reason for referring any type of pain into the tooth, sir. So if it is like
Okay.
after root canal also, if the patient is going
Mhm.
to have a pain, like it has a referral
Mhm.
pattern, which is very, very standardized. Simon and Travel is one of the finest book on this topic, where you can see the trigger points or the referral pattern that is going to happen from the entire body into the orofacial pain region. So myofascial pain, for example, the number one culprit, especially when it comes to the maxilla and the mandible, is masseter. A masseter spasm has a huge impact on even a root canal, well done tooth. If it is going to happen, 100% you can be sure it can be caused because of muscle pain. It can be due to muscle spasm. So how do you deal with it? Naturally, we need to learn about the trigger point injections, where we need to shut down the, where we need to find out the site and the source of the pain, right? That is into the next level.
Okay.
So I'm just diverging into the mastership. So once I enter more into the depth of it, maybe I'll be able to better answer your questions. So in
Okay.
short, if root canal treated teeth is having pain, if it is properly done, all the other basic dental abnormalities or the dental things are cleared. If it is going to have pain, then I'll suspect the muscle as the first source. Then the other things.
Okay.
Okay, sir.
Okay, sir. Okay.
Yeah.
Thank you.
Thank you.
Dr. Ramesh, in the chat section, please answer a few questions that have been asked.
Okay,
So,
let me look
okay.
into it. Sorry.
And
I think so. The question is the name of the book. The name
Yeah.
of the book that you mentioned. So they
Yeah.
wanted to.
Okay.
I have gone through the chat. It's the question is that the book that you have. Can you please
Did I
tell
mention a
the
book,
book
sir?
name
I'm
again?
wondering.
Travel.
Simon and Travel. Right.
Okay.
Myofascial pain and triggers or trigger
Yes.
points.
So
Yeah,
you
you
just
can just
write it
mention.
on the.
Is it that topic, Dr. Tanvi? So she will be the best person to see.
No, you can
Yes.
just write the name of the book, doctor, then we can continue. And any
Yeah.
other speakers, please check the chat section. If there are any questions, you can answer in the chat section also later.
Yeah, I have seen only
Okay.
this.
Yes.
That's the
Now,
only question. I checked it out
only
for
one
some.
question. Okay. Yeah. Now,
Thank you, sir.
yeah. Thank you so much, Dr. Ramesh, and it was very enlightening. And
Thank
thank you for adjusting the time. I know you have some other commitments and you have canceled some schedule for us. And
Yes.
that too on one phone call, and that's really overwhelming that you did all that for us. Thank
Okay,
you so
Dr.
much.
Sonal. Can I leave, Sonal? So I have to run
Yes,
back to
please go ahead.
my
Yeah.
site
And
where I
drive
have to
safe,
conduct
drive
the
safe, drive
course.
safe.
Okay. See you
Okay.
then.
Yeah.
See
Thank
you,
you.
sir.
Bye.
See you, sir. Ratan, sir. See you.
You
So,
definitely.
sir,
I mean,
I'm
thank
great
you,
in.
sir.
job.
I'm moving,
Take
sir.
care. See you soon.
Thank you, sir.
Yeah,
Thank you, sir.
I'm in
Thank you.
Chennai in
Bye.
February. We'll see you at that time.
Yes, sir.
Yeah.
Okay. So next we have Dr. Ratin Das, sir. He needs no introduction. Everybody who has learned something or the other about prosthodontics knows about him. They have attended his lectures. They have seen him handling many different cases also. Dr. Ratin Das currently serves as the director of Indian Academy of Aesthetic and Functional Rehabilitation, and is and that's his own baby, I would say, because I've heard many complaints from madam that you concentrate more on that section rather than concentrating on her. So yeah, that's his baby, and you can join his course and learn from him. And he is actually speaking. Don't have to join. Just call him, ask a question. He will tell you. He'll guide you. So that is what Dr. Ratin Das is for everybody. And he is currently a professor of practice in D.Y. Patil Dental College, Nerul, Navi Mumbai. Dr. Ratin Das, sir, this session was an impromptu session for you. And as usual, you have surprised me. Now we have slides presentation from
No. The slides are very
Okay.
simple. I
Okay,
just
Dr. Ratin, you can share
yeah.
your screen, and
Just
looking
let me.
forward to getting more and more enlightenment from you, doctor.
Yeah, just a minute. Give me a minute. Yeah. So basically, I wanted to share this slide because dentistry in India has just lost two stalwarts, Dr. Krishna Nayak and Dr. Daksha Chitri. We just lost them in last 2 days. So I said before, whenever we have a conference like this and a conglomeration of dentists like this, we must remember these two people because they have really enlightened so many of us. And there are no words to describe their role in our lives. So I just wanted to share this one slide with all of you all before we start. Let us all pray that their soul rest in peace. And that's all. Let me go to my next slide. And as Dr. Davis said and Dr. Ramesh was telling, that, Dr. Davis said it took him 25 years back when he removed that block of wood in front of his eyes and he saw the splinters in front. In 2017, life changed for me also when I got through this saying of Steve Jobs and I told myself that I really need to improve on whatever I was doing. And that's when I went through my Dawson Academy. I went through my Moroferiani training, my Edelweiss training, and my Smiley's training. So I just wanted to share this and and that's where I would like to finish my presentation, where I said that we dentists are the engineers of the most complex part of the body. And I think it's exactly what my last two speakers have been trying to emphasize, that we have to understand that we just don't treat the teeth, but we are treating a human being and a human body. And a couple of slides, that Panky always had to say that I never saw a tooth that walks into my office. So important it is that we understand that whenever there's a patient, don't just look at the tooth. And one more slide, don't change what is right to fix what is wrong. This is what Dr. Peter Dawson has to say. And Ramesh was so passionate about occlusion, and he's one person, Dr. Peter Dawson, who defined occlusion to all of us. And I'm sure they all will agree to this thing that we should, before we think of changing anything, please look into what is wrong in the patient. And lastly, I have a lot of respect for the smiley's concept that Maria introduced in our life. So with this, I'll again hand over back to uh, Sonal to take us ahead to our journey of our session today.
Okay, thank you, Dr. Bindas. And can you stop sharing your screen so that I
Yeah, we'll
can
stop
start with
sharing.
our, yeah.
Yeah.
So this session with Dr. Ratin Das is actually a session that is in conversation with Dr. Ratin Das. And here we want to debunk, or we can say, the facts and fallacies that are concerning with orofacial pain practice. And Dr. Das, as usual, being a student, I will ask certain questions, and I'm sure this is an impromptu session. So I
So it's
would
a role reversal. It's a role reversal. You're
no,
asking a
no,
question.
yeah, I'm not the one giving the viva this time, so I'm very happy
I'm giving the
that
viva this
you are
time.
giving the, and it feels good also that okay, I am the one asking the question now.
Yeah.
So Dr. Das, one pertaining question that comes to our mind now is, what are the factors that have contributed to the evolving or understanding, or this heightened awareness of or diagnosing and management of this non-odontogenic issues or pain related factors that come to our practice? So what do you think, what has contributed to this whole evolving situation? Because earlier also you have been practicing for what, past 25 years or more, I would say. And now the dentist today is more aware. So what led to this transition? So what are the factors that led to this transition as as a clinician, as an academician? What do you
Yeah.
think has led to this transition?
I would say orofacial pain always existed. It was nothing new that dentistry is seeing. It is only thing that we are identifying it today. And when it comes to identifying, as Dr. Davis has rightly said, that the identification that this is orofacial pain and it is not just tooth related or it is not odontogenic in origin is extremely important. And for that, I'm sure specialized training is required. You just can't one day suddenly think that I can start diagnosing the difference. Even Ramesh has very clearly said the pain, what type of pains, the different types of pain he has explained so beautifully. The last two presenters actually demystified this entire thing of orofacial pain. And I feel that orofacial pain, most of it is iatrogenic in origin. We dentists try to create that pain into that patient's mouth. And, it is very, very important. Every time, both my speakers have been emphasizing the importance of diagnosis. We dentists are, we are very dogmatic in our practice. Moment a patient walks in, we make our diagnosis even before the patient is sitting on the dental chair. If the patient complains of pain, we feel it has to be either endodontic in origin or periodontic in origin. And we define it that way. We don't see the patient as a human being, as a total, package, I would say. And it's only when you look beyond just the tooth, and for that, you need to have training, first of all, and lot of time you need to spend. A diagnosis is the crux of any of our good orofacial practice, I would say. Not only pain, even our daily dental practice, where we lack is diagnosis. We do not sit with our patients, right, Sona? So did I get my point through?
Yes, doctor. So, do you feel that we need a standardization for clinical application protocols to be followed for diagnosing this or managing these conditions?
Absolutely, absolutely. Now, again, if we go back to our dental college days, your dental college days, even with mine, there was a case history pro forma that was given to us. And the least importance was given to filling that case history pro forma meticulously. None of us did it. I did not do it in my college days. My students did not do it in their college days. But today in practice, we realize that this case history pro forma is the crux of everything. You tell me, we all taught you how to do TNG examination. We have Dr. Abhay over there, who's an oral medicine person. He will agree with me that we have every dental student should have a stethoscope with him when he's on the OTT or when he's doing a diagnosis, when he's doing a clinical examination. He has to check the temporomandibular joint. Where do we do it? Who does it? So, that's where we have not done. And today we are taking it as a specialization ahead. So it was always taught, and as Dr. Davis has rightly said, at that time we did not understand. Chaurasia was sold off and we burnt a Chaurasia, but today we realize, occlusion, how passionate Ramesh spoke about occlusion. Wheelers, chapter number 13. I think so we all jumped that chapter because at second PDS level, we never understood that chapter. Unfortunately, most of the teachers teaching dental anatomy and dental histology did not understand it also. But today, practice is just occlusion.
Yes, doctor.
You understand occlusion, you'll have everything of it. So definitely, as you said, it is very, very important for us to re-emphasize this and have a proper training in diagnosis and treatment plan.
Doctor, you have been a clinician and a academician all this while. So what do you think, what measures at your level can be taken to strengthen the connection between clinically diagnosing and therapeutic strategies for orofacial pain management? And also, how do you educate the future generation? Like when you're educating your students, how to clinically approach these kids? Because most of us are into practice for many years, but we as I am when I started doing this orofacial pain practice, I felt as if it's a new day for me, first day for me. So what strategies you would want to inculcate as a clinician, academician, for the students? So what are the skills that they need?
Yeah. Sonal, very good question you asked me. And I think so the answer to is, I have everything is pointing towards Dr. Davis. I know he's the guru in this of all of it. And you know how Dr. Davis is today rightly telling that he's sitting in a ship full of physicians. And as a dentist, he's making them aware what is orofacial pain. So this understanding is extremely important. We fellow colleagues have to understand. Ramesh also has rightly said that if there are 5 dentists on the road, everybody can't be trained. One gets trained specially, and not only training. See, we all may have attended courses, but fortunately, unfortunately, you get cases. Certain person gets more exposure. As Sonali rightly said, I have a wonderful setup because I've got a wife who's an oral surgeon and people refer cases to her. And whenever I get to see these cases, they are filtered down because when there is no joint problem, there's no surgical requirement, those patients are referred to me. So I get the crux of these, TMJ disorder patients, so-called or orofacial pain disorder cases. So it's extremely important for us to understand, train ourselves, even at the academic level. I would say probably at a postgraduate academic level, I would say, and at undergraduate level, it is very difficult to understand this. But at least at the postgraduate level, we should understand that this is like a super specialization. It's a super specialization. 2017, when I got myself trained, I was teaching postgraduate students. I had postgraduate training going on with me. But I realized, what am I doing? What am I teaching these boys? I'm just teaching them the same simple dentistry prosthodontics. It's only when I went and explored and dentistry changed with me with my training. So it's very important for the academicians first to train themselves. Yes. So that the future generation gets an exposure. At least somewhere, like a conference like this, it's so important. Somewhere it is going to scratch our brains that, okay, we need to do something different. We have to understand there is something different happening. And there's nothing new. I will simply say there's nothing new. It was all there. And little bit, there's a hype of it, we dentists, unfortunately, what happens, after a few days, there was root canal happening. When root canal came in, root canal happened. Then we went from root canals to, engine-driven root canals. So, something or the other, we need to have new in our practice. Like the scanners, as Davis has rightly said, the scanner has come like a scam in dentistry. I totally agree with this term that he used, and I'm going to use it in my lectures now, that scanners is a scam. It is trying to make dentists feel that, I put it very simply, you have a Mercedes, you have a Maruti 800. Both will drive you, and especially in Bombay roads, won't write you the same way. It's only when we hide things with things. But when you want to really improve dentistry, you have to understand, train ourselves in good courses, take good training, understand, and remember one thing, very, very important is, when we get trained, we finish, that is the end of the road. It's never an end of the road. You have to keep listening, you have to keep doing and keep, revising. It's very important. This is what I would say as an academician to my fellow friends over here. Yeah.
Thank you, Dr. Das. And I am sure this is like an accumulation of what I was trying to put. This whole Congress itself, the feelings behind it is that we need to provide students or faculty members a right succinct pathway, or maybe something for them to take home and teach the students also. The faculty has to be equipped with what you correctly put it up.
Absolutely.
And
Absolutely.
and
all my faculty here will agree that we love to teach because we are at the base of the pyramid, which says that teaching increases our knowledge. So we love to teach because our knowledge increases in that. And with that, we increase the knowledge of people around us.
yeah,
Yes.
yeah. Okay.
Can
Yeah,
I add a little bit if the time permits?
yeah,
Am I
Dr.
permitted?
Yeah, tell me.
Okay, just 2 or 3 minutes max. As sir rightly said, that in the academics we should have a separate pain clinic rather, because when I was learning my dentistry, that was in 90s, late 90s, and rather early 90s. And that time my sir used to say, keep pain is a bread and butter of dentistry. And his saying is still holds true for all the academicians and clinicians, that 90% patients are referring to us because of a pain, and either they don't see because we cause pain in our clinic to them. So we need to work much more on this aspect. So every academic institute have a separate plain clinic plus a separate temporomandibular joint clinic. The temporomandibular joint pathologies are not treated properly. So if a patient is having a TMJ problem, a oral medicine specialist, a oral surgeon specialist together should work at that time and should try to solve the problem. Then only it will probably work and it will have a good shape for the patients.
Thank you, Doctor. Thank you for this insight. And Dr. Das, back to you. Yeah. Dr. Abhay?
He's
Yeah.
done, I think so.
Yeah, he's done.
Davis,
Yeah.
sir wants to say something. Dr. Davis
Yeah,
has
just a
something.
second. Dr. Davis, yeah, you can.
Yeah, I'll be quick. I just want to make sure that my Wi-Fi might get cut off a little bit. Because as you can see, there's another ship. It's coming through. It's a huge one. So when that happens, that Wi-Fi just gets interrupted a little bit. And we are about to, this is Grand Cayman Island. So I'm going to go back down to the room. I'll probably try to join from there. Bear with me that time. The course is fantastic. My all the best to the course, but I'll try to stay logged in, okay, if I can.
Yes, Doctor. We
And
have
bear with me.
presentations now, so you can you can look into the new generation of budding orofacial pain
Sure.
specialists who are coming in from colleges now.
Okay.
Okay. And
Okay. Again, this is finally for the
Yes.
patients, that's the thing.
Yes.
So we need to make sure that thing is pushed forward. Thank
Okay.
you. I'm going to log off for a moment and then I'll rejoin again.
Okay. Yeah. Dr. Das? Yeah.
दरवाजा
Yeah.
खोला ठीक है
अनुष्का, दरवाजा खुल गया है, अनुष्का अपने दिमाग का दरवाजा खोल दीजिए अभी.
It's open.
You're muted, Sonal, you're muted.
Okay, Dr. Das, as always, you are the person who concludes the whole session. I always say that, but this time you are the paper presentation jury also, and I
Yeah.
would like you to go through all the presentations, and we will give them marks and scores and all. And with you, we have another faculty as our paper presentation jury, Dr. Seema Rathi. Dr. Seema Rathi, are you there?
Ma'am, she was there just now.
Hi, can I
Hi.
have a word, please?
Yeah, Dr. Sameem.
Sameem.
Yeah, tell me.
Yeah, so I get back to the days when Rathan sir, Das sir basically was at YMC. I am sir's student, and after like 5 years, I'm watching him and hearing him again. So it's just nostalgic that hit me. I have so many pictures with him. I just wanted to say a very thank you to Ratan sir at this such a big conference for putting up that prostho fear plus that prostho uh, complete guidance, right? Because prosthodontics was there since day one we entered the college till day
And
last.
Samin,
Joshi
if
sir,
you remember,
Das sir.
we were the only department which gave you all stethoscopes to examine the TMJ during the exam.
Yes, yes, sir. And I remember Joshi sir said, this girl will do JR only in the finals. Rest everyone's do. Rest
So we knew
everyone do the
you're good at it. See, since those days we knew you were good at it.
The fan
Yeah.
moment.
So thank you so much, sir. It was
Stay
great
blessed.
listening to you again. And now again, I feel that I have to uh, become an orofacial pain specialist again.
Stay blessed,
The
dear.
right
Thank you
Stay
so
platform,
much.
blessed.
right platform for you. Yeah, now we have Dr. Seema Rathi here, a second jury for paper presentation. Hello, Dr. Seema.
मैं सोच रही हूँ अंदर से
Can
मैंने
you
स्टेपलेस
unmute,
ब्रा
can you
मंगवाई
unmute
है
yourself,
वो
Dr.
पहन
Seema?
लूंगी मैं कि
Dr. Seema, unmute
इसमें
yourself.
तो कुछ
Dr.
नहीं हो
Bhagwat,
जाएगा
please
सिर्फ
mute
इसमें
yourself.
Anushka,
हाँ दीदी कही
please
थी
mute.
बूट टेप ले लो
Yeah.
Hi, Dr. Seema.
Hi.
Hello.
Hi, it's a pleasure to
देख
be
सुन
on such a fantastic
तेरा जो वो है
platform.
स्टेपलेस ब्रा
Anushka,
है
last warning for
वो
you,
कैसा
dear.
है दिखा
Please mute yourself. Dr. Anushka Bhagwat.
रिवीलिंग लग रहा है
She's yet not unmuting herself. She's not listening.
पर पल्ला आ जाएगा तो नहीं होगा इतना
साड़ी का है
Okay.
Dr. Sonal,
भरी
you
हुई है
can
Sonal,
unmute rest
Sonal,
of
just
all
mute
the
everybody,
participants.
ऊपर का
Sonal.
पल्लू
Just
और
mute
दिखा
everyone. You can allow them to come
सर
in.
उनके पास
Otherwise,
वाइट
it's going to be
नहीं है
continuous like this.
Where is she?
ऐसा है
Just
ना
mute
वो मैं ब्रा
everyone.
में ही
Ask the
खिंचवाई थी ना
organizers to mute.
ब्रा जैसा लग रहा है क्या
Dr. Mural, please intervene here and mute Dr.
पैडिंग जो है ना वो बहुत विजिबल है
I'll just
She
take
is
her out.
not
नहीं मिल
listening.
रही
She
है
has just
यार
kept
तो
it
क्या
on
कर
and she's
सकते
off.
हैं
God.
Just, that's it. Just
Okay.
remove her from the group.
I did
That's
that.
it.
Okay, Dr. Seema Rathi, and Dr. Seema Rathi is actually when I saw her profile, I was like, where to start? I should call her an implantologist and a general practitioner, a dedicated wife to Dr. Akshay Rathi, who is and also a course mentor for implantarian and KOL for many companies, and she's speaker on various platforms. And I see her always as a jury for various things other than dentistry also. So she's been a jury and a participant there also. So Dr. Seema Rathi has always been an inspiration to many, and this time we have her as a jury. Dr. Seema, one question or two question I would like to definitely know from you. Where do you see or how do you see the students, or when you talk to your students, how do you see them getting involved into orofacial pain practice? Like, what do you see the future of orofacial pain practice as an implantologist? Like, how do you like to incorporate it to your students, and how do you want them to come into this practice?
Oh, it's very important. Now that orofacial pain, it is not that a thing of the past. It was always there. So now I heard all the revered speakers also speaking that you're not supposed to see a tooth walking into your practice, but the patient attached to it, the other way around. So we tend to see these factors a lot more now that we are understanding treatment plan holistically for the patients, where you are covering 360 degrees treatment for the patient. The plan is there right from the inception, from the time the patient walks in. So it's very important that all these factors are taught and covered at the time when the student take admission in the BDS level, like in the first year BDS itself. The anatomy is not given so much of importance. We use it just as a subject to get some marks or pass and move further. But it is very important, and the details should be covered much more in with precision, because that is going to be the base of how we're going to practice further. As Dr. Ramesh also said that he always wanted to be a MBBS doctor. He is a doctor as a dentist also. But if you are supposed to study the anat rightly, right from the beginning, and not after becoming a dentist going backwards. So these things are necessary to be given so importance into our teaching in college level itself. And also, I would also say that this is we as dentists as a group have to be very, very proud and sure of our knowledge, and the depth of our knowledge should be so much that the physician faculty are able to refer the cases back to you. The neurologist should be calling you up and asking you the diagnosis and talking to you, because this is pertaining to the orofacial structure where you are the super specialist. If you have done this course, you become the super specialist. You're already a super specialist as a dentist for the body. So
Yes, very
these
well
are
put,
the
Dr.
things.
Seema.
Yes.
Very, very well put. And welcome to this panel and thank you for your time for being the jury. And
Yes, it's
with
my
that,
pleasure.
all the presenters, are they there present? Our first presenter is Dr. Rukshin Irani. Are you there, Dr. Rukshin?
Yes, ma'am, I'm there.
Okay, can you switch on your camera? Okay, let me be very clear about the rules that we will be following during this paper presentation. One is your timing, because you are in category A, you know the time limit. And secondly, the topic has to be a very relevant topic, that as well as the presentation part of it, how you're presenting, how well you have understood the topic, and if at all there are any questions which we would like to ask you, and how well you answer them also. Okay. And don't worry, this is not a viva, though you have two faculty members over there. They are very strict and stringent when it comes to giving you marks for viva. But here they will be lenient, so don't worry on that. Be very relaxed, have a sip of water, okay? And share your screen. Dr. Ratin, and once I say go ahead, that is your time limit start. So I'm marking you with time limit also. So don't worry, there will be a fair chance given to you regarding the time.
And
Okay.
we will not give you pain. Don't worry.
See, lenient. He's very lenient. I know that. Okay, the first presenter, can you go on a full screen mode, please? Dr. Irani, full screen mode, please. Your time starts now, doctor.
A very good evening to one and all. I'm Dr. Rukshini Rani, and I'll be presenting on endodontic excellence, navigating the hot tooth challenge. So basically, endodontic emergencies are the conditions associated with pain and or swelling requiring immediate diagnosis and treatment. And a major challenge faced by an endodontist is the successful management of endodontic pain with adequate anesthesia, especially when one encounters a condition of a hot tooth. So basically, a hot tooth refers to a pulp that has been diagnosed with irreversible pulpitis with spontaneous moderate to severe pain. Clinical signs and symptoms for recognition, how to identify a hot tooth. The clinical sign can be that of a deep restoration, caries or secondary caries, accompanied by the symptom of pain on biting, positive percussion test. Clinical sign of a coronal fracture line is accompanied by the symptom of increased sensitivity to temperature extremes. A clinical sign of increase in tooth mobility is accompanied by a symptom of intense pain in response to heat relieved by cold water. And radiographically, when there's thickening of the periodontal ligament, there is poorly localized pain, which is often radiating from the ear to the temple. The pain is referred to the opposing arch at times, but never crosses the midline. Causes of anesthetic failure, there have been several theories which have been proposed, like the iron trapping, altered membrane excitability, central core theory, central sensitization, and tetrodotoxin resistant channels. All these theories are based on the fact that irreversible pulpitis is accompanied by inflammation of the pulp tissue, as a result of which there are inflammatory mediators, and these inflammatory mediators at some point are going to affect the action of the local anesthetic. In addition to that, there are some anatomical factors like in a mandibular molar tooth, where there is a dense cortical plate, which can affect the efficacy of the local anesthetic, or there is sometimes even accessory innovation. And psychological factors also when the patient is fearful or anxious. Now, coming to the management of a hot tooth. So basically, the typical tooth which usually presents with this condition is a mandibular molar that we have to deal in our clinical practice. And when the typical inferior alveolar nerve block fails in both symptomatic and asymptomatic patients, a dentist must have a fallback technique. So let us consider the fallback techniques in addition to an inferior alveolar nerve block. One is that of conduction anesthesia. Conduction anesthesia consists of the Gao-Gates and the Vazirani-Akinosi technique. The Gao-Gates technique provides sensory anesthesia to the entire mandibular trigeminal division using extraoral landmarks and a single intraoral injection puncture point, exposing all branches of the mandibular nerve to the anesthetic solution. Whereas the Vazirani-Akinosi technique, also known as the reduced mouth opening technique, it is indicated when patients have reduced mouth opening. It is a technique which involves the insertion of the needle just medial to the ramus of the mandible at the level of the gingival margins of maxillary molars in a closed mouth position, depositing the local anesthesia solution into the pterygomandibular space. And a modified version of the inferior alveolar nerve block, it deposits the solution a little higher than the level of the inferior alveolar nerve block. Supplementary anesthetic techniques that can be used to anesthetize a hot tooth are that of intraligamentary anesthesia. The intraligamentary, it involves depositing the local anesthetic solution into the periodontal space between the tooth root and the alveolar bone. Usually a 27 to a 30 gauge needle is used at an angle of 30 to 40 degrees up to a subgingival depth of 2 to 3 millimeters. The next supplementary anesthetic technique is that of intraosseous injection. The intraosseous technique involves the local anesthetic solution deposition directly into the porous cancellous bone around the tooth using a port or a perforating system as seen in the accompanying figures. The last supplementary anesthetic technique that we can use to anesthetize a hot tooth is that of intrapulpal anesthesia. And it should be the anesthetic of last resort. The needle should be engaged into the canal. And for this method to work, the local anesthetic has to be injected under resistance. In addition to all these techniques of anesthesia, the patient may be pre-medicated as well. So in case of pre-medication, frequently used are NSAIDs, like ibuprofen, we can use acetaminophen, we can use different combinations like ketorolac and paracetamol, etc. We can also pre-treat a patient with corticosteroids like prednisolone. And a study suggested that a single oral dose of 30 milligram prednisolone administered 30 minutes before the endodontic procedure reduces post-endodontic pain. We can also use a combination of ibuprofen and dexamethasone to pre-medicate a patient to enhance the efficacy of the local anesthesia. Pre-medication with nitrous oxide and ketamine is also indicated. And the only thing is that adverse effects associated with nitrous oxide sedation are that there is diffusion hypoxia after cessation of the nitrous oxide and vomiting. Now, we can also undertake changes in the anesthetic solution to enhance the efficiency of the local anesthesia. So the methods that we can undertake is addition of dexamethasone to lidocaine, addition of mannitol to the lidocaine. And now gaining popularity is 4% articaine, which is used instead of 2% lidocaine, which enables us to improve the efficiency of the local anesthetic. And another method is also pre-warming or preheating the anesthetic solution, which is also going to enhance the local anesthetic effect. Coming to how to treat a hot tooth in a nutshell, as far as local anesthetic techniques are considered, mandibular posterior teeth, inferior alveolar nerve block, long buccal nerve block, and supplemental techniques like intraosseous, PDL, and intrapulpal may be used. For mandibular anterior teeth, again, the inferior alveolar nerve block, and supplemental can be intraosseous or intrapulpal. Maxillary anterior teeth are one of the easiest teeth to be anesthetized, and in the sequence of hot teeth, they will present as the last one. So for maxillary anterior teeth, we have to use labial or palatal infiltration. And for maxillary posterior teeth, we have to use a double dose of buccal infiltration, and then we can use infiltration at the apex palatally, and supplemental methods are intraosseous and PDL. Recent advances in the management to enhance the efficacy of the local anesthetic, cryotherapy, lasers, we can use benzocaine gel and hyaluronidase enzyme, as well as acupuncture. Thank you so much.
Yeah.
These
Thank
are my references.
Thank you, Dr. Irani. Yeah, you can send the presentation to us on email. Good one. Dr. Das, do you have a question for Dr. Irani? Hello? Dr. Ratin Das or Dr. Seema?
Yeah, it's okay. I think we will go ahead with the next.
Yeah, okay. Fine. So the next presenter is Dr. Jay Joshi, category A. Dr. Jay, are you there? Jaya. Sorry, Dr. Jaya Joshi. Pardon me, Dr. Jaya Joshi. Are you there, Dr. Joshi?
Am I audible?
Yeah, you're audible. Can you switch on your camera, dear?
Yeah. Ishan,
Dr. Irani,
camera
please.
काम नहीं कर रहा है. Fail to start the video camera.
Dr. Jaya, till then can you share your screen, please?
Shall we take the next presenter?
We'll give her a second. Yeah, she's sharing the screen. Okay, can you go on a full screen mode, Dr. Jaya? Yeah, your time starts now. Dr. Jaya, go ahead. Your time starts now. Your screen is visible.
Good evening to all of you there. It's
Dr. Jaya, start the presentation, please. Forget about the camera.
Yeah. Am I audible to you?
Yes.
Am I audible?
You're audible. Yes, please continue.
Good evening to all of you there. It was a wonderful entity listening to some of the.
Dr. Jaya is not very clear.
Yeah, your voice is not very clear. Is there any other device around you? There is an echo.
Yes.
In the meantime, we can tell other participant to come in and she could correct this.
Yeah, Dr. Jaya, we'll take you in after the third participant. Dr. Jaya, stop sharing your screen. Okay. Do we have the third participant with us, Dr. Usma Mari, with us? She wanted to come in a little early. She's from the category B, the student category.
She's there, I think so. Please unmute yourself, Usma. Unmute yourself. Okay?
Yeah, please unmute yourself.
Hello.
Yes. Hello, doctor.
Lisa,
She's a
Lisa.
student. She's a student, okay?
Lisa.
Lisa, okay. She will be, yeah, she is Dr. Lisa. Dr. Lisa, you are from student category. She will be marked, doctor. The jury member, please note, she will be marked, okay? Doctor, please start sharing your screen. Dr. Lisa, please start sharing your screen. I think we lost her also.
So Dr. Jaya Joshi is back, so we can take her back.
Am I audible? Firstly, I would like to know. Am I audible?
Yes, ma'am, you're audible.
You're audible.
Thank you. Can I start sharing my screen with your permission?
Do that. Please do that. Dr. Lisa, we take you in later then.
Is it visible out there?
Yes, ma'am.
Yes.
Okay, thank you. It was wonderful listening to the extensive, wonderful sessions on orofacial pain.
Be little audible. Dr. Jaya, not audible. Please be a little clear.
Just a
It's
minute.
okay, I think so. We'll go ahead. We'll go ahead. Let's
Go
finish
ahead.
it.
Your time starts now, Dr. Jaya.
Yes, yes. Is it fine there? I need
Yeah.
to be more. Okay. So with the orofacial pain and the dental pain coming in picture, we talk about the cells of the tooth, the significant one, the odontoblast playing the significant role in not only regulating the pain, but also the pulpal inflammation. So we are here with odontoblast in pulpal inflammation, its role of immunity there. When we talk about the immunity, we all are very well versed with the graduation level teaching of innate and adaptive immunity. The innate takes its own pattern of recognition of the pathogens by its sensor, removing the infectious agent, while the active one, which is very specific antigen acts to bring about the effect of the T and the B cells in the lymphoid organs. Here, in terms of the odontoblast, both the system works hand in hand, but then the innate seems to be playing a very significant role there as compared to the adaptive immunity. So the components of the innate immune system, that is a natural immunity, is basically these four ones. They're talking about the first one, the physiological barriers. Physiological barriers are the epithelial lining of skin, mucous membrane, or the parameters like temperature, pH, whereby the barriers acts and then the innate system starts. In terms of odontoblast, the dentinogenesis is the physiological barrier that it forms the reparative, the tertiary dentine. The second one, the anatomical barriers, is very significant with odontoblast recognition of the innate or the odontoblast playing the innate immune response to the pulp. It is the pattern recognition receptors. The pattern recognition receptors are lots of them are present in the odontoblast, and they recognize the receptor called as the pathogen associated molecular patterns, PMMPs, and thereby bring about the effect in the form of innate immunity, in the form of phagocytosis or the inflammatory response of the pulp. Inflammatory response is further being brought about by the innumerable number of cytokines and the chemokines that are getting released by the odontoblast. This is the same small picture of the adaptive immunity, whereby the dendritic cells are getting activated by the microbe, which in turn activates the B and the T cells and bring about this effect. Here, the odontoblast also brings about the activation of the dendritic cells and subsequently brings about the adaptive immunity of its own in the pulp, in the vicinity of the things. So, am I right when I say that the odontoblast are the gatekeepers of pulpal immunity, taking place the innate as well as the active ones? Yes, the odontoblast, which are lining the pulp-dentine interface, not only acts as a protective barrier through the process of dentinogenesis, but also mediates the immune response of the dental pulp. And this is how it brings about its effect. The interface is out here, the gatekeepers are out here. This gatekeeper is receiving the signal from the bacteria, assaults into it, releases lots of antimicrobial peptides, which are the beta defensins or the nitric oxides or the lipopolysaccharides, and releases a chain of interleukins and the chemokines to bring about its protective mechanism. We know about it, protection, reparation. Reparation is brought about by the dentine. But can we talk about the second one, that is the regulation of inflammation by odontoblast? Yes. How? It is not only the pro-inflammatory. Odontoblast doesn't bring about the inflammation itself. It leads to a lot of production of anti-inflammatory cytokines. Why does it need the anti-inflammatory cytokines? Once we know that the inflammation the low grade of inflammation will bring about the protection, while a high grade of inflammatory response by the pulp lead to the damage of it. And this is getting regulated through the other chemicals. So it is not just about the protection that it brings about. Now, talking about the basic mechanism by which the odontoblast brings about the innate immune response. The first one is the recognition of the pathogens through the pattern recognition receptor, like the toll-like receptors or the nod-like receptors. What it detects the microbial component, that the PMAPs, and how the microbial component of the lipopolysaccharides from gram-negative bacteria, while the lipoteichoic acid from gram-positive bacteria. Both of these are the, particular microbial component which elicits the toll-like receptor. And here, if you talk about the toll-like receptor 2 and 4, these two are the most significant one, which brings about the gram-positive recognition and the gram-negative recognition respectively, while the rest of them also seems to be playing the role, but not that much as compared to the TL2 and the TL4 receptors of the odontoblast. So activation of these receptors initiates the downstream signaling pathways that leads to the immune response of the pulp. Now, beside the pathogen recognition, the number 2 is the production of the antimicrobial molecules. Odontoblast produces beta defensins, the cathelicidins, the nitric oxide, and directly neutralizes the microbial invasion. Further, odontoblast also secretes a cytokine secretion. It releases the pro-inflammatory cytokines like the interleukin 1b, which promotes inflammation and recruits the immune cells. While the tissue necrosis factor, what does it do? It amplifies the immune response and induces the apoptosis. The chemokines also brings about its effect in recruiting the macrophage and the neutrophils, and thereby it bringing about the phagocytosis. Beside, the plexus of nerves that you can see in this picture is also responsible for secretion of the neuropeptides, and thereby odontoblast enhance the neurogenic inflammation through the pain signaling pathway, which is very protective and bringing about this immune response. This is a simple presentation of how the bacteria, with its production of the proteins coming into the dentinal tubule or the dentinal fluid, exciting the odontoblast and leading to the secretion of, firstly, with antimicrobial peptide that directly kills the microbe, while in turns the cytokines, which brings about the inflammation, the chemokines, which recruit the inflammatory cells. So all these mechanisms is there. And see the gatekeepers, how they are taking up the front at the gate when there is inflammation in the pulp. All of them are moving towards the interface of the dentine and the pulp. Now, talking from the innate to the adaptive, yes, odontoblast also has got the antigen presentation function, and they are not professional ones like the antigen presenting cells, but they are unprofessional ones, and they present the antigens to the T cells as well as brings about the adaptive immune response to the T cell differentiation and the dendritic cell activation that I was talking about in the previous. The interaction of the further, it is also in the adaptive immunity, it is also leading to the interaction with the immune cells through the cytokine secretion. Crosstalk with the dendritic cells, the odontoblast also interacts and brings about the modulation in terms of immune response with the activation of the T and the B cells. So are we right when we say it bridges? Yes, odontoblast bridges the innate and the adaptive immunity. It plays a very significant role there. The signal transduction and modulation is another very significant feature of the odontoblast. This odontoblast detects the mechanical and the chemical signals of inflammation and mediates its transmission of nociceptive signals. And this is how the signal transduction, while not only it also regulates it leads to the regulation of the immune environment. How? By balancing the pro and the anti-inflammatory signals. Because we need to have a balance of the inflammation. If the inflammation exceeds beyond a boundary, it leads to the further damage to the pulp. So it has to stop it out. It has to halt it out with the production of the chemokines, especially with the interleukin 10. It brings about this effect. The signaling pathways are there, which is basically leading to this entire mechanism. It works, the odontoblast works mostly through the nuclear factor kappa B pathway and the MAPK pathway. The first one is leading to the toll-like receptor activation that leads to nuclear translocation of nuclear factor kappa B into the expression of cytokines and the chemokines and the expression of the antimicrobial peptides, while the mitogen activated protein kinases are activated, contributing to the cytokine production and immune cell injury. So both these signaling pathways are significant. With these whole lot of understanding of the immunity, why do we need it? What is the clinical implication of doing this? Well, it can be used. Understanding the odontoblast mediated immunity is crucial to understand the target treatments for pulpal inflammation, the chief problem with which the patient comes to your clinic. The pulpal inflammation, the diagnostic markers, and the therapeutic intervention. So diagnostic markers can be, increased expression of the toll-like receptors or the antimicrobial peptides in this particular odontoblast can be used as a biomarker and for the early pulpitis detection, while the therapeutic interventions can also be tackled. How? By modulating the odontoblast mediated response, which helps in the control of their pulpal inflammation. How can we achieve that? With agents like enhancing the antimicrobial production of the odontoblast, or some agents which is leading to the toll-like receptor signaling pathways.
Time is up. Can you just conclude?
I will just take 30 seconds more and I will conclude it there. So, but it's not that simple. There are challenges in pulpal defense. What are the challenges? The microbial evasion. We know the COVID, the virus evaded us, and so here was the bacteria evade, and thereby these are the two challenges that we face when we design with the therapeutic management. So, summarizing the last slide of it, the odontoblasts serve as a frontline defense of pulp, functioning as sensors, responders, and modulators of immune. The three things, and it has got a very significant dual role in immunity with the tissue regeneration, that is dentinogenesis, and maintaining the pulp health during inflammatory challenges. Thank you out there.
Thank you, Dr. Jaya. It's a wonderful presentation, and we would like to know more about how you can incorporate orofacial pain practice also in relation with all these pain pathways. Thank you, and would love to hear from you in next presentation also.
Thank you there.
Next presenter is again Dr. Lisa Mari, and I'm sure she is here now. So, Dr. Lisa, are you there?
Am I audible, ma'am?
Yes.
I'll just share my screen. Please give me a minute.
Yes. Please go on full screen mode. Your screen is visible.
Ma'am, full screen, ma'am. Is it visible?
Yes, it is visible. You can start now.
Very good evening, respected judges.
Dr.
and
Lisa,
members of the
Dr.
audience.
Lisa, there is an echo in your presentation. Is there any other device nearby which is running?
Just a second.
Switch that thing off.
Use headphones, dear. It's better if you use headphones.
Now is there an echo?
No.
No.
Okay.
Yeah.
Your
No.
time starts now, doctor. I'm rescheduling again. Okay,
Yes.
start.
Very good evening, respected judges and members of the audience. The title of my presentation today is Lighting the Way Forward, Low-Level Laser Therapy in Temporomandibular Disorders. So temporomandibular disorders are a set of clinical conditions that include disorders of the TMJ and or the masticatory muscles. So now this occurs in all age groups and has a female predilection, which has commonly been noted. It's characterized by symptoms of orofacial pain, joint noises, the TM joint noises, restricted mandibular movements, abnormal swallowing, tinnitus, headaches, and hyoid bone tenderness. Now, this severely affects the patient's mental health as well as his day-to-day activities and severely affects the patient's quality of life. So coming to the etiopathogenesis, it's said to be multifactorial with factors ranging from biological, like fluctuating hormones, which can affect the joints and bones, genetic factors, genetic predispositions, biomechanical factors like bruxism and occlusal overloads, neuromuscular and biopsychosocial, stress, anxiety, and depression. However, in this lecture, we've just learned that this might not be the case. Anyway, moving forward, the treatment of temporomandibular disorders is multidisciplinary. So it involves physiotherapy, ultrasound therapy, intraoral appliances, and TENS therapy. So medications are often the first line of treatment, and then surgical intervention will be based on symptoms, severity, and cause of pain. So now low-level laser therapy has come into the spotlight for its applications in temporomandibular disorders. That is because of its easy application, short treatment time, and relatively fewer contraindications. So why low-level laser therapy? So low-level laser therapy basically means that is a therapeutic use of light. So this light is able to accelerate ATP synthesis, which will help to give an anti-inflammatory effect. Nitric oxide, which is also produced by this LLLT, will reduce the inflammation, will get rid of the offending factors. Ion concentrations will increase. There will be the release of growth factors. Mitochondrial signaling will increase. Transcription factors, especially I would like to mention HIF factor, that is the hypoxia-induced factor. This factor will aid and increase the healing of burn wounds, the alleviation of neuropathic pain. LLLT really does have its advantages and is a proven. It's proven in relieving pain. So I did a brief review of studies. So this all the research is controversial because there's never any conclusive result whether low-level laser therapy is effective in the long run. However, it definitely does provide short-term relief. I would like to highlight four major studies. So Marini et al. In Italy in 2010 carried out a study on 99 patients, and they tested laser light versus ibuprofen versus placebo, and they found that a low-level laser therapy was effective in reducing pain intensity, increasing mandibular function, and the movements of the TMJ. Kali et al. Similarly tested laser and piroxicam, laser and placebo, and laser and piroxicam, and they found that the placebo was more efficacious in reducing pain intensity and in the functional movements of TMJ. So Demirkol et al., they carried out a study with the external auditory meatus. They used different lasers and they also instituted mouth opening exercises in certain patients, and they found that the severity of tinnitus decreased with low-level laser therapy. And Yumoto et al. In 2013, they tested laser versus needling versus placebo on the mastication muscles, and they found that low-level laser therapy was more efficacious in reducing the pain intensity. So that brings me to my advantages and disadvantages. So LLLT definitely improves the functional outcomes and reduces pain on a short-term basis. So it can be used as a complementary therapy. It has no side effects, and but however, it's a double-edged sword. There's no standardization of these laser parameters, so we don't really know what to do. And long term, it did not show any significant advantage over the other therapies, and a large loss of follow-up was reported in a lot of these studies. So, to conclude, scientific literature does not give us a conclusive evidence regarding the reduction of pain, and hence all the results and conclusions derived from this research are still debatable. So, further studies on a large sample size and double-blinded trials on a larger sample size will help us to determine the real efficacy of low-level laser therapy in pain reduction of temporomandibular disorders. Thank you so much for your time. These are my references.
Yeah, thank you, Dr. Lisa. Very well timed lecture, I would say. Dr. Rathi and Dr. Das, do you have questions for Dr. Lisa?
Yeah, I just have something that I would like to add on to what Lisa has spoken. It was a good presentation, Lisa. You summed up it very well. But I think so the crux of this entire thing is to diagnose that TMD pain.
Yes,
You
sir.
know, what sort of pain it was, because when you're targeting with a low laser therapy, it's very important to know where we have to direct the laser, whether it is coming from the joint or from the muscles, or
Yes,
there are
sir.
some other reasons. So probably you need to work on that part a little bit more. Okay.
So that's what I mentioned. I wanted to show that's part of the disadvantages. There's a lot of laws to follow up, as well as at what parameters we should be testing and how to use lasers. That's still debatable. Hence,
Beyond that,
yeah.
beyond that, it is the diagnosis where the pain is coming from.
Yes, sir. Yes, sir.
You understand? I'm not talking about the laser usage. I'm talking
Yes, sir.
about where the pain is coming from
Yes,
is
sir.
more categoric. You have to be more categoric in that. You have to identify that more. Okay,
Yeah.
because most of the times what we are shooting it somewhere else and we feel the
Yeah.
laser therapy is not working.
Yes, sir.
Okay.
Yeah.
Anyway, thank you. Good presentation, dear.
Thank you, sir.
Well, I have a comment, if I may.
Yes, Dr.
Can you
T.
hear me?
Yes, Dr. T.
I just love the enthusiasm with which she has presented, and the fact that she had one slide on which she had put something, and then she said something to the effect that means she paid attention to the previous couple of presenters, and then she said it might not be true, but I'll adjust that later. I love that enthusiasm. This is
It's
the
about the
what year are you?
bruxism she spoke about.
Is that right? Okay. What is the level of education you have? What year is she
Dr. Lisa?
in dental school?
Dr. Lisa?
I'm not sure if
She's freezed. She's freezed.
Yeah,
Her
Dr.
video is
T.
freezed.
We probably lost.
Coming from you, she's free.
Hello, sir. Hello.
Yeah.
Hello, sir.
Yes,
I missed that.
Lisa,
I'm so
what year
sorry.
are
Could
you?
you repeat? Hello.
Which
Okay, I'll
year
be
of
quick.
post-graduation are you, is what I wanted
Here.
to know.
Hello.
Dr. Lisa, can you tell
Yeah,
me about your class year of education? What class are you in right now?
Ma'am, I just entered my final year of post-graduation.
Okay, so what post-graduation are you pursuing?
Oral medicine and radiology.
Dr. Davis Thomas was just praising you
Okay.
regarding the same.
Okay, thank you. So I'm so sorry. I have a bad network. I'm really sorry for that.
Dr. Thomas,
That's okay. We just were saying the enthusiasm you had in correcting one segment of a slide that you had based on your knowledge from the previous two sessions, or rather lectures. So we really appreciate that. And that is the first level of learning. So keep up the good work. That's all I have
Thank
to
you
say.
so much,
And thank
sir.
you.
Thank
Appreciate
you
it.
so much. Thank you for your lecture, sir.
Great. Thank
You're
you, Dr.
welcome.
Lisa.
Okay.
Yeah, the next speaker
Thank you,
to
ma'am.
here, Dr. Smriti. Dr. Smriti Golhar.
Yes, ma'am.
Yeah, can you, Dr. Lisa, can you stop sharing your screen? And Dr. Smriti, can you switch on your camera?
Yes, ma'am, I'm doing.
Yeah, your screen is visible. Go on a full screen mode.
Is it okay, ma'am?
Yeah, can you be a little louder?
Yes, ma'am.
Yes, yeah. Hold the mic near you. Okay, your time starts now, doctor.
Okay, ma'am. Thank you, ma'am. Good evening, all. Today's my topic is therapeutic evaluation of cervical dysfunction in patients with myofascial pain dysfunction syndrome, a prospective study. Under this heading, I'm going to elaborate my topic. Moving towards the introduction. Myofascial pain dysfunction syndrome is one of the most common cause of the chronic pains in the orofacial region. It is a highly prevalent condition. It affects up to 85% of the general population. 30 to 85% of patients would have true trigger points. The health impact of MPDS can be quite severe. Patients not only suffer from the decreased functional status, but also suffer from the impaired mood as well as decreased quality of life. As we know, it has many etiology, and the clinical features are mostly like pain in the TMJ region and muscle of mastication. There is limitation or deviation of the movements and sound. And because of this features, if the feature is persist, there is a pain viscous cycle which goes on. And we know this pain is a very radiating type of pain. So it involves some other regions like neck, shoulder girdle, and other region. So there is a documentation of interconnection between neuroanatomy and neurophysiology, and it affects on orofacial area. It is noted that the change in the craniocervical junction can alter the occlusion pattern and jaw position. It is also noted that the masticatory system can influence the position of the craniocervical junction. Thus, MPDS may lead to compensatory changes in the craniocervical posture and develop the neck pain. So the aim of this study was to find the therapeutic correlation between the cervical dysfunction and MPDS and to check for the relief from the symptoms of cervical dysfunction by treating myofascial pain with the 3 different modalities. So the study was conducted in the Department of Oral Medicine and Radiology, Ranjit Deshmukh Dental College, Nagpur, in collaboration with the VSPM's College of Physiotherapy and Department of Orthopedics, NKP Salve Institute of Medical Sciences, after obtaining the permission from the IEC committee. So we include total 46 patients in the age range of 15 to 60 years, out of which 23 patients having MPDS with cervical pain and 23 patients with only MPDS but no cervical pain. That is group 1 and group 2. Again, they were divided into 3 subgroups according to different treatment modalities, that is A, B, and C. All the patients in group 1 were also examined by an orthopedician to rule out any cervical deformity. So for the MPDS, we use the Laskin's criteria. There are some pictures to show the palpation of the muscle, that is masseter, temporalis, medial, and the lateral pterygoid. For the cervical pain, the pain and tenderness in the muscle of the neck region and the presence of pain on the following motions like flexion, extension, rotation were examined. And also the tenderness on the base of skull and the spinous process were also checked. The armamentarium used in the study is the digital vernier caliper and the helium neon laser with the VAS scale and the grade of muscle tenderness. So in subgroup A, the patient is asked to do the TMJ exercises, which include opening, protrusion, lateral excursion movements against resistance. For neck pain, exercises include for the strengthening of the neck and upper back muscles, and patients were advised to perform each type of exercises 10 times twice a day. And all the patients were guided and taught the exercises. Subgroup B, in this group, the patient were treated with the laser therapy, which was given in the 10 sessions for the 30 days, 3 sessions per week, that is alternate day, and each session for the 9 minutes. And the subgroup in subgroup C, we use the combination of both the therapies. Patients with the congenital anomalies of TMJ, history of trauma and other diseases causing TMJ pain, congenital or degenerative changes of the spine were excluded from the study. Moving to the statistics, this table shows the different parameters in both the groups respective to day 1 to day 30th. And in group in this the table group different both the groups and all the parameters from day 1 to 60th day, the difference between both the groups is shown, which is statistically significant except the range of mouth opening. In table 4, there is a region difference between the groups shown, which shows there is a statistical significant improvement in all the treatment modalities. The photograph of patient showing the mouth opening before the treatment and after the treatment. Moving towards the discussion, the term MPDS is used to describe the condition with the dull, aching, radiating pain associated with the tenderness of muscle as well as TMJ. Myofascial pain dysfunction syndrome causes mandibular dysfunction that generally leads to limitation in jaw opening, along with the deviation, presence of trigger point, and noises. This intimate relationship between the cervical spine and the masticatory system through the joint articulation, muscle attachment, and neural and vascular innervations is very well known. Nicholas et al., it is postulated that the posture of the cervical spine and electromyographic activity of the masseter and temporalis muscle is interrelated.
Vishal, mute yourself.
According to Srinivas et
Vishal,
al.,
mute yourself.
he found 50% of MPDS patients suffering from the craniocervical dysfunction. According to them, MPDS in TMJ region can be caused by the craniocervical dysfunction, and alternatively, craniocervical dysfunction can be caused by the MPDS in TMJ region. Akere et al. Showed that the cervical dysfunction may be one of the extrinsic etiological factors for the MPDS when they advised various physiotherapy modalities to the patient. In this study, 3 treatment modalities were used for both the groups, that is exercise, laser, and combination. Both the groups showed a significant improvement in all the parameters, although better response was seen when the laser was used either alone or in combination with the exercise. The efficacy of exercise therapy in reducing pain in MPDS and cervical pain, the MPDS observed in this study is similar to the observation made by the Nicholas et al. And the Melochetti et al. Azizi et al. Observed highly significant reduction in pain in the TMJ, but not in the neck muscle with the laser therapy. And they also recommended that if there is no relief from the pain and tenderness in the neck region, a longer duration of treatment and correction of head and neck position is required. But in our study, we found a significant improvement in neck muscle pain along with the TMJ muscle. Researchers observed significant pain reduction using laser therapy. The present study gives some evidence that by the treating TMJ muscle, we can eliminate the cervical pain as well. So I conclude the patient having cervical pain showed significant improvement comparable with the patients having no cervical pain. Hence, the conclusion drawn from that there is a positive interrelationship between the MPDS and the cervical pain. And MPDS may act as a catalyst for the precipitating the cervical pain. So cervical pain showed significant improvement to the physiotherapy in the form of exercise, laser, and combination treatment, though the effective modality was laser and the combination of both exercise and laser. The oral and maxillofacial radiologist and surgeon, dentist, as well as orthopedic surgeon should be aware of this association. These are my references.
Yeah. Thank you, Dr. Smriti.
Thank you.
Very well-timed lecture. And Dr. Das, Dr. Thomas, and Dr. Rathi, do you have questions for Dr. Smriti?
Yeah, I have a question.
Okay.
Ma'am, in your entire study, you said MPDS caused the cervical pain, right?
Yeah, yes, sir. It's a vice versa.
What was the cause of MPDS?
So there are so many factors.
So what were your elimination factors that you included? Did you check the occlusion? Did you see the other little
Yes.
factors? So
Yes,
that
yes,
was
sir.
not, you did not mention about it, ma'am, because that is very important that you have to categorize the MPDS before we say that MPDS causes cervical
Yeah.
pain.
I will do the correction, sir.
Sir
Recording in
Davis,
progress.
Dr. Davis, would you like to add something, sir?
I just have a quick comment for Smriti. The term MPDS, right? Myofascial, it's not facial, fascia, which is the tissue connecting the muscles together. So myofascial pain dysfunction syndrome, the previous terminology MPDS, in the latest orofacial pain, it's really redundant.
Absolutely.
We need to redefine either myofascial,
Dr. Vishal,
myofascial trigger
last
point.
warning, sir. Dr. Thomas, just a second. Dr. Vishal, can you mute yourself? Please. Yeah, Dr. Thomas, please continue. Very sorry, Dr. Thomas.
No, it's okay. It's just that we need to redefine it, and that is why these type of seminars, what you presented is fantastic, the way you have, flowed in. But like Ritin was talking about the prerequisites, have you rolled out any other factors? And plus, definition-wise, I don't really, I'm not sure if MPDS is the term that you might be using in 2025. You can use myofascial pain, myofascial trigger points. Define that a little bit, because Laskin
Absolutely.
and they published it, decades ago. So we need to really come to, and I strongly recommend you looking at RDC-TMD and DC-TMD terminology. If at some point this will get into a publication, and I'm a reviewer for a lot of journals, I would love to see DC-TMD or RDC-TMD, one of those, and you can follow the criteria. That's only my suggestion for a future reference
sir.
as well. And thank you. Nice.
I'll do so. Thank you.
Wonderful
Do the
clinical
correction.
work, doctor, to take home. Yeah, we have our next presenter, Dr. Altaf Malik. Dr. Altaf, are you there?
Yeah, ma'am. Yeah, ma'am.
Okay, can you switch on your camera, doctor? Others, please mute. Otherwise, I'll have to remove you from the Zoom link.
सभी वैसा कर रहे लोग देश में.
Dr. Akhtar.
Yeah, ma'am. Good evening. I'm starting my screen.
Yeah, share the screen, doctor.
Yeah, ma'am. Just good evening, everyone. Good evening for having me here. I'm just.
Your screen is not visible, doctor.
Oh, I can't understand. Is it visible now?
Yeah, it is. Can you share the presentation?
Yeah. Is it visible?
Yeah. Can you go on a full screen mode?
Internal drainment of TMJ, advances in diagnosis and management. That's a disclaimer. I have not received any funding from any source for the content I'm presenting. Temporomandibular joint is one of the simplest but the complex, because it is subject to vector of the forces. The unique features being simultaneous functional joint on both sides, extremely large force per unit area, and fibrocartilage were there, and teeth which resist restrict movement of TMJ, and they're subject to wear and tear. Internal derailment is just this classified. It is basically a term borrowed from orthopedic literature, and it is actually disarray between the disc and the joint, as simplified by International Association of Oral and Maxillofacial Surgeons. It is second.
We are unable to see your screen, doctor. We are unable to see your screen.
Oh, sorry. I'm sharing from my side. Is it visible?
We can only see a zoom.
Yeah. Oh, what happened?
Are there two presentations running in the same, two Zoom meets running?
No, ma'am. It's only one presentation running.
No,
So
through
you
Zoom.
shut down all of this, and just run your presentation. Please shut down all of this.
Because two Zoom meets are visible.
Yeah.
One minute, ma'am.
I'm stopping your time now. Just for seconds. बंद कीजिए. Zoom meet बंद कीजिए.
He has not shared the full screen. he needs to share the full screen. Altaf, please share the full screen. You have only please go back and rejoin. Share the full screen and device.
Is there Dr. Ansh also there? Ayansh? Is he sharing the screen, Dr. Ayansh? You were not permitted to share the screen. Please stop sharing.
Ayansh is not sharing.
No, there are two screens, doctor.
Okay, but we can't see. We can only see this master screen now.
Okay.
Altaf, is he back?
Altaf, are you there? Okay, now Dr. Ayansh is out. Dr. Altaf, start sharing the screen now. Now only one screen is there. Others, please mute yourself and don't share any screen till the time we give you the permission. You all will get permissions to present.
Altaf is logged out, I think.
Okay,
So.
can we get the next presenter, Dr. Sheikh Nahida Farhin? Are you there? Farhin, are you there?
He's back.
Can I come back?
Yeah. Okay, Dr. Altaf is there. Okay, start sharing the screen, doctor. We'll restart for you.
Yes, ma'am. Is it audible?
It is audible. Dr. Ratindas, can you see the screen now?
Yeah, we can see.
Okay, continue.
The clinical features, sir, sorry for this, or pain, limited mouth opening, clicking, crackling sound, otalgia, tinnitus, neck pain, and decreased efficiency of the chewing. These are some of the, like we start with the normal, then go clicking, sometimes locking, then full lock, and then full bony changes. I'm not going into pathology, that is between interplay of the inflammatory meters, wherein we get, how do we diagnose? Usually it is clinical examination, tenderness with the joint, Mahan's test, deviation to the affected side, normal ipsilateral movement, decreased contralateral movement. And we always start with the blood test in the form of PCR, CT, CRP, plain radiograph, CT, and MRI. MRI is actually standard for the disc. And to correlate the findings, it is always to be supplemented nowadays with arthroscopy to arrive at the conclusion. So it can be in the form of diagnostic blocks to rule out any pain over there, exam under anesthesia, arthralgia, myalgia, and mouth opening. So pain in hypermobility can be due to the disc displacement, cyanides, myalgia, and disc displacement can be with reduction, without reduction. I'm not going into this classification now. MRI is considered to be as a gold standard for diagnosing internal derangement of the joint, and it has to be obviously supplemented with other. But is MRI conclusive? No. It has been found that even in MRI, which has actually shown a displaced disc, but the patients were not having any clinical features for the disc displacement or in the form of pain or limited mouth opening. So there comes the role of arthroscopy, which is always done under a general anesthesia to look out for the changes in the disc. And it is advantageous. There is no significant incision or facial scar. There is reduced incidence of nerve injury. And it is diagnostic as well as therapeutic also. We can carry out the large and do certain procedures to reduce the decreased mobility or increase the mobility. The agreement between arthroscopy and MRI is poor, which means when blinded to clinical scenario, the MRI and arthroscopy can lead to different conclusion. What are the other aids is USG, EMG, and T-scans, orthography, and CBCT. But diagnostic endeavors cannot be one size fitting all. Exemptions can be minimized if we expand. What are the treatment? The goal of the treatment is to decrease the joint pain, increase joint function, and increase the mobility. And as per American Association of Oral and Maxillofacial Surgeons, this is the goal: mild or no pain with vast pain score less than or equal to 3, or maximum mouth opening greater than 35 after 12 months of treatment. Now, how do we treat? We start always with the conservative measures, minimally invasive, and the invasive ones. Conservative measures are always limited to diet in the form of analgesics, physical therapy, TENS, low laser therapy, interforces, trigger point injections, and stress reduction therapy, or doing some occlusal reductions or But here comes the role of that can patients be treated by minimally invasive measures? Obviously, in the form of injections, steroids I don't prefer, NSAIDs, intra-joint I don't prefer, hyaluronic acid I prefer in the older age group, PRP, autologous bullet prolotherapy, dry needling, and the Botox. Now, minimally invasive therapy can be in the form of arthrosynthesis and arthroscopy, which we do in stage 2 and stage 3 of the disease. Arthrosynthesis is done simply by simple maneuver by 18 or 19 gauge needle, which are actually put in the joint at specified points to promote the lavage. We have done a patients, 100 patient study wherein we have done conventional arthrosynthesis, and we compared it with the guided arthrosynthesis with a CT scan manufactured splint for the needle insertion. And what we found that there was significant reduction of the pain and increase in the mouth opening. But if we compared this computer-guided arthrosynthesis with the conventional arthrosynthesis, we did not achieve better results, and conventional arthrosynthesis gave the same results as the computer-guided arthrosynthesis, which actually used specific landmarks for the needle insertion for the injection. And this is already published in the PubMed journal, this study about the arthrosynthesis. And this is in the Journal of Plastic and Aesthetic Research that this. Now, coming down to intra-articular injections, which can be in the form of PRP and other things. PRP obviously has potential healing properties on new bone and cartilage through the recruitment, proliferation, and migration, differentiation of cells, and tissue remodeling and anti-inflammatory in this. Arthrosynthesis and PRP, it has obviously a double advantage by flushing out the inflammatory mediators and promoting the natural healing. Now, do we do arthrosynthesis by single and double needle arthrosis? We do both the things at my center, but we found that there is no significant differences in the two techniques, whether we do it by single needle or double needle. The single needle had the ports in the injection and ejection ports into the same needle. Now, coming down to arthroscopy. Arthroscopy nowadays is considered the golden standard to treat the redundant internal derailment of joint disease, which is actually non-responsive to minimally invasive procedures. Thus, open joint surgery, we obviously come to a stage wherein there is no relief from all these, and all these measures get exhausted, as in this case, and then we had to actually go for condylar shaving and do the disc repair. So, is there any scope for TMJ joint replacement? Obviously, when the joint is destroyed, when the inflammatory mediators and the remodeling is deficient, then obviously there are failed treatments. Then we can resort to TMJ, TJR, or total joint replacements, which is actually lost result for this. So now, what we exactly have a disorder wherein there is not much consensus as it, though there are so many theories suggested, but it still needs and attention in the form of that we always have to start with the conservative measurement. But in our studies, we found early arthrosynthesis had better prognosis as compared to delayed procedures. So we conclude that no procedure is fully curable for internal derailment. We should start with least invasive first. Arthroscopy and MRI needs to be nicely calibrated for following surgical parameter internal derailment. Early intervention has better prognosis. Patient-specific treatment is desired. Thank you very much.
Yeah, thank you, doctor, for this timed lecture, I would say. Initial glitch was not taken into account. Dr. Das and Dr. Thomas, do you have any question? And Dr. Rathi, if you have any question for Dr. Altaf?
It's okay, I think so. I'm okay.
Okay. Dr. Thomas, do you have any question for him? Okay, I think, and Dr. Rathi?
No, Auntie, I'm fine.
Dr. Rathi? Okay, we continue with the next presenter, that is Farheen. Are you there, Dr. Farheen? Dr. Altaf, can you stop sharing your screen?
Yeah, sure, ma'am. Sure, ma'am.
Request to everybody that mute yourself, and as soon as your presentation is over, stop sharing the screen. Dr. Farheen, are you there? Dr. Puneet Vora, are you there?
Yes, ma'am, I'm there.
Who is this? Farheen?
I'm Dr. Punita, ma'am. Good evening.
Yeah. Okay.
Yeah.
Punita, can you just switch on your camera as well as your...
So Nahida is not there, right? Nahida is not there.
Yeah, she didn't come.
Okay.
Ma'am, Am I audible? And
Camera is not visible, Doctor
I've
Punita.
switched on my camera, but I don't know why.
Okay, can you start sharing the screen at least first? We'll see that.
Yeah.
The camera access is not allowed. That's what is coming actually.
Yeah, let's maybe it's the Zoom setup.
Ma'am, my screen is available. Is
Yeah.
it? Can you see the screen?
Yes. Go on the full
Okay.
screen mode. Dr. Punita, category A. You know the time. Okay. Go on full
Yes,
screen.
ma'am.
Your time starts now, Doctor.
Okay, so good evening to one and all present here. Here, I have been hearing you and such insightful sessions. I'm privileged to hear all of you. Now, today I'll be presenting my original research on evaluation of efficacy of platelet-rich plasma in management of trigeminal neuralgia, which is a case-controlled study. The study was done in SGT University, Faculty of Dental Sciences. Now, trigeminal neuralgia, as we all know, for our undergraduates and postgraduates who are present here, it is also known as tic doulorex. The prevalence of this disease is 0.16 to 0.3%, not that high, but it is a highly debilitating disorder and is characterized by recurrent, unilateral, very brief but very painful electric shock-like lacinating pain episodes. The distribution of trigeminal nerve is affected, specifically mandibular, maxillary, and ophthalmic branches. A trigger zone, which is a pathogenomic of trigeminal neuralgia. In contrast to myalgia, where we have trigger points, we have trigger zones in neuralgia, which are exceedingly tender zones on face or in oral cavity that produce local and referred pain when stimulated, even very lightly. Even on the breeze of air or just by touching or smiling, suddenly the pain shoots up. Now, regarding PRP, why I'm talking about PRP in case of neuralgia, not that PRP is in all the sectors, starting from aesthetics to orthopedics to neural regeneration, but specifically why I'll be talking about PRP in patients of neuralgia is that it has very profound analgesic, anti-inflammatory effects, and also it has multiple growth factors which are necessary for the neural regeneration of the myelin sheath. Now, the traditional treatments which the patients have been taking till now, like carbamazepine, lamotrigine, baclofen, or some surgical interventions and other modalities, but these patients, they always seek for alternative therapies due to the side effects or insufficient relief caused because of the medications. Also, the patients are not so compliant that on daily basis that they keep on taking the medications. Hence, PRP, which is derived from the patient's own blood, has no properties of causing the allergy or causing any kind of reactions to the patient, has gained attention for its potential regenerative as well as analgesic properties. In most of these studies available in the literature, now this is the rationale for my study, that in most of these studies which are available in the literature, the PRP injections were aimed at achieving symptomatic as well as functional relief in muscle injuries, inflammatory conditions. However, to my knowledge, no study on trigeminal neuralgia are available in the literature till date. Thus, the present study was designed and to judge the efficacy of PRP in the patients of neuralgia. Now, going ahead, how I did the study, the patients who were coming to the OPD of the dental college were enrolled in the study. Ethical clearance was taken from the ethical committee of the university. A detailed case history of all the patients, including the medical history of the patients, were recorded. A clinical diagnosis of trigeminal neuralgia was made based on the diagnostic criteria of International Society of Headache, which I'll be showing you in further slide. All the odontogenic causes of pain were ruled out specifically by taking OPGs, whether any tooth is affected or there is some ulcer, some pathology related to the floor of the mouth, oropharynx, palate. The thorough examination was done to rule out and come to a diagnosis of trigeminal neuralgia. Extraoral examination, proper auscultation of the TMJ joint, all the pathologies related to the muscles and the TMJ joint were also ruled out before enrolling and diagnosing the patient with trigeminal neuralgia. Now, this is the criteria which we followed according to the International Classification of Headache Disorders. Based on this, we had enrolled the patients for neuralgia. The VAS scores and the trigeminal neuralgia symptoms for the orofacial pain subjected to the patients were noted. Now, the
You got muted. We can't hear you.
Punita?
Punita?
Dr.
I
Punita,
think
for some reason we cannot hear you.
so she's freezed. She's freezed.
Okay. Yeah, no, she's logged out also. So
Yeah.
it was a good presentation, but unfortunately we have to stop it.
Presentation.
Okay. Dr. Bangar, are you there?
Yes, ma'am. I audible?
What was her sample screen?
Dr. Punita, yeah, I think she's back. We'll give her a time. I have stopped the
Yeah, yeah.
volume. Yeah, we'll give her 2 minutes more.
Yeah, yeah.
Dr. Punita, you have 3 minutes now. I know you're rejoined, but start. Dr. Punita, you're not audible. Dr. Punita?
Am I audible now?
Yeah.
Yeah.
Now stop sharing your screen, dear.
I'm so sorry for the glitches.
Yeah.
Now, in group 2 patients, ma'am,
Go
the
to full screen.
carbamazepine
Go to full screen. Go to full screen first. Yeah.
was given along with PRP. This PRP was given once in 3 weeks for 3 months, and we kept a follow-up of 6 months. The PRP was produced just by using our regular procedure through the centrifuge machine, in which we used a machine of 220 volts, 50 hertz, 5 speeds regulator, and a hard spin was done, and the best of the platelet was supernatant plasma was taken, and this plasma, this PRP, was introduced into the trigger zones wherever the patient was telling that he has a trigger zone. Using a 25 gauge noodle and 1.5 inch diameter, the PRP was injected, and the follow-up was done for 4 weeks along with a 6-month follow-up. Now, the results were astonishing. These values were highly significant. With the help of PRP, we found out that the patient has 70% relief. The patients who were taking PRP with carbamazepine had 70% relief in the frequency of the episodes as well as in the pain. Also, the patients' VAS score were recorded. The results were again highly significant. In the group 2 patients, the subjects were having less pain episodes, lesser pain, and the conclusion of my study is that the encouraging results in this baseline study should prompt a clinical trial or more number of neuralgia patients to broaden the therapeutic usefulness and application of this novel modality. In future prospects, we should be developing more standardized protocols for developing consistent preparations and the treatment methods with more focus on elucidating the PRP's pain relief related to the nerve mechanism. Thank you.
Okay, doctor. Though we could not see you, but thanks for
Yeah,
the presentation. Dr. Thomas, I'm sure you have some questions for her.
मम्मी
Yeah.
सुमिश्रा बोलोगा
Oh, who's talking? Okay.
I think the little one started talking.
Yeah, Dr.
He
Thomas.
probably will answer.
Yeah, Doctor.
Hey, can you hear me?
Yeah.
Yes, sir.
Okay. Trigeminalgia is paroxysmal, right? It is comes and goes. It's
Yes, sir.
episodic.
Right.
Yes.
Right.
So the key to it, and if you're doing this as a study to be published in highly peer reviewed, you need to do some few things. Number one, patients should not tell you where the trigger zones are. You should be the one eliciting the trigger zones and marking it.
Right.
That's number one. I mean, if you really plan to take it to the next step. Number two, you need to have controls, right? You have to have really high level controls. But the problem is you don't get too many trigeminalgia cases. So the control for me would be, let's say 10, 100 patients with trigeminalgia, similar ones, classic trigeminalgia, no secondaries, but that is not mentioned here. So let's say there is no brain tumor, cyst, nothing like that, no MS, no Lyme disease, none of that stuff. And you're
Right.
just, idiopathic, classical, trigeminal neuralgia, different terminologies, but same thing. And then you need to have, you're injecting CRP, that means you need to compare it with something else.
Right,
And one
sir.
of the things I would inject with is, number one, to compare it is with lidocaine. And the other one should be normal saline. And the patient should know, the control patient should know that, this might be a placebo or an actual drug. And the
Right,
fourth
sir.
control I really want to use is do nothing, right? Do nothing. Or give a
Right, sir.
placebo pill.
Right, sir.
Because you're combining PRP with carbamazepine or PRP alone, it's a big basket of apples, oranges, bananas, and everything is in there. You need to
Right,
have
sir.
a pure beginning and then multiple controls that will be more predictable results.
Right, sir.
And I think that will be, if you're trying to publish this in a high-end journal, that will be a
Right, sir.
real fundamental flaw. You have to have standardization, you have to calibrate, and you have to define things, and you have to have absolute high-end controlled groups. That's
Right,
what I
sir.
said. Nicely presented, but I think if you're trying to publish this right
Right,
from the
sir.
beginning, it will be fundamentally flawed because of these.
Right, sir.
But the presentation is fantastic. It's really good. You've done your homework. And
Thank
I
you
think
so
that
much,
was the
sir.
little one that we heard in the background. How old is
Yes,
he or she?
I have a small daughter, right, sir?
Okay.
She
So
was
tell
banging
her
the
we all
door.
say hello.
Yeah,
In
thank
every
you
one of
so
my
much, sir.
programs, there's some kids showing up. Okay. Enjoy the rest of the day. Thank you.
Great.
Thank
Dr.
you so
Purita,
much, sir.
thank you, Dr. Thomas. Okay, Dr. Purita, can you stop sharing your screen, dear?
Yes, ma'am. Yes, ma'am.
And do we have Dr. Bangar with us? No. Dr. Vasudha? Okay, Dr. Vasudha, can you switch on your camera? And can you be a little louder?
Yes, now am I audible?
Yeah, but your camera is not visible. I can just see a white screen. So, okay, start sharing your screen, dear.
Okay. Okay.
Go on a full screen mode, doctor.
Yeah. Is it in
Yeah.
full screen now?
Yes, your presentation time starts now.
Good evening.
Dr. Vasudha, you're not audible. Your voice is cracking, maybe.
Am I audible now?
Yes, hold the mic the way you're holding it now and then start.
Okay. So I'm here to present my paper titled Sleep Tight, White Right, an evidence-based study of treatment outcomes for oral bruxism devices.
Can you hold the can you hold the mic little bit closer to you and don't move too much?
Yeah. Okay. Sleep bruxism is
Doctor, your voice is really bad, feeble.
Okay, then can you ask the next presenter to present? I'll
No,
be
this is
back with
okay.
another.
When you start presenting, only the voice goes off. So this is okay. The way you're holding the mic now is better. Present
Okay.
for a second in the same way. We'll check.
Okay, now?
Yeah, it is better. Now continue, please.
Okay. So it affects both the sexes equally with a higher prevalence among young adults. The exact cause is debated, but recent studies suggest that it may be an excessive response to microaerosols during the sleep. So the widely accepted hypothesis is that the abnormal rhythmic movements seen here are due to central and autonomic nervous system. It is linked to tooth wear and orofacial pain, and in severe cases can cause tooth fractures and damage to dental restorations. It can disrupt sleep quality, and the Pittsburgh Sleep Quality Index is commonly used tool to assess the sleep quality. Currently, there is no definitive treatment. Various methods have been employed, ranging from reversible occlusal therapy to pharmacological treatments. Among these approaches, occlusal splint is the most prevalent method. Numerous studies indicate that occlusal splints significantly decrease the sleep bruxism motor activity index. Two common types of occlusal splints available are the maxillary occlusal splint and the mandibular advancement device. However, the effectiveness of these splints in reducing the sleep bruxism motor activity and improving patient outcomes has not been thoroughly compared. Understanding this comparative efficacy among these devices is essential for developing an optimized treatment protocol for sleep bruxism. So the aim of this study is to systematically evaluate and compare the effectiveness of these devices in management of sleep bruxism and provide evidence-based insights to guide clinical decision-making and optimize treatment strategies. The objectives include to compare the efficacy of both the devices, to evaluate the impact of these devices on sleep bruxism motor activity, to assess any effects on dental health, to investigate the influence on patient sleep quality, to identify any adverse effects and patient preferences. Moving on to materials and methods, a systematic review protocol was developed with the aim to answer the following review question. In patients diagnosed with sleep bruxism, how effective is the mandibular advancement device compared to maxillary occlusal splint in terms of reducing sleep bruxism motor activity, improving dental health, and enhancing sleep quality? The study followed PRISMA recommendations and is registered in Prospero under the following ID. Inclusion criteria are as follows according to the PICO format: the population being adults and adolescents 12 years or older diagnosed with sleep bruxism, both male and female patients, the intervention being mandibular advancement devices, the comparison being maxillary occlusal splints, and the outcomes being reduction in sleep bruxism motor activity, dental health outcomes, sleep quality improvements, adverse effects, and patient preferences. The review focused on randomized controlled trials, cohort studies, case controlled studies, and comparative clinical studies. Only English language studies published in peer-reviewed journals within last 20 years were included. Additionally, only studies with full text availability were selected to allow for complete data extraction. This review excluded non-human studies, non-English publications, and studies with insufficient outcome data. Full case reports were not considered, and review articles without original data were also excluded. Although references to potential relevant articles were noted for further investigation. The search strategy was systematic and included multiple databases. A comprehensive literature search was conducted across databases like PubMed, Cochrane Library, Embase, Scopus, and PsycInfo using Boolean operators to refine the results. Searches were customized for each database using relevant keywords and studies covering studies published from 2004 to 2024. The complete search strategy is summarized in this table. Both the selection of articles and data extraction were conducted by an author and reviewed by another. So any disagreements regarding study inclusion were resolved through discussion and consensus. In cases where data were incomplete or unclear, emails were sent to corresponding authors for clarification. The extracted data included the following details for each study, that is the study characteristics, the splint characteristics, and the outcome data summarized in the table here. All the included studies are randomized controlled trials. So Cochrane risk of bias tool was used to assess the risk of bias, and the grade assessment was done to evaluate the quality of evidence. Moving on to the results, following PRISMA 2020 guidelines, we conduct a rigorous selection process. Initially, 1119 records were gathered from databases along with 8 additional sources. Difference manager tool Zotero was used to remove duplicates, 187 duplicates. This left with 940 records to screen, with 112 reviews excluded for not meeting our criteria. From 828 full text articles assessed, 823 were excluded for reasons such as misalignment with our focus, irrelevant outcomes, non-relevant interventions, or insufficient evidence from case reports. This comprehensive process resulted in 5 articles that met all the inclusion criteria. 5 randomized trials published between 2004 and 2024 in English were included in the systematic review. The sample size ranged between 12 to 28 participants, and 2 primary interventions, that is mandibular advancement device and maxillary occlusal splints, were evaluated over the duration of 2 weeks to 3 months. The key characteristics of the included studies were independently reviewed by 2 authors, and detailed study characteristics were presented in the table. According to the Cochrane risk of bias tool, 2 studies, Laundry et al. And Singh et al., were rated as having low risk of bias, whereas Franco et al. Was identified with high risk of bias due to issues in randomization and intervention adherence. The remaining 2 studies by Schonbeck et al. And Kara et al. Were characterized as having some concerns. According to the grade assessment, study by Laundry et al. Highest quality rating with minimal bias. Studies by Singh et al., Schonbeck et al., and Kara et al. Had moderate quality ratings, and Franco et al. Was rated as low due to concerns over high risk of bias and moderate inconsistencies. These are the results for primary and secondary outcomes. The primary outcomes, the sleep, bruxism, motor activity, and dental health. In these both, the mandibular advancement devices showed a statistically significant reduction when compared to that of maxillary occlusal splints. Whereas in case of improvement of sleep quality, both the devices had equivalent results with no statistical significance. The outcomes in adverse effects, the mandibular advancement devices were associated with mild adverse effects such as temporomandibular joint discomfort and hypersalivation, whereas maxillary occlusal splints were better tolerated with higher patient preferences and comfort levels. Moving on to the discussion, sleep bruxism involves clenching or grinding of teeth during sleep, leading to dental and sleep-related complications. It is a significant concern in clinical practice due to its adverse effects on dental health, including tooth wear, fractures, damage to restorations, and orofacial pain. The prevalence spans over all age groups with varying etiologies linked to central and autonomic nervous system. A wide range of treatment modalities are available, ranging from behavioral therapy to occlusal appliances. The two primary devices employed most commonly are mandibular advancement device and maxillary occlusal splints. The mechanism underlying the effectiveness of these two devices are distinct, with each device offering different benefits based on the unique needs of the patient. The mandibular advancement devices are believed to work by advancing the mandible, which stabilizes the upper airway and reduces the microaerosols. So by holding the mandible and tongue in a forward position, these reduce the collapsibility of soft tissue. This dual mechanism of airway stabilization and muscle activity reduction accounts for superior reduction in sleep bruxism seen in mandibular advancement devices. In contrast, the maxillary occlusal splints operate by providing a physical barrier between the upper and lower teeth, which redistributes the occlusal forces and reduces the strain on jaw muscles. By preventing direct tooth contact, this helps reduce damage from grinding and clenching without directly influencing the airway. So their lack of airway involvement might limit their effectiveness for patients with severe sleep bruxism. Despite the widespread use of these devices, there is considerable uncertainty regarding their comparative effectiveness. Several studies and systematic reviews have compared the efficacy of various types of splints by different, such as rigid and semi-rigid splints made from different materials. But there is a lack of systematic review specifically comparing the effectiveness of maxillary occlusal splints and mandibular advancement devices. Furthermore, there are only few randomized controlled trials that directly compare these two interventions. To address this gap, the present review aims to evaluate and compare the effectiveness of these devices in managing sleep bruxism. By systematically analyzing the available evidence, this review aims to clarify few. This systematic review evaluated 5 randomized controlled trials involving 82 participants, and the findings are as follows. They are effective.
Time is up already. So can you just conclude within 30 seconds? I'll give you 30-second leeway.
Yeah. So to conclude from the systematic review, the mandibular however, higher comfort and fewer adverse effects associated with the maxillary occlusal splints made them an effective alternative. The choice should be individualized considering each patient's unique needs, severity of the disease, and the tolerance for specific devices. So these are my references. Thank you.
Yeah, thank you, doctor. It was a good presentation. Wish we could see you also. Anyways, can you stop sharing the screen? Dr. Thomas,
Yeah, sure.
do you have questions for Dr. Vasudha?
Yeah, I probably have several, but we'll, in the interest of time, we'll have limited. Vasudha, can you hear me?
Yes. Yes, sir. Yes, sir. I can hear you, sir.
All right. Question is, so the inclusion criteria is, diagnose sleep bruxism, right?
Yes, sir.
You need to define how do you diagnose the sleep bruxism. You hear me?
Sir? Hello?
You need to define.
Yes, sir.
You need to define. I mean, if this is a systematic review,
Yes, sir.
I'm not sure if there was a meta-analysis, but systematic review.
Yes, sir.
How did you identify? By the way, diagnosing sleep bruxism, that concept itself is changing. All right, sleep bruxism, you diagnose a disease. Sleep
Yes, sir.
bruxism is not considered currently, 2023, 24, 25, as a disease. It's not.
Okay.
So it's like saying, I can diagnose fever. Can you diagnose fever? No, you can't diagnose fever. Fever indicates something else. So sleep or awake bruxism or a combination of both can can be the presenting thing of something else that we know, or a
Yes, sir.
protective measure. That's what some of them say.
Yes,
Latest
sir.
research, right?
Yes, sir.
So first, you need to describe and define how did you determine inclusionary criteria for the patients. In other words, who is a bruxer? How did you define it? Did the patient just report it? Or the patient's 12-year-old, 13-year-old, 14-year-old, the parents report it? If that is true, then how many parents even pay attention to their kids' sleep?
Yes, sir.
So that step, you need to really go back and clarify. Publication anywhere is one thing, but I think that will be a fundamental problem here is how did you diagnose? And you can look at the data and go back and do it. That's not a problem. If
Yes,
you
sir.
have a
Yes,
set of data, you can
yes,
go
sir.
back and you can find out, reconfirm those. But without the definition, it could be awake bruxism. I could be bruxing in sleep. A third
Yes, sir.
person could be bruxing in both awake and sleep. And
Yes,
the
sir.
fifth one has no tooth-to-tooth contact at all. They're just bracing. Look at the publication by Daniel Manfredini, and of course, I was co-author, and I was a reviewer for their newest one, STAB, STAB. Please look into that.
Yes, sir.
All right.
Yes, sir. Sure, sir.
Again,
Sure.
you have the potential, nicely presented potential for higher, but I would redefine the foundation. Without a foundation, the building is useless. So
Yes.
the
Yes.
foundation is, how did you diagnose, how did you define a bruxa?
Yes, sir. Yes.
Okay.
Sure, sir. Yes,
All
sir.
right. Thank you.
Thank you, sir. Thank you.
I'll just take 1 minute. I'll just take 1 minute of, I know we're running short of time, we're going quite delayed.
Yes, sir.
Dr. Vasudha,
Yes, sir.
you are from Geetam Dental College, right?
Yes, sir. Yes, sir.
You all were co-host for the IPS conference at Vijayawada.
Yes, sir. Yes, sir. Yes,
Were
sir.
you there for the conference?
Yes, sir.
Did you attend Dr. Rangarajan's lecture?
Sir, unfortunately, I didn't attend, sir, because we
You
were
should
on.
have. You
Okay,
should
sir.
have.
Okay, sir.
He has
Yeah.
totally demystified what you have spoken today. And that's
Okay, sir.
exactly what Dr. Davis is telling. I went back to his slides. I was looking at all my slides when you were talking because he
Yes, sir.
redefined the entire thing exactly today what Dr. Davis has said. Dr. Ranga is a wonderful person. We all know him. I'm sure you know him, ma'am. We
Yes,
need
sir.
not tell you about Dr. Ranga.
Yes,
The
sir. Yes, sir.
presentation was not to be missed.
Okay, sir.
I
Unfortunately,
have told people who did not go to the conference that they missed something because they missed Dr. Ranga's lecture.
Yeah,
Rather,
okay.
I told Dr. Rangarajan after his lecture that, sir, I would be coming back to you to know more about all that you spoke. And Dr. Davis is there. He knows. He spoke so much about Ranga highly. Sir is a big mentor for all of us, sir. And
Yes.
Vasudha, you should have listened to his lecture. You would have changed your presentation today before you come, because what is sleep bruxism and what is awake bruxism is what we need to understand before we talk any systemic review on bruxism.
Yes, sir.
So
Yes, sir.
let me just sum it up with that. Thank you so much, Davis, sir,
Thank you,
for
sir.
giving us Dr. Ranga also.
Sure, he's fantastic. And he's taken the fellowship and the master's before. Vasudha, I would recommend you look into that type of a course where Divya, Sonal, and Sanvi, all of these folks have gone through it. I'm
Sure,
going to
sir.
grind your brain from hour number 1 to 150 hours. Seema, I'm seeing you right now. I didn't see you before. I'm just sorry. Oh, and say hello to Akshay for me too. I'm going to mute myself. Maybe going downstairs in like 15 minutes or half an hour.
Yeah, we have a next
I'm going to mute
presenter
myself.
who is also Dr. Davis Thomas's student, Dr. Deepika Jerome. I'm sure Dr. Thomas will remember her. Dr. Deepika, are you there? Dr. Deepika?
Hi, Deepika. She's also a presenter here,
She's
right?
there.
One of
No,
your faculty.
she's there, but no, I have, she's a paper presenter, Dr. T. Dr. Deepika, are you there?
Yeah, she's there.
Also, okay.
Yes.
Deepika, please go. She's freezed again. I don't know what is happening today. I think so. The winters
Deepika,
have.
you're unmuted. Say hello. No, you're not audible. That's all.
The
There's a
winter has caught up.
disconnect.
The winter has caught up everyone.
Dr. Mrinal, are you there? Dr. Mrinal Shetty? Dr. Deepika?
One thing was, Deepika is asking for a minute. Please give her
Yeah,
that minute.
we'll give her a minute, and that's what I'm seeing. The next speaker also, they need to be there because the clinical pearls of wisdom, what everybody is receiving today. Dr. T, this is like a lecture for us, like, again it's like a
I
revision.
feel like I have a batch here that I have to
Yeah,
lecture to.
and Dr. Ranga is ghosting us all because ghosting as in he's always there, present there. His
But
blessings are
Dr. Davis, I must tell you, I heard Dr. Ranga and he totally, he has motivated me to go into your course. Let me tell you, I'm seriously looking into it. But there's a fight between me and my wife who would like to join your course. So then the fight is between both of us.
Oh,
so
by the way, we have like people like Akshay and Seema, they all joined together. I really recommend it because you can work together and something that is not clear you discuss. We have couples in every batch. Husband and wife, both dentists. I'm serious. So consider it strongly. Talk to Arlene. She'll come up with a good. Akshay.
See, I should speak to from there.
Yes. Seema and Akshay, the golden couple.
Hi, good evening.
Hello to you all.
Yes, sir. This was nice listening to you lecture again at the first session, and you're continuing with this. That's great.
Our presenter is ready.
I'm muting myself again and again because I'm on that ship.
Deepika, are you ready, beta?
I just docked in and it came an island. So I'm muting.
Yeah.
Seema and Akshay, where is my little hero?
Dr. Deepika would want to be the next presenter. So we will invite Dr. Bangar now. Are you there,
For
Dr.
his
Bangar?
peer Pochard certification.
Okay.
Dr. Bangar, are you there?
Yes,
Sanjuta
ma'am.
Yeah.
Sanjuta Bangar, please go on there.
Yeah. Please go ahead, share your screen.
Yes, ma'am.
Deepika? Is that Dr. Deepika?
No, this is
Also.
Dr. Bangar. Dr. Deepika will join.
Ma'am, my screen is visible?
Yeah, open your
Yes.
presentation.
My
Please
screen
on
is
your-
visible, ma'am?
Yes, we can see you.
Please open your presentation.
Okay. Yes, ma'am. My title of today's presentation is the role of magnetic resonance imaging in diagnosis.
Doctor, your screen is visible on, the presentation is not visible, but can you start your presentation? Click on the presentation slide.
Yes, ma'am. Ma'am, I'm audible?
You're audible here.
Yes, you're audible.
Dr. Das, can you see the screen? I am
Yeah,
just...
but she has to go and click on that
Yeah, click on
presentation
that
of
orofacial pain. Yeah, click on that presentation. Is your screen
Yes, ma'am.
black or something like that? Just check that.
My title of today's presentation is role of...
Madam, your screen is not visible, as in your presentation is not visible. Do one thing, go back and share the screen again. Then only I'll start the time for you.
Yes, ma'am.
Stop sharing first.
Stop sharing now first.
Dr. Bangar, you just open your presentation and minimize it, and then you go to the Zoom and open it. You will be able to share your screen.
Yes, sir.
I think Sonal, if one of you can help her stepwise, like click out of everything, like all the screens.
Yeah, that's...
The
You
team
want
is
to click out of everything.
The team is talking to.
Okay, X out of everything.
Just log out of everything. Whatever is seen on the screen.
Everything.
Yeah, and then re-enter through the share screen mode.
That's it.
Right. X out of everything.
Yeah, that's
And then
it's an Indian.
click on the green arrow.
Yeah, click on the green arrow now. Okay. The next
And then
speaker.
whatever appears on the upper left side, just double click on that.
Then you'll
We
be on
could,
your shared screen.
Yeah.
and we can finally see Vasudha.
Oh, Vasudha is here.
No, I can see her
Okay.
her
Dr.
DP.
Deepika will join, and then Dr. Mrinal Shetty, be ready with your slides. Now Dr. Deepika has joined.
Yeah, am I audible, ma'am?
Dr. Sayojita?
Deepika, wait 1 second. Sanjota is sharing her screen now.
Deepika, you can mute yourself.
Go up and start the slideshow.
So my screen is visible?
Yes. Start
Yes.
the slideshow. Full screen.
Okay. Hello?
Can you go to the full screen mode, madam, first?
Go to slideshow and start your slideshow. Yeah, that's
perfect.
it.
Okay, your time starts now.
Yes, ma'am. My title of today's presentation is Role of Magnetic Resonance Imaging in Diagnosis of Temporomandibular Disorder. First, aim to investigate the role of magnetic resonance imaging in assignment of temporomandibular joint disorders. Introduction. First, the clinical and imaging examination of temporomandibular joint to resonance imaging, computer tomography, cone beam computer tomography for the diagnosis and management of temporomandibular disorder. MRI. M means that is a require the magnetic field. Resonance means the interaction between magnetic field and radio frequency wave, and imaging to make the image. This is use the technique to because it is a non-invasive technique gold standard in imaging soft tissue component of EMG. MRI is not only used to evaluate the articular in term of location pathology, but is also determine the sign of temporomandibular disorders and persistent joint effusion. Joint means there is a two points are attached the purpose of motion of body parts.
Dr. Bangar, hold on for a second.
Yes, ma'am.
The next screen is not visible. Only the first screen is visible. Yeah, keep clicking on the next screen. Yeah. Yeah, continue.
Yes.
Continue.
Can visible. Okay. Then the chief patient came to the OPD. Chief complaint is patient that is a pain in temporal region, disruption in sleep, then jaw joint pain. Then we normal anatomical landmarks of TMJ. That is it image through the image that image through the TMJ evaluate the nerve tissue osseous anatomy, and this of signal and shape like that is a thin intermediate zones are present. In B diagram that is a T scan. T-scan that is a type of there is two T1 and T2 image. T1 means that is a fat image and T2 means that is a water image. Thus we see the second image that is a corona section of the TMJ. That T2 scan is open mouth position and this position between the condyles and articular eminence with normal range of translation of condyles. And we see the diagram C, the normal osseous anatomy of TMJ that is oblique sagittal reconstruction are present. Then first osteoarthritis. Osteoarthritis means inflammation of articular surface of the joint. Then chief complaint of this osteoarthritis that is inflammation of the TMJ. Then that is a first the radicular feature. First is diagram C that is sagittal of T1 weighted magnetic resonance image. It show the surface of irregularity of anterior slopes of the condyle head and is suggested as osteoarthritis. See the arrow and then first diagram and articular anterior displacement, and we see the B that is T2 weighted image of the same joint show the high signal intensity of condyle head is suggested as bone marrow edema, and it is note the fluid effusion in upper joint compartment. Management splint therapy, relieve the joint trace, NSAID to relieve the pain, and physiotherapy. Then rheumatic arthritis is autoimmune disease that result in chronic systemic inflammatory disorder that affect the many tissue and organs, but is principally attack the joint. They see the radiograph. It is a sagittal of magnetic resonance image. It show the displacing anterior, that is right arrow, and the left arrow is show the condyle with flat and erosion. Then juvenile idiopathic arthritis, it means it is characterized by it is a chronic and intermediate synovial inflammation that result in synovial hypertrophy, joint effusion, and swollen painful joint. See the radiograph. That is a first sagittal T2 weighted fat diagram, the scene A, and T2 weighted post contrast show the annual is C arrow, and in the arrow show the erosion changes at condyle head are also
So
evidence
Yojita,
on
can you
B.
stop for a
Management
moment?
analgesic pain.
Hello, can you stop for a
Yes, sir.
moment? I think you are
Hello,
one
sir.
slide behind what you're talking. You can take a breath. I know it's stressful sometimes. And then right now, you were talking about rheumatoid, but what we saw, everything was osteo. So go to the juvenile idiopathic. Okay, this is what you're going to talk about right now? Juvenile idiopathic?
Yes, sir.
Okay, go ahead.
Yes,
I'm going to
sir.
mute myself, all right? You can go slow because the quality is what you deliver, not the completion itself, right? So go ahead.
Okay, sir. Then septic arthritis of TMJ. This is characterized by septic arthritis means that is condyle destruction due to the sepsis of TMJ from the surrounding area. Then see the diagram. Septic arthritis TMJ lead to an epidural abscess. It show the fluid collection in right temporomandibular joint. Management in antimicrobial therapy, drainage of the effusion and rest of joint. Follow the physiotherapy. Then trauma induce the disc displacement and the arrangement. It is an abnormal relation between the disc
Change
of the
slide.
mandibular condyles
Change
and
slide.
articulinus.
Doctor, change slides.
Yes, ma'am.
Keep changing the slides. Have a sip of water and keep changing the slides. Yeah. Now speak.
Then trauma induce the disc displacement and dearrangement. It is a abnormal
the slides
relation
also.
between the disc and mandibular condyle and yes, sir.
अभय जाऊ दे काही नाही सर कंटिन्यू संसद आरामात जा तू स्लाइड बघ आणि बोल दोन्ही एकत्र जायला पाहिजे कंटिन्यू
Synovial chondromatosis of temporomandibular joint. This is a real condition which is characterized by persons of loose cartilaginous body due to the abnormal proliferation of synovial membrane. Radiographically, we see the diagram that is a hypotense loose body surround the hypertense joint fluid was detected on T2 sequence of MRI. And A is isolate the chondrophile loose body was detected using the arthroscopy surgery. Management is synovial membrane, loose body, all removed from the joint face in articular disc. Then osteosarcoma of the mandible, seen diagram that is a preoperative axial magnetic resonance image is left of mandible condyle has burr counters and tumor is expand into the adjacent soft tissue, seen arrow. Then chondrosarcoma, it is slow-growing malignant neoplasm that produce the cartilage matrix and it is the third most common primary malignant bone tumor after the myeloma and osteosarcoma. In radiographically, MRI T2 axial show the no recurrence of right of TMJ chondrosarcomas managed. In internal dearrangement, it is most common TMJ temporomandibular disorder of internal dearrangement, which is a mechanical interference of smooth joint movement. In MRI, internal dearrangement can occur due to the displacement of articular disc. Seen diagram with the mouth opening, the disc remain anterior displaced, has blur or fold appearance, and normal anatomy translation of mandibular condyle, resulting condyle with articular eminence of temporal bone. Then idiopathic condylar resorption. It is a poorly understood disease, aggressive form of degeneration disease of TMJ. Then it's radiographically seen in diagram A, that is sagittal density weighted magnetic resonance image in closed mouth position demonstrate anterior displacement of the disc in front of mandibular condyle. And see diagram B, that is sagittal density of weighted MRI in mouth opening, which demonstrate the reduction of the disc between the articular eminence and mandibular condyles. Discussion. Temporomandibular joint disorder, common disease in maxillofacial region and pathology not understood. Then magnetic resonance image is most popular or most commonly used method for imaging, examination, evaluation and diagnosis of TMJ, temporomandibular disorder, and it can show the condition of temporomandibular disorder well. Recent year, the application of bilateral TMJ in MRI in clinical practice has slowed a lot of scope in medical science. MRI is best modality for evaluate the intra-articular process. Conclusion. is the most common TMJ pathology, which can best evaluate the magnetic resonance imaging. The key of imaging finding on a magnetic resonance is a displacement with or without recapture. Other important but less frequently, TMJ pathology are osteoarthritis, idiopathic condyloresorption, inflammatory diseases, so trauma-related condition, tumors and tumor-like lesion. References. Thank you.
Okay, doctor. Yeah, it was a good content presentation. Just have a sip of water. You have done a good job. Only thing, your slides and your presentation was not in line. The slides were running a little slow. Okay, Dr. Thomas, do you have any question, or Dr. Das or Dr. Rathi? Please let me know.
I'm okay with it.
I don't
Okay.
have any questions.
Okay, Dr. Rathi, should we continue with the next speaker?
Yes, go ahead,
Deepika?
go ahead.
Yeah. Doctor, please stop sharing your screen. Dr. Bangar, please stop sharing your screen, dear.
Yes, ma'am.
Yeah, and Dr. Deepika, are you here now? Okay. Please start sharing your screen and unmute yourself, Dr. Deepika.
Yeah. Yeah. Hi everyone, myself Dr. Deepika Jerome.
The time starts now.
Yeah, myself Dr. Deepika Jerome, practicing general dentistry from 2010 in Apollo Dental, Chennai, and recently have completed my mastership in orofacial pain specialty under Dr. David Thomas. So today my topic is post-traumatic neuropathy. In that I'm just going to discuss related to its clinical features and pathophysiology and a presentation of a patient whom the diagnosis was made and management was done and general management and treatment modalities and key differences with traumatic neuromas and the conclusion. So regarding post-traumatic neuropathy, it is a unilateral or bilateral facial or oral pain followed and caused by trauma to the trigeminal nerve with other symptoms and other clinical signs of trigeminal dysfunctions. There are various classifications of neuropathic pains were there, nearly 13. Among the most common one are the trigeminal neuralgia, painful trigeminal neuropathies, and glossopharyngeal neuralgia and occipital neuralgia. In trigeminal neuropathy, there are various categories. The most common one is post-traumatic trigeminal neuropathy, which is caused mainly because of the dental treatment like placement of post implants and endodontic treatments and differentiation followed by the extractions, and also through viral infections and through the secondary causes like space occupying lesion. Switching over to the clinical features and pathophysiology of it, the mechanism of nerve injury. Once the physical trauma to the nerve fiber happens, the inflammation and oxidative stress will follow in the injury region, which causes changes in the ion channel expressions, which lead to the hyperexcitability of the nerves. And following pathophysiological events will happen like Valerian degeneration, ectopic activity like spontaneous nerve fibring caused by the damaged neurons, which left untreated will lead to the neuromas formations. And the sensory changes and the nerve dysfunctions with the patient usually experience will be the paresthesias and dysesthesias. And regarding the peripheral sensitization, increased sensitivity site at the site of injury, which will progress to the central sensitizations, which causes the amplifications of pain signals at the spinal cord and the brain levels. And moving on to the clinical features of it, the main quality of the symptoms, in the common symptoms, the main quality of the pain will be the burning and it of shooting and stabbing type of pain, and hyperalgesia and allodynia will be happening. Regarding the neurosensory deficit, the sensory deficit's numbness, which is a negative sign of it, and there will be a loss of sensation in the affected area. And with motor dysfunctions, weakness or paralysis of the muscle innervated by the affected nerves. If it is left untreated, the acute condition might progress to the chronic pain syndrome, which is a complex pain syndrome. What are the diagnostic criteria and the methods which is available in it? The clinical evaluations to be done with the detailed history of injury and the symptoms related to the trauma to be taken. Next, the physical and neurological examination to assess the sensory and the motor function of the particular nerve and the region. And regarding the diagnostic part, QST to assess the pain threshold and the sensory abnormalities. EMGs and nerve conduction studies to be assessed for assessing the nerve damage and the conduction speed. And the most gold standard diagnostic test will be the CT scan, which is useful in identifying the structural causes of the nerve compression where the implant placement was done. And general differential diagnosis will be like diabetic neuropathies and compression neuropathies or spinal cord injuries and multiple sclerosis. But most common will be the infections like herpes zoster. And now I'm just going to discuss about a patient whom she was diagnosed with PTTN, and the management was done. She is a 58 years old female patient of Indian ethnicity who's a homemaker, and she's a known diabetic and hypertensive and very anxious patient. And she underwent for chemotherapy for carcinoma of breast before 2 years, and these are the following medication she was under. And regarding her dental history on 24/7/23, we did under conscious sedation. The following procedures were planned, like flap surgery of the maxillary first and second quadrants and the mandibular anteriors, and extraction of wisdom teeth and implant placement were done in all the posteriors, mandibular posterior and first quadrant of maxillary. Posterior 17 is also done. These is a clinical pre-op and post-op photographs, and post-implant the CBCT sectional image has been posted. After the placement of implant, within 3 days, she complains of severe pain, and her initial symptoms were severe allodynia, continuous dull aching pain was there, and burning pain in the gingiva, and which was referral headaches and occasional shooting type of pain and mild numbness in the right lower region. So when I did a physical examination, the facial pain, which is more on the right side, and even the light touch provoked the pain were more predominant in the right V3 division of the trigeminal nerve. Sensory deficit was found in 7 regions, that is, which is involving the mental nerve, and our other cranial nerve screening were done, which were intact. On the diagnostic results, she was responding to a right mental nerve block, and with CT imaging, the implant was found very close to the nerve. So regarding her treatment modalities, initially I discussed with her physician and monitor her diabetic levels before prescribing her prednisolone for 3 days with a taper dose was given. And her pain was relieved within 3 days on observation in the follow-up visits. Her intensity of pain was reduced. Her VS score has come down to 1 to 2, but she accompanied of occasional numbness alone. So a topical application of GABAergic gel was given with the Neurostent for 2 weeks, and then after 2 weeks of follow-up and a review visit, a significant reduction in the pain level was achieved. And during a long-term follow-up visits, absolutely, that is after 6 months, her pain was absolutely nil. So what are the general management and treatment modality for PTTN? In the acute phase, the pain management will be the use of NSAIDs, opioids, and topical analgesias. And neuroprotective agents like antioxidant and corticosteroids may reduce the inflammation and the damage, and even followed by the topical application of GABAergic gel will help her to relieve from the symptoms. And to be reviewed or to check for if it is going for any chronic phase. If at all, if it is more on to a chronic phase, then to be started with the long-term pharmacological management with antidepressants like TCAs and SNRIs, and anticonvulsants like gabapentin, pregabalin, and opioids. If it is left untreated, then the interventional techniques to be followed like nerve blocks, spinal cord stimulation, and physical therapy and surgical options to be taken out, and definitely a psychological support is required. And regarding I always want to describe the 3 differences which I want to describe later to PTTN and traumatic neuroma. These are common points, which this is a nerve dysfunction due to trauma, followed by that, if it is untreated, it might progress to the traumatic neuroma, which is a localized nerve tumor or which is formed disorganized nerve regeneration after the injuries. And the mechanism will be the nerve damage due to leads to the dysfunctions. Here, the abnormal nerve growth will be there. The pain here will be the chronic pain, like burning and tingling and shooting type. Here, it will be a localized and sharp burning pain. And the symptoms will be the sensory loss, weakness, or motor dysfunction. Here, the main thing is potential numbness will be there over the traumatic neuroma region. And the treatment will be, as I said, drugs and pain management. Drugs will be prescribed here. Definitely, the removal of the surgical approach is required. The prognosis is good for the PTTN, but for traumatic neuroma, pain can persistent if the surgical intervention is not done. So, and regarding the region, it involves the entire nerve here at the injury site. So, this is my presentation related to PTTN, and my takeaway point is PTTN is a serious and often under-recognized condition that can lead to long-term pain and disability. Early and accurate diagnosis is crucial for effective management. And my sincere thanks to my mentor, Dr. David Thomas, for all the guidance and knowledge that he has given to me. And I just want to share the references. Thanks.
Thank you, Dr. Deepika. Well presented case. Dr. Ratindas, do you have any questions for Dr.
No,
Deepika?
it is a well covered presentation. Thank you.
Okay. Can we have the next presenter? Or Dr. Rathi, are you there? Do you have any questions for her?
It's well covered, well covered. We can go ahead.
Yeah, Dr. Thomas has left. I think he had to join somewhere else. Okay. So now the next presenter, Dr. Mrinal Shetty, are you there? Okay. What about Dr. Anaga? Dr. Priyanka?
Dr. Priyanka is there, I think.
Okay. Dr. Priyanka, are you there? Okay, what about the next speaker, Dr. Aisha Sheikh? Dr. Noorul, can you check?
Ma'am, I am present.
Dr. Aisha Sheikh is present. Okay.
So she's
in
number
category-
14, right? Aisha Sheikh is number 14.
Yes. No, number 12. Number 12, doctor. That is category A.
Number 12, no?
Yeah, category
Okay.
A, number 12. Okay.
Okay.
Dr. Aisha, please switch on your camera.
Yes, ma'am. Ma'am, I'm category B.
Category B?
Yes,
She's
ma'am.
14 number. She's 14 number.
Okay. Okay. Then there is a, okay. Yeah. Dr. Aisha, 14 number category. So now you will be marked, doctor. Dr. Rathi and Dr. This thing, Dr. Das, we need to mark her also. She's a student.
Yeah, I know.
Okay. Dr. Aisha, can you start sharing your screen or switch on your camera? Anything? One of the
Yes, ma'am. Yes, ma'am. I'm just doing that. Is my screen visible?
No, dear.
Just a second. I'm just checking.
Dr. Nural, till then, can you check the other doctors, other 3 doctors who were not present? Are they available? We give them 20 minutes time. If they are, they can reach us before that, then we take them in.
Ma'am, is it visible?
Yes, dear. Now, can you start? Where is your presentation? Netflix, I can see. Okay. Okay, start. Okay, start.
Good evening, one and all present. My topic for today is from torment to tranquility, the Jinwala approach for trigeminal neuralgia, a case report.
Trigeminal neuralgia is basically a chronic, debilitating neurological disorder, which is characterized by recurring episodes of intense shock-like pain in the face. This condition affects the trigeminal nerve and which is responsible for transmitting sensory information from the face to the brain. Trigeminal neuralgia can significantly impact an individual's quality of life, causing emotional distress, disrupting daily activities. Uh, it has an estimated incidence of 4 to 5 per 1 lakh people, and it is considered as a rare condition. The Jinwala approach, which is which is a surgical approach for trigeminal neuralgia cases, offers a novel, minimally invasive surgical technique for treating trigeminal neuralgia. What is it does? It targets a specific nerve branch which is responsible for patient's pain and utilizing micro decompression. The approach can provide improved outcomes. A 58-year-old female patient reported to the Department of Oral and Maxillofacial Surgery with a chief complaint of sharp shooting pain in her lower left back region of the jaw since 1 month. She had no medical history, and she had a history of extraction in her lower left back region of the jaw. Uh, Basically, the patient was apparently all right 1 year ago. Then she started experiencing a sharp shooting electric current like pain intraorally in her lower left back region of the jaw. The pain radiated from the canine region to the molar region on the left side. For the same thing, the patient referred to a private hospital and where she was advised extraction of her lower left teeth, but the pain still persisted. So she visited a private hospital again, and when she underwent some investigations like MRI and CT scan, and there it was diagnosed as trigeminal neuralgia. But she was kept on medical treatment. She was basically advised carbamazepine medications. But even after the medications, the pain still persisted, and recently the pain started intensifying since last 1 month. For which we visited our department for her further treatment. On local examination, we found that the following teeth were extracted. That were the fourth quadrant and third quadrant anteriors, along with the third quadrant posteriors. The nature of the pain that the patient described was a sharp shooting continuous pain, which was present unilaterally, and it extended from the canine region in the third quadrant to the molar region in the third quadrant. And the aggravating factors were eating and speaking. The pain was usually relieved after taking medications. And she also complained of difficulty in mouth opening. We also observed that she had difficulty in mouth opening, for which we did assessment of TMJ as well, but there was no abnormality detected. Further, we proceeded with the following investigations, which were OPG and the diagnostic block test. The diagnostic block test brought us to the conclusion that the left trigeminal nerve was affected, and talking specifically, the inferior alveolar branch of the trigeminal nerve was affected. So our treatment plan was peripheral neurectomy of the left inferior alveolar nerve. For for this peripheral neurectomy, the approach that was selected was the Jinwala approach. Basically, in the Jinwala approach, what we did was we took a inverted Y incision extending from the uh, coronoid notch till the retromandibular area, and it was taken on the anterior aspect of the ramus. Then the temporalis and the medial pterygoid muscles were identified, and then they were transected. Then we identified the mandibular foramen through which the inferior alveolar nerve was running. Here in the clinical picture, you can see that the inferior alveolar nerve is visible. And after we identified the nerve, we did a 2-point ligation of the nerve, and then the nerve was cauterized. Then further we took a vestibular incision, and then we identified the mental foramen through which the which the mental nerve was running. Then the mental nerve was held with the help of a hemostat, and again 2-point ligation was done, and it was cauterized using a cautery. And what we did was we excised about 4 centimeter of the nerve, and then the mental foramen was closed using bone wax, and closure was achieved using 30 suture. This was basically the entire surgical procedure that we did. And after that, the patient is kept on the follow-up for 6 months, and the patient complains of relief from pain, and she has no new complaint of any paresthesia or anything in the lingual region also. And her post-operative healing is also satisfactory. Thank you.
Okay, doctor, it was a time lecture, little bit overspent, but then that's okay. Dr. Das, do you have any questions for her?
It's too much of surgery for me.
Yes.
The only question that I have to ask her is, who is Dr. Jinwala?
So he was the one who gave this technique for the
Why?
trigeminal.
Who? Other than that, what? How is he known in the oral surgery world? Find out. He was the first oral surgeon of India. He was the first oral surgeon of India, Dr. Jinwala. All your oration lectures start with Dr. Jinwala oration lecture. All oral surgery conferences.
Yes.
So he was the founder of oral surgery in India.
Okay, sir.
Okay. Over to Seema ma'am for the question.
Dr. Seema?
Yeah. There will be paresthesia to the patient's jaw on the side. The pain would be gone, but there will.
Sorry, ma'am, I was not able to understand the question. Could you repeat it?
Hello.
Hello. Yes, ma'am.
Yeah, there will be paresthesia after the procedure, no? The pain will be relieved, but
yes, ma'am. But the pain was relieved, but ma'am, I was talking about the lingual paresthesia, because generally in this Jinwala's technique, there are chances that the patient will get lingual paresthesia also, but in our patient, lingual paresthesia was not present. If our incision gets extended too much lingually, then there are chances that we get lingual paresthesia.
okay, but the patient would be comfortable with the numbness in the left side. Otherwise, the pain is not there, but the numbness
Yes, the
paresthesia
pain
will
is
be
not
there,
there,
right?
but the numbness will be present because we have removed that segment of the nerve.
Exactly. So you would still advise this kind of treatment to the patient where you actually just remove the nerve.
Ma'am, according to me, that it is better than the pain that she was experiencing, because she was having that electric current like continuous pain, and now she tells that she's much better than before due to that pain relief.
I could add a little bit to it. Basically, what happens when you do this, there is partial dissection of the nerve that is taking place. And there is regeneration of the nerve. Patient is put on a gabapentin so that the numbness is taken care of. And then within 3 months, the nerve regenerates. Now, this regenerated nerve doesn't have the compression which was causing the numbness. So that's how the think that treatment is done in Jinwala approach?
Yes, I wanted her to answer this. That's why I was taking her.
Okay. Do we have our next
Well,
presenter with us?
Yeah, someone
Hello,
has to
can I
say
ask one question to faculties also regarding this?
Yes, please go ahead.
Just a small, 1 or 2 minutes max I'll take. Sir, I wanted to ask, how much the surgical approach is reliable? My teacher used to say, if the trigeminal neuralgia patients, they are getting relieved by the medical treatment itself, then don't go for a surgical treatment.
100%. 100%.
I mean, the
100%, sir.
achieving more refractory period is our aim in
Medical
trigeminal.
line of treatment is always advised over surgical line of treatment. It's only when the medical line of treatment. See, these were basically, if you see, Jinwala approach is a very, very old technique. It is no longer done today because today we have much better medical line of treatment for it. She has just done a review that she gave of her case. So this is one of the techniques that in surgery they do.
Yeah, that's what I just wanted to have an opinion from a surgeon also. Thank you. Thank you.
Okay. Do we have our next presenter with us? Dr. Nooral, any chance of getting in the earlier 3 presenters, or should we continue?
We can continue. We have 2 participants left,
Yeah,
Dr.
1, 2, 3,
Sakshi
4.
and Dr. Payal, and then we'll
Okay.
conclude for the day.
Okay, Dr. Sakshi, are you there, dear?
Yes, ma'am.
Okay, switch on your camera, please.
Yes, ma'am.
So Dr. Shahala is not there.
No, only 2 presenters are remaining, Dr. Rao, Dr. Payal and Dr. Sakshi.
So number 15 is not there.
Yeah, number 15 is not there. Number 16 is presenting now.
And 17 is also not there.
Yes.
Okay.
Excuse me, ma'am.
Yeah, your screen
Sorry to interrupt, but I'm Rageshwari this side and I was on the list.
Dr. Rageshwari.
Yeah.
We'll take you in Dr.
Rageshwari is not there on the list.
I'll get back, Doctor, on that. I'll get back. Okay, Dr. Sakshi, go to a presenter. Yeah, your time starts now.
Okay. Good evening, everyone. My topic presentation is orofacial pain through a molecular lens. Mainly, I will be talking about the role of genetics and epigenetics in the orofacial pain. As we know, orofacial pain is a frequent form of pain perceived in the face or the oral cavity. It can be acute or chronic depending on the duration. Also, it can be due to dental pain or the nociceptive pain. It can be caused by the diseases or disorders of the regional structures or the dysfunction of the nervous system or through a referral from the other distant sources. So local cause of the pain can be due to eye, nose, dental, ear, pharynx, or the jaw, or other causes that can be vascular, neurological, or the psychiatric also. So the main orofacial pain can be due to the TMD or the trigeminal neuralgia. The first
Is a slide going ahead?
Nooral, is there a technical glitch here? I think we lost Dr. Sakshi's presentation. Okay. Dr. Sakshi, I think she's logged out. Okay. Dr. Payal, are you ready with your presentation?
Yes, ma'am. I'm ready.
Okay, do one thing. Switch on your camera, dear, first.
Yes, ma'am. Just give me a minute. Am I visible, ma'am?
Yes, you are visible. Now start sharing your screen.
Yes, ma'am.
Dr. Sakshi, you can continue later if you have joined.
Ma'am, is my screen is visible, ma'am?
Yes, it is visible. And can you go to a presenter's mode?
Yes, ma'am. Should I start?
Yes, go to presenter's mode.
Okay. Good evening, everyone.
No, go to presenter's mode, doctor, first.
Ma'am, I am in presenter's mode.
No, doctor.
Okay, I'll check.
Dr. Nural, can you just check on the status of
I'll
others?
help her. I'll help her.
Ma'am,
Go
is
to
it visible
slideshow.
now?
Yeah, go to slideshow. Go to slideshow. Click on that slideshow. You will see.
Slideshow. Just a minute, sir.
Or just come down where you can see 92%. You can see 92% down there on the lower left side. On the lower left side.
No, sir. I
अरे
can't
नीचे
see.
ये देखो एकदम नीचे.
Escape first. She's already on.
Yes, yes, yes. Okay, sir.
You can see this lower 92%.
Yes, sir. Yes, sir.
उसके बाजू वाला जो icon है ना, just press on that icon. उसके बाजू वाला, हाँ, this next to it. More to the right. More to the right. Come to the right.
This
Pacha,
one,
come
sir.
to.
Left. Then according to her, the left. She's a female
Come to
doctor.
the.
Slideshow, sir, right?
Yes.
Yes. Press
Click
on
on
that.
it.
Sir,
Click on
thank you, sir.
No, see, your protected view is on. Switch that thing off first.
Okay, that is also on.
Protected view is on. Enable editing and all that. Switch. Just press on the cross over there and then do the slide share.
This one, ma'am.
Extreme
Upper.
or extreme right.
Right or left, whatever. Upper right. Okay.
Right. Go on the right side. Go on the left side then, according to you, the left side.
Sorry, ma'am, for the inconvenience. Is it visible now, ma'am?
Can you see yellow band on your screen?
Yes, ma'am. I can see.
Just close that band. Just close it.
Dr. Sakshi, just click on the enable editing.
No.
No, don't do that. Don't do that. You will go to the. Just click on the cross.
Just Sakshi, listen to me. You can see your date
Now
slide.
it is visible, sir.
Can you see the date? Can you see your 6/12/24?
Yes, sir.
Just go ऊपर जो yellow band में cross है ना, press that. Go with your cursor. See that yellow band? Yellow band में cross है देखो. On the
yellow band में cross, yes, sir.
Just press that. Where is your?
No, sir, I can't do that.
Over your date, bacha.
Okay. Sir, I can't see my own screen now.
Actually, don't panic. First of all, stop sharing the screen. Re-enter. Okay?
Re-enter. That is better.
Okay. And Dr. Nural, do we have a status on other speakers?
अच्छा exit पूरा रोशनी अरे रोशनी बोल रही Sakshi is exit the entire thing. Payal is exit the entire thing and come back.
Exit and re-enter the share screen mode. Acha.
Now perfect.
Okay. Sorry, sir. I'll do that again. Just give me a minute, ma'am.
No problem.
Is it visible now?
Wait. Now go on the go there. Click on it. Click.
Ma'am, is it visible now?
No. Just go again back to that thing.
I don't know what is the problem, ma'am.
Okay, do one thing. Can you present in this mode itself?
One sec. Give me 1 minute. See, you can see the upper home insert design.
You are screen sharing. I can see that.
No. Uske niche you can see home, insert, design, transition. Those things you can see.
Insert, yes, sir.
Go to slideshow over there. Click that.
Yes, sir.
Now come and from current slide. Come to this from current slide. No, ऊपर जा और थोड़ा ऊपर जा.
Slideshow. And
now
then
come to go by last way. एकदम come to the
current slide, right,
click
sir?
that. Yeah, click that.
Is it visible now?
Sir, she has to do one thing. Sakshi.
Ma'am, my name is Payal, ma'am. I'm Dr. Payal, ma'am.
Dr. Payal, very sorry about that. I'm getting confused now. Okay, do one thing. We'll go by Jamin's route. Do that enable and editing, and then let's see what happens. Dr. Nural, can you get back to me regarding the other speakers?
Okay, now start. Now go back where you were.
Udhar karo.
Yeah, karo. हो गया.
Is it visible now?
Done.
Done. Continue. Your time starts now, doctor.
Okay. Good evening, everyone. I'm now really sorry for the.
You want to drink water, bacha?
Yeah.
That's all right. You want to drink water? Then I'll start.
No, ma'am. I'm fine. Thank you, ma'am. Thank you, sir.
I'll be presenting a case report, which is comparison of soft tissue healing with scalpel and laser. So we all know fibroma is the most common soft tissue lesion in the oral cavity, and most common reason is trauma or irritation. So it is named as irritational fibroma. It is reactive lesion, and there are various reasons for fibroma to occur, including chronic trauma, trauma due to unpolished overhanging restoration, unpolished dentures, occlusal disturbances, aesthetic and functional disharmony, etc. So here is the treatment include excision of the lesion, and in this case, two fibromas on the same side was removed, one with the scalpel and another with the laser, in order to observe the healing in these two modalities. So, a 60-year-old female partially edentulous patient, resident of Malad, Mumbai, shopkeeper by the occupation, reported to the Department of Periodontics with 6 to 8 months history of two painless mass in right buccal mucosa, which was interfering her ability to eat normally. Ma'am, something happened. I can't see my own screen.
No, you are visible. It is visible.
Is it visible, ma'am?
Yes, yes. Continue, dear.
Yes, yes, ma'am. So the first lesion was located near the angle of mouth, and another one is behind it on cheek mucosa. They were not associated with any pain. The swelling gradually grows to the present side, and she found difficulty during chewing. Extraoral findings, she has bilaterally symmetrical face, lymph nodes were not palpated, and there were no tenderness or clicking deviation of TMJ. So in medical, she was systemically healthy. There were history of ill-fitting denture, so she stopped wearing that denture. And she brushes her teeth with once daily with a toothbrush and toothpaste, with no adverse habit involved. Her gait was normal. She was mesomorphic with a pulse rate of 80 beats per minute at that time, with a blood pressure of 120 by 80 mmHg. In intraoral findings, the lesion marked with a black circle was 6 mm to 5 mm in size, oval in shape, reddish pink in color, lobulated sessile mass, which was located on the right buccal mucosa behind the anterior lesion. And the lesion 2, marked with a white circle, was 9 mm to 7 mm in size, round to oval in shape, reddish pink in color, soft sessile mass, and located near the angle of mouth. So we came to provisional diagnosis of irritational fibromas of right buccal mucosa. So in that patient, first we did scaling and root planing, and oral hygiene instructions were given to that patient. Then 0.2% chlorhexidine mouthwash was given twice daily for 15 days. Then patient recall after 1 week for follow-up. And then we did well-scope examination, and there were no malignant changes were found in both the lesions. So then we performed some blood investigations like HB, CT, and CBC. Their values were within physiological limit, and then we planned for excisional biopsy. So in lesion 1, 2% lignocaine with adrenaline were infiltrated. Then we sutured that lesion for better handling. And then diode laser of 2.5 watt fiber tip was used in a contact mode and moved in a paintbrush-like stroke. And the tissue was removed by gently swiping the laser tip, and the ablated remnant tissue was cleaned with a gauze soaked with a saline. And in lesion 2, 2% lignocaine with adrenaline infiltrated, and we sutured that lesion for better traction, and we excised that lesion with a scalpel. This is the immediate post-operative view, and bleeding was seen with a scalpel incision. We can see an arrested bleeding, and charring was seen with a laser excision. And this is the excised tissue with the scalpel, and this is the excised tissue with the laser. So we can see there is a clean, clear-cut bleeding margin noted with the tissue excised with scalpel, and there is a blurring or charring was noted with the tissue excised with a laser. So in histopathological finding, H&E stain of both the lesions shows stratified squamous epithelium and underlying connective tissue removed, numerous plumb fibroblasts with a dense collagen fiber bundles along with blood vessels and few inflammatory cells. And at some places, muscles was seen in a deeper section, and overall clinico-histopathological features were suggestive of fibroepithelial hyperplasia. This is the histopathological biopsy picture of tissues excised with a scalpel, and we can see that there is no epidermal destruction with this biopsy. And this is the histopathological picture of a tissue excised with a laser. And the energy transmitted by laser beam resulted in warming, welding, coagulation, protein denaturation, and there is a vaporization and carbonization of cellular tissue, and which causes histological changes such as intracellular vacuolization with some degree of marginal charring was noted. So, in this case, wound healing of each lesion was clinically evaluated over the 7 days, 14 days, and 20 days after the surgical procedure. And post-operatively, the healing process was monitored based on the clinical signs, symptom, pain, induration, and post-discharge. So on 7 days post-operative, we can see there is a delayed healing in the case of laser. The thin denaturalized collagen layer was observed on the surface of surgical surface, and which was act as a natural barrier to isolate that wound. And this further reduces the pain and maintains sterility of wound. And in site which was excised with the scalpel, there was scab formation on scalpel biopsy, and there was no signs of infection at the both the sides. And following laser excision, the associated blood vessels and lymphatics were sealed, and resulting in insignificant extravasation of the fluids and limited inflammatory reaction. This is the immediate post-operative view, and this is the 14 days after surgery. And there is a barely difference between the two techniques on 14 days of excision. And this is the 21st day post-operative view, and we can see that there is hardly any remarkable difference or healing between these two modalities. So we can, in discussion, we can say with the scalpel technique, there was more intraoperative bleeding and post-operative pain was noted, but the healing is better with the scalpel in earlier days. And later on, there is no significant difference between these two. So diode laser provide a better patient comfort in terms of minimal intraoperative bleeding, pain, swelling, epithelialization, infection, and reduced post-operative pain, but its thermal changes damage can be managed by using a low power laser. So coming to conclusion, I would like to say it appears that either technique seems to be equally effective in carrying out excisional biopsies for benign oral lesions. Laser was the advantage in maintaining the bloodless field and avoidance of suturing as well, and better post-operative sequela. However, due to dangers of associated thermal damage, there may be a loss of some histological architecture by utilizing the minimum power setting that can be needed for a traumatic excision. Thank you so much.
Yeah, it was a little overshot presentation. Next time, please maintain the time.
Okay, ma'am.
But then don't get nervous, have a sip of water. Dr. Das and Dr. Rathi, do you have questions for her?
Only one question to you. What is the recurrence rate? Which
Sir,
is there?
Yes, sir.
Yeah.
Sir,
Recurrence rate
recurrence
between the
rate for
two.
fibroma, sir?
Recurrence rate difference with laser and scalpel.
Sir, recurrence rate, sir, I don't know, sir, I'm not aware about the laser recurrence rate, sir, but I'm aware about the fibromas which are recurred after scalpel incision, sir, and they are 22 to 38% recurrence rate is there, sir. And female predilection is more, sir, rather than male.
Even with lasers, the recurrence rate is lesser. It is 18% with lasers. So that is why lasers are recommended now for fibroma excisions.
Yes, sir.
Yeah. Seema ma'am. Seema ma'am, she's freezed, I think. So.
Okay. Okay. Dr. Sakshi, are you there now?
Yes, ma'am.
Okay. Can you switch on the camera, dear, first?
Yes, yes, ma'am. Yes, ma'am.
Dr. Payal, yeah.
Yes, ma'am. Thank you, ma'am.
Okay. Can you share your screen, Doctor? Dr. Sakshi, can you share your screen?
Yes, ma'am.
Category B, Doctor.
Yeah. That's the last presentation of the day,
This
right?
is the last presentation for the day. Okay. Start sharing your screen. Go on a full screen mode. Okay. Your time starts now, Doctor.
Yes, ma'am. Good evening, everyone. Today, my topic of presentation is orofacial pain through a molecular lens. I will be talking about the role of genetics and epigenetics in the orofacial pain. So, as we all know, orofacial pain is a frequent form of a pain received in the face or the oral cavity. It can be acute or the chronic depending on the duration. Also, it can be due to the dental pain or can be caused by the diseases or disorder, the regional structures or the dysfunction of any nervous system part or through the referral from other distant sources. So it can be local cause like ear, nose, dental pain, or other causes like vascular changes or neurological changes or the psychogenic symptoms are there. So the first in the orofacial pain, the main is the temporomandibular disorders, that is TMD. So it refers the functional disturbance in the stomatognathing system. So any deviation from the TMG normal anatomy and the movement that can lead to either clicking, capitis, the pain in the preauricular area. So the main symptoms include clicking, pain, and the limited mandibular movement. So many of this TMD is highly prevalent in the women, especially in the productive ages like 20 to 40 years. So we have seen that TMD is variable in the sex differences in the some pain conditions, as well as considerably variability between racial groups also. So all these differences in the gender, the racial groups, also due to the chronic pain treatment responses also, and the suspected due to risk factors. This whole suggestive that the main reason can be due to environmental factors as well as the genetic factors. So as we all know, there's a difference between the child who laughs of skin knees and one who cries at the smallest pinch can be due to in the DNA. So there is one quote that is, we wondered if more common, apparently harmless changes in the gene might give rise to an altered degree of pain threshold. So the
We have again lost her. Noor,
Just a second.
Noor,
Yeah, Nooral, Dr. Nooral, just see. Dr. Sakshi, we lost you again.
So
okay. I think we can wind up. Dr.
Excuse me, ma'am. Yes, ma'am.
Yeah, Dr. Rageshwari and Dr. Manmeet, I suppose. Do one thing, take down my number. I would like to talk to you because I don't have your name on the list. Dr. Sakshi?
Yes, ma'am.
Yeah, share your screen, dear.
Yes, ma'am.
Dr. Rageshwari, just jot down your number on the chat. Yeah, Dr. Sakshi, continue, please.
Yes, ma'am. So the main in the TMJ orofacial pain is a TMD, temporomandibular disorders. So it refers to functional disturbance in the stomatognathing system, and a deviation from the TMJ normal anatomy or the movement could lead to into either clicking, capitis, or pain in the preauricular area. It is mainly high prevalent in the women, especially during the productive ages. So we have seen that the main and the pain threshold is mainly seen in the sex differences also, the racial groups also, the treatment responses are different. So all of this, the cause can be due to environmental factors as well as the genetic factors. So there's a difference between a child who laughs of skin knees or the one who cries at the smallest pinch can be due to in their DNA. So the main genetic factors that is mainly involved in the orofacial pain is the genetic polymorphism. It is a form of gene sequences variants that is found in more than 1% of the world population. So the mainly gene involved in the orofacial pain are due to the pressure of the thermal pain sensitivity, that is serotonin or the catecholamines, dopamine, estrogen, and the folic metabolism. So the main gene involvement is the serotonin activity, that is HTRA gene.
I think we again lost Dr. Sakshi's presentation.
I think she has a network issue, I think.
Yes. Okay. Dr. Nooral, any idea about these two presenters, Dr.
Dr. Rageshwari is the last one in the list
Yes,
actually.
I'm here.
Yeah.
Ma'am, I'm here.
Please
Okay,
take
Dr.
Rageshwari. Yeah.
Okay. Dr. Rageshwari, you're there?
Yes, ma'am.
She's category A or B?
Category B.
B. Okay. Okay. She's been added at the last minute. We don't have her on the list, panel list. Anyways, Dr. Rageshwari, can you switch on your camera, dear?
Yes, ma'am.
Okay, great. And
I have my friend Manmeet with me in here.
okay. So it's a joint presentation?
Yes, ma'am.
ma'am.
Fine. So, okay, great. So, you both are logging in from different devices?
Yes,
I'll
yes.
share my screen, ma'am.
Okay, do share the screen.
Is my screen visible, ma'am?
Yes, please go on the presenter's mode.
Yes, ma'am. Just a second.
Dr. Das, just last entry.
Finish, not an issue.
Ma'am, is my screen visible now?
Yes, please go ahead. Your time starts now.
Good evening. We are here to present a paper on the topic Assessing the Knowledge and Clinical Attitudes of Indian Dentists in Diagnosis and Management of Oral Traumatic Neuroma.
1 minute, 1 minute, madam. 1 minute, madam. When two presenters are presenting, the other one, please mute yourself or mute the mic because we are getting an echo. The other presenter, Manmeet, you are presenting, then the other presenter should mute her mic. Dr. Rageshwari, you are there?
Yes, ma'am. I'll continue with the presentation.
Okay.
Good evening.
There should not be any echo. Two devices cannot work simultaneously. The echo starts.
Yes, ma'am. The Manmeet will carry on.
Okay. Am I audible?
Yes, continue.
Yes. We are here to present the topic on assessing the knowledge and clinical attitude of Indian dentists in diagnosis and management of oral traumatic neuroma, a case-based online questionnaire study. Next slide.
Just a second, I'm sorry.
Orofacial pain is a common condition where odontogenic problem is the main cause, but a lesser known cause is traumatic neuroma, which is a hyperplastic lesion, which it is a hyperplastic lesion of peripheral nerves, which is resulting from a nerve trauma. The clinical feature present as a small lesion with gnawing pain and paresthesia with burning sensation. The treatment of the same includes surgical and conservative. Continuing with methodology.
The current study aimed to assess the Indian dental practitioners' knowledge and clinical approach towards diagnosing and managing the traumatic neuroma through a case study, with a similar objective of correlating it with years of practice, degree, and specialty. The study was carried out among the registered dentists of the India. It was a cross-sectional, online structured, questionnaire-based study shared through assigned social media platform after obtaining a ethical clearance from the institute. A sample size was calculated using proportion formula, which came out to be 2,100 subjects. But considering a design effect of 1.5 and 50% loss to follow-up, 683 participants were needed, and thus we contacted 1,400 participants for the same. The inclusion and exclusion criteria were as follows. The questionnaire was divided into 4 parts, and pre-testing of the questionnaire was done through a pilot study among 15 experts with a content validity of 0.9 and Cronbach's alpha of 87%. The case study-based question had 11 questions and knowledge had 5 questions, and the scoring criteria was as follows. Following statistical analysis were used. The majority of the participants were academicians with a experience of 0 to 5 years. The following data showed that only 2% had a good knowledge about traumatic neuroma, while 71% lacked it. The table shows that the private practitioners had higher odds of bad knowledge as compared to the academicians. Coming to management and investigation, we can see that the participants had a very poor clinical attitude towards the management and investigation of the traumatic neuroma. And also, coming towards the clinical attitude, only 4.4% participants had a good knowledge about managing and investigating the traumatic neuroma. Coming to the discussion.
There is a lack of awareness among dentists about traumatic neuroma, which leads it to be misdiagnosed. Our study found that 71.7% of participants had limited knowledge. Several other studies have been conducted where the initial diagnosis based on clinical symptoms and radiographic evidence wasn't traumatic neuroma, and it was confirmed only after a histopathological evaluation. Study by BC Jam reported that the initial diagnosis was of mandibular osteolytic lesion. Study by M.A. Lopes concluded that the initial diagnosis was of a neural benign tumor. And a special case by Y. Kodoma, where a 52-year-old female reported with pain after 5 TMJ surgeries. The initial diagnosis was inconclusive, and all these tests had a confirmed diagnosis of traumatic neuroma only after a histopathological examination. Here we can see that there is a set pattern, and either of the studies did not perform a simple Tinel's test to confirm any neurological involvement. In a study which was conducted by V.N. Devi, assessing the knowledge and attitude about managing traumatic neuroma, 89.1% of dentists were aware. The contrasting data was seen in our study, where 57.7% of the clinicians have poor clinical knowledge, indicating a lack of knowledge of the disease, causing it to be misdiagnosed and mistreated. In conclusion, this study reveals that most dentists in practice were not aware of how to diagnose and treat patients with traumatic neuroma, which is in accordance to what Dr. Davis said in the previous slides. Therefore, it could be necessary to implement intensive dental awareness campaign to address this problem. These are our references. And thank you.
Yes, a good Jugalbandi kind of a lecture and well within time. I thought you will overshoot, but you proved me wrong. Anyways, very good presentation. You all can still
Thank
do
you, ma'am.
better. Dr. Das, do you have questions for both of them?
Yes, I have a lot of questions.
Please.
Sorry. First of all, you're a postgraduates of which college? What post-graduation are you doing?
No, actually, we just passed out. We just graduated like 1 week back. We did internship. We are just undergraduates right now.
Okay. From which college are you from, Ita?
Manarachna Dental College, sir.
Huh?
Manarachna Dental College.
Manav Rachna Dental
Yes, sir.
College. Rageshwari, keep your camera on. Yes. Great. So first of all, both of you, even if it is an online presentation, see that you dress up. See how Sonal is dressed up. Her lipstick is also perfect till the end. From 3 o'clock to 8 o'clock, 8:30, her lipstick is perfect. So you should present yourself well, bacha. So that's one first point to you. Next, your topic is very good. But unfortunately, I think so your inclusion criteria were not, see, as an intern, I'm okay, whatever you all have spoken, it's very good, rather, I would say, for an intern level who has just passed out. Your attempt was very good. But if you look at V.N. Devi's study, she must have, that study must have had a good inclusion criteria. Your inclusion criteria was very vague. It had PDS, it had MDS. You ask me, I do not know what is a neuroma. So, you cannot have an inclusion criteria of such types. Clinicians and academicians, if you have to include, then you should have both with the equal knowledge background. So your inclusion criteria should include all of that. Okay. And you said it's a 1400 number that you have taken, and you are supposedly telling it's an Indian report. So generally, you shouldn't do that. So if you're from Manav Rachna, you must have done in North India. All your 1400 people was from North India. Right?
Actually,
How did you make it pan-India?
Through our professor's help only. So we have
Yeah,
circulated the form. Yeah.
see, finally, it is a limited. You cannot call it a pan-India. So when you make it pan-India, you have to see that you include particular clinicians from each zone of India. Then only you can call it an Indian study. Okay. So this
Okay,
just
sir.
it's a learning phase. You'll have done a very good at this phase of yours. So I'm just giving you points. Whenever we call it Indian, it has to be pan-India properly. The entire subjects have to be distributed properly. Anyway, good attempt. Yeah.
Thank you,
Seema
sir.
ma'am. Over to
Thank you,
Seema
sir.
ma'am.
Dr. Seema? Can you unmute, doctor? Dr. Seema, you are muted. Dr. Seema, you are muted. Dr. Seema?
Seema, you're on mute. You. Seema ma'am, are you unmute, please?
I think her screen is, no, she is visible. Okay.
Let me call up Akshay.
Yeah. So what a fantastic presentation, and all these are small little kids who have been presenting and including topics which we at our graduation level we never even thought about. So
Exactly.
kudos to that that you all at least have the resources and mentors.
Unmute करने का वो सीमा को.
Okay, and remember that this whole thing is just so that you all learn something new. We at our age, after 40s, we have started learning an unlearning phase, I would say. And I always say that there is every day will teach you something different. This criteria for marking the students and all, it is just a formality's sake. And whatever is a decision done by the jury or by the team, don't worry about that. All of you were fantastic, and even the faculty. I'm sure this is not, see, making a presentation takes days, hours, and years of research work. It cannot happen in one day. So kids are doing it at this level. Kudos to you guys, and faculty members are helping them. And it's a joint effort. It's a team effort. And thanks for being. Thank you to all the audience, and I'm sure the audience were fantastic because, and Dr. Kulkarni for being such a attentive audience and audience amongst the audience, and also providing his insights. It was very insightful, doctor. And Dr. Kulkarni, I'll keep your number because I keep searching for speakers for my presentations, and I have one speaker now, Dr. Nural. We need to contact him.
Sure,
So
sure, sure.
he's on our list. He's on our radar now. Okay, and with that, I would like to conclude day one. Dr. Seema, if you are there.
Yeah, I just got disconnected and it took me some time. I could hear you guys,
Great.
but I couldn't respond back.
Thank you.
Yeah.
Thank you for coming.
Yeah.
Dr. Das and Dr. Rathi, please, both of you, how was your day like this after? I know it was
fantastic. It was fantastic. It's very nice to see all the students also coming up with presentations and going in depth. It's really nice. I enjoyed the session a lot. Each one was coming out with some of the other ideas, which you felt like questioning. You did feel like going more and more deeper into. So yes, pain has many faces and everybody's watching. Yeah, good.
Yes. We as clinicians have the responsibility to help the patients with pain. So Dr. Das, I know the time limit has overshot. I'm sure
For maybe one thing, I sat from 3 to 9 at one place. It speaks a lot about your entire conference.
Thank you so much. And Dr. Nural, we should conclude the day one.
Yes,
and Dr. Rathi and Dr. Das, thank you so much. And dinner is on me one fine day, definitely. Okay, so we should meet virtually instead of this virtual
Not
world.
virtually, actually.
Actually, not virtually.
Yes.
We have two dinners, one with Nurul at Delhi.
Yes, of course.
Okay.
Of course.
And I know where to take him in Delhi also. I have got the places fixed also in Delhi. When I go at Connaught Place, it's a lovely place where I and Akshay usually go. So we can go there.
Yes,
Seema doesn't
And
need to hear that.
we take you to IOPCON.
Most welcome. Yeah.
Thank you so much. And
So,
thanks
Dr.
for being
Sonal, for a small announcement for the forthcoming 2 days. We will start tomorrow at 9:30, 9:30 in the morning. So in winters we are starting a bit early because we have a pressure that we have to accommodate speakers. So that's why we are starting at 9:30 tomorrow. And I'm requesting all my delegates who joined, all registrants who are log in with Zoom, they keep on watching the website. You will be getting all the updates over the website because sometimes you keep on calling us and to our team and all. So it's a better one. First, see the website, the notifications, the informations, etc. Everything is there. It's a dynamic website. We are keep changing on it. So you will be getting the updates over there. So you need not to call to our resource for your information. So keep your eye on the website iopcon.com, and we'll join tomorrow 9:30. We have a 19 speaker tomorrow and 18 speaker day after tomorrow, Sunday.
Yeah, I'm fully loaded with speakers and information tomorrow. So see you all tomorrow. And
I will try and be there as much as I can.
Yes. Thank you so much. And thanks for the patient listening. And without audience, we are nothing. So thank you, everybody who is there till the very last minute. Thank you so much. And with this, I conclude the day one. And with your permission, Dr. Das and Dr. Rati, let's call it.
Good night.
Well done.
Good
Well
night.
done. Well done.
Good night. Shappa khair.
Good night. Good night.
Bye. Bye. Take care. See you all tomorrow.
Nice. Thank you.
Yes.
Thank you very much.